Stop, give a minute. Breathe, even if you can't stop from crying. Or nothing that we can do now. If I follow you, follow me, we're probably meant to be. Grab a cigarette, you will not regret it. If I follow you, follow me. Follow you, follow me, follow you. Even if you follow you, follow me, follow you. Even if you if I follow you, follow me, we're probably meant to be. Grab a cigarette, you will not regret it. If I follow you, follow me. Follow you, follow me, follow you. Even if you follow you, follow me, follow you. Even if you in my body feels like summer rain. Tastes like sweet and sour every time I talk you. If you ask, every night I feel like I lose. Everything you do is up to you. It's the weakest. Never explain that. If you ask, every night I feel like I lose. Everything you do is up to you. It's the weakest. Never explain that. If you ask, see if I wanna do it every time that you the most scary girl that I've been to. But the way that she treats me, it's better than every girl in the world. And every girl she gave me is like rain. Your kisses in my body feels like summer.
Carpe diem. Seize the day. Let us be the best that we can be. Megamind 2024 is an ambitious project. Over 500 contestants around the world participated in this open league competition. The scale of such an event is unprecedented. Now, we have top 21 finalists representing their own countries to compete for the main podium in Cannes, France. This is super exciting. It is truly a Cinderella story because it takes courage for these young doctors to make such an effort in front of the global audiences. The goal of Megamind is to search and cultivate the future leaders in dental education. Please spread the news. Tell your friends. The final competition will be aired live from Cannes, France in October the 18th at the European Scientific Meeting. So please stay tuned and help promote this amazing event. Who will be the next Cinderella? Unlock your potential, test your minds, because we are Megamind. Welcome to Megamind 2024, everybody. No matter what anybody tells you, the words and ideas can change the world. I truly believe that from the movie Dead Poets Society. Before I start, I want to welcome all of you to this amazing event that we call Megamind. In my book, all of you are already winners. So I want to start by congratulating all of you. Let's give everybody a round of applause. We started with over 500 contestants all over the world. And here you are, top 21, representing your own country. In my opinion, it's like an Olympic or like a World Cup. Make us proud, but you're also here to make your country proud. And all of you, you deserve to be here. Thank you so much. And before I start, I want to thank those people who made this Megamind project possible. First is obviously the man, we call him the little giant, PKB, Dr. Park Kwang-bom. There's something that he said a long time ago when I met him for the first time 6 years ago. He says, don't build a tall wall, build a bigger table. And Megamind embrace that philosophy. And that has been our core value throughout this project. And when he approached me to take the task of becoming the global ambassador for Megamind project, there was something that he really compelled me and drew the attention and attracted me to participate in this. He says, anyone, anywhere, using any implant system can compete. It is the only true openly competition that I'm aware of. And I think that talks a big volume of what the Magazine Implant Company is all about. And before I start, I want to really thank some of the key supporters of Megamind, and that starts with the judges. And I'm here to introduce each and one of them. First, Professor Cristian Dinu, the Dean of Faculty of Dental Medicine, University of Cluj-Napoca, Romania. He is also the founder of private implant clinic, MedArtist. Thank you so much. Next is Professor Gühan Durgan from Turkey, a head of the Department of Oral and Maxillofacial Surgery, Faculty of Dentistry in Marmara University in Istanbul, Turkey. Thank you, Gühan. Professor Jordi Galgallo from Spain. He's a full-time professor of the Department of Oral and Maxillofacial Surgery at the University of Catalunya, Barcelona, Spain. Obviously, I am shortening a lot of your bio because it takes like a page and a half. I just don't have the time for it, so my apologies. And next is Professor Christian Makari. He holds a PhD in oral biology from the St. Joseph University of Beirut in Lebanon.
He's a former chairperson and currently associate professor and director of the master's program at the oral surgery department of the Faculty of Dental Medicine. Okay. Next is Professor Yong Kwon. He's an oral maxillofacial surgeon, a full-time professor and chairman of Department of OMFS, Kyunghee University School of Dentistry in South Korea. Thank you so much for joining us. Dr. Leonard Schwartz. Dr. Leonard Schwartz is a board-certified specialist in periodontics certified by the Royal College of Dental Surgeons of Ontario, Canada. He's a graduate of McGill and awarded a certificate of periodontics from University of Connecticut, USA. He's my mentor. He's one of the most well-renowned periodontists in my country, Canada, and it's such a humbling experience for me to stand in front of him. So thank you, Dr. Schwartz, for joining us as well. Okay. Next, I want to thank truly the unsung hero of the Megamind. We have Selena, who's not here, and we also have Jin-sun. Where are you, Jin-sun? Over there. And we have a Sujin, okay, yeah. I truly can't thank enough. When this project started, we didn't know how it's gonna turn out. That was the last year, season 2. It was such an enormous project, and there was a lot of doubt in our mind too. I had this vision of how I wanted to tell the story of the clinicians all around the world. And without their support, it would have been an impossible task. And you know, a lot of people don't know, but we've been having almost a weekly Zoom meeting for 1 hour each week for the past 2 years. That's the level of dedication it took us to make this possible. So once again, thank you so much for all of the Megamind headquarters, the members. Thank you so much. Also, I need to say thank you to somebody, because somebody says it's not about the destination, it's about the journey. And I knew that in order to make this Megamind brand successful, I had to ask one of the best videographer that I ever known. And he is David O, standing right over there. And oftentimes I forget to thank him because I take it for granted many times. He's been working with me at my institute and my organization in Canada for the past 6 years. And I forced him to practically volunteer last year, all throughout. I forced him to volunteer, okay? That's our definition. And he obliged, and he did a lot of the heavy lifting. So I want to take this moment to thank Mr. David O. Thank you, thank you. Some of the house rules, okay? House rules. My job is to start on time and hopefully finish on time, okay? During the presentation, each of the presentation, there will not be no in and out of the door, because we want to make sure that when you're presenting, you're not disturbed, okay? So there's going to be a doorkeeper that's going to block anybody coming in or anybody going out. If you need to go for washroom, then you can do in between the presentation, but if you take too long, you might not be able to come back, okay? Yeah, all right, so my recommendation is hold, all right? Yeah. There will be a 5 presentation and a break of a half-an-hour break, and there will be a second bracket and a lunch break, and the third bracket of the 5 presentation, and a break, and then last. So it's going to be a whole day, okay? So use those break time wisely. During the break time, there's not going to be a true Q&A. So if you guys are wondering, oh my God, are the judges going to ask me tough questions and grill me? No, it's not going to be, so you can relax right now, okay? However, they'll give you some feedbacks, okay? Some feedback that's going to make you better, okay? So that will happen during the break time. When you go out for break, please come on time, because we will close the door. So break time, make sure you come before the break time is over and secure your seat. Thank you very much. And also finish on time as well. And there will be a timer at the front right there, iPad, so you will know, right, what your pace is, okay? Yeah. So if you think that you're talking too slow, you can speed up or vice versa. And also, there's going to be one contestant that will require translator today. That's why you have this earplug. Okay, I believe it's a Q1 is a third contestant, right? Yeah, on the list there, and I'll give you a prompt when to put the earplugs on, and there will be a real-time translation. Okay, so that's what the earplugs are for. All right. So no further ado. Let the Megamind 2024, let the game begin, everybody. All right, the first presenter. Is that a good thing or a bad thing? You know, we always say, when we get invited as a main podium speaker, we say, you know, I don't want to be the first, I don't want to be the last, right? Yeah, I think they take on some of the extra pressure, right? And, you know, but somebody has to do it, and I couldn't find anybody better than the next presenter, okay? The first presenter is the most important, of course, and the most difficult because being the very first, because I know for sure everybody is nervous. The first presenter is a periodontist. His focus is on one of the most challenging subjects, immediate anterior therapy, and especially in the class 3 sockets. And we all know how difficult it's going to be surgically. So much effort, both in and hard and soft tissue, goes into such a surgical planning. I don't know about you, but I'm very excited for this subject and also for the presenter. Let us welcome Dr. Pablo Urrutia, representing his country, Chile. Everybody.
Yes, yes. Representing Latin America too. Maybe I am the only one from South America. Yeah, so it's very important for me to be here and with you guys. So hope you enjoy my presentation. This is very challenging case with maybe a different approach. Okay, so this is immediate implant placement in compromised class 3 socket. Maybe the title is so obvious, but the situation here has different challenge situation that we change our mind about how we focus on that kind of process. So this is a high smile line patient. The story of Maran is a good patient referred to us with a difficult situation. As you can see in the picture, this is the high smile line with thin phenotype. So the situation is very challenging here because you know how thin phenotypes behave. So the point here is this is an endodontic treatment, and we focus on one in the 2.1. So, but the situation is more global because the aesthetic embrace the smile. So for us, the situation is that maybe, but for us, this is the article that we always put in our classes. It's about the different stages that we have to keep in mind in patient. It's about the compliance, for example, the story of periodontic surgery, the healing protocols, and the surgical experience. The implant related about the macro and micro designs, the timeline of the implant placement, the healing protocol, the loading protocol, and the soft tissue management, and of course, the biomaterials in the proper selection of this kind of biomaterials. So assessment is high smile line, for example, that patient, thin phenotype, high aesthetic demand, the soft tissue is an issue, the hard tissue too, and the prosthesis. So, okay, this is easy to maybe to diagnosticate, but the point is how we put that things in the timeline, the treatment. When I talk the timeline, because this is difficult, because how you manage that kind, because of what Yusuf told us that we can do early implant placement. But what happened with early implant placement? You have to wait 8 weeks, sorry, and the healing of soft tissue, what happened with scar tissue, what happened with recession, with aesthetic, and the timeline and comorbidity of the patient. So for us, is why don't we think different, this kind of approach? What happened with recession too, and the aesthetic, okay? So this is the situation. We don't have bone wall here, and a granulation chi tissue, that this is a chronic lesion. So for us, what thinking about how we can take this situation to another level. So for us could be a very user approach, ITI, I think, that maybe safety flap and elevate everything and put some graft material and wait 6 months and then the implant placement or immediate implant placement with GVR early implant placement with GVR, but soft tissue maybe could take 2 years, that kind of treatment in the stage approach. Soft tissue, healing, GVR with implant placement, connection, and everything. So a patient with high smile line has different situations that we need to confront here. So for us, it's the situation. This is the European colon classification. I always put that classification because give me perspective of the 4th dimension that we need to keep in mind with this situation. About, for example, the medical story, it's a green flag for the patient because it's a good patient and put his mouth in, or the team, as a team, to he believe in us, okay? But let's take a look about what we can find in local findings, for example. The healthy patient is as a 1, okay, 2.1 chronic lesion, high smile line, thin phenotype, and class 3 alien. You know how demand that kind of treatment because of the gingival margin and the aesthetic. Okay, but surgical. Surgical, different approach. Every surgery has his rules about the time, his expertise, the risk management, okay? The younger are maybe more prone to take more risk, but the older one maybe have more experience or have more stage approach in that kind of situation, okay? But we need to face the GVR, the restore the bone wall, the implant placement in 3D position to have the soft tissue in proper thickness and gingival margin position. Multiple surgeries could be faced in that case. And restorative, one single crow restoration is very challenging to the prosthesis. The merge profile, the provisualization, and how we manage the stabilization of the contour of the gingival margin. Okay, so here is a maybe challenge situation in these 3 topics. Okay, 10 minutes. This is what I always put. This is the protocol of perioplastic about stage approach. We need to prepare the patient, do the EVR, maybe the implant placement, the soft tissue, prosthesis, maintenance. Okay, this is how we manage the complication management, the 2 cases before. But for us today, something different. This is a challenge situation here with you, all the competitors, maybe excellent cases. So I put things different. Okay, this is maybe Steve Jobs put that things in the 90s about things different or things outside the box. Okay, but maybe it was very important for me because maybe as an Aquarius guy, maybe I always go through the other direction. Okay, but things different for me is very important because how we can put all things together and do maybe something different. Okay, so I've been in 2013 with Dr. Da Rosa in Caxias do Sul, Brazil, with the tuber graft about immediate GVR. No, it's the name in English. Well, immediate gingival restoration. I don't know it, but Dr. Chu used in NYU the same approach with biomaterials. So the local finding is easy. Extraction, a traumatic extraction under premedication of antibiotics and the local management of the granulation tissue with the chemistry and cleaning all the socket. Okay, so here this is maybe the same approach ever, but what happened with the surgical? Maybe the surgical maybe is different because we do it immediately. Immediately, okay. We put the implant in the palatal approach, guided with osseoidentification. We know that osseoidentification increases the stability with the spring back effect and with apical and palatal anchorage. Okay, so that okay, but at the same time, we do it the gingival graft to increase not only the thickness, to mobilize the gingival margin to the coronal position. And why not to the lateral and to the canine? Okay, we use the modified tunnel approach with a coronal displacement, and then why not to use a socket preparation with GVR? We perform, this is from Stephen Shu approach in his book, and with Dr. Da Rosa approach with this kind of class 3 alveolus. As you can see here, this is abutment that creates a space, and this is the membrane that we use. It's a collagen membrane, but very rigid and very easy to handle because it's not flexible, it's deposit. So you have time to put the membrane with these wings supported in the proximal tissue and create this space that we need to separate the soft tissue and the bone box. Okay, so now we use the membrane. As you can see, we create the soft tissue space the membrane with the rigidity and the abutment, and we create this box to fill with bone. Okay, so now we fill it with bone, and why not again? Why not if we have stability, the proper 3D position? Why don't we put the provisionalization immediately? Okay, so this is how we resolve the surgical, and why don't we go to this prosthetic? This is Alberto Gonzalez, the new article that he suggests the GVR space. We know that's subcritical and critical contour, but what happened with the regeneration space? So with that kind of abutment, we create the space, and the position of the implant goes more apically. 5 millimeters apical, because that abutment give me 2 millimeters to support and to create the space for prosthesis and create the space for GVR. So now, this is the approach that restorative have to perform. This is with my friend Jonathan Esquivel. He suggests with Ramon Gomez Meda the passive full contour, active full contour, and subcontour provisionalization. So now we have to wait for the tissue to healing during the space. So what we do here, we use a subcontour provisionalization to support the tissue and give it the proper time to heal. So you can see the displacement more than 5 millimeters coronally. This is no time for restore the gingival margin, and we wait 3 months to have the maturity of the tissue again. The collagen is so important here to be compressed then. Then active provisionalization to give the same level of the gingival margin, but more important, to copy the same form of the gingival margin of the 1.1. So now wait a little bit more time, and then this is the MERV profile. Okay, so we check the MERV profile because we were scared about that, so we wait 3 months later to maintain the same profile. And then during this time of waiting, why not to restore all the gingival contour of the upper jaw? So we perform another surgery plus surgery. The patient saw the result, the outcome, and say, okay, why don't we do the same thing with increase the thickness and restore the gingival recession in the upper jaw? So one surgery for upper jaw to restore the gingival margin. As you can see, we resolve all the upper jaw during the healing process. During the waiting of the 3 months of the provisionalization, we change the color to increase maybe the aesthetic demand of the patient. And then this is the flow chart that we use to explain that situation. Okay, this is again from Ramon Gomez Meda and from Jonathan Esquivel. And they use, this is when we have the gingival margin in position. And this is when you don't have the gingival margin in position, and he showed us the thin phenotype, apical position of the gingival margin, bone dehiscence, and they say, okay, we can't do it immediately, or the gingival margin, we have to wait. And this is approach of the subcritical contour and critical contour, and how they manage the provisionalization to increase the support and the space for the tissue to heal. And then wait a little bit with 4 to 6 months, because 3 months maybe it's maybe too close to have some compression and restore the gingival margin. So we wait a little bit more. Okay, so now for 4 to 6 months we left provisionalization and start the compression to restore the gingival margin. And then the final restoration. As you can see, this is the final restoration where we restore the gingival margin, the thickness, we restore the gingival recession of the 2.2 and the canine. And you can see this is what we reach with the patient. It's very important for us that the crown have the same level in the palatal aspect, to the patient don't have some issue with the tongue when they pass the tongue in the palatal aspect of the crown. And you can see here the restoration of the thickness and restore all the emerged profile of the 2.1. As you can see the before and after. The before and after maybe can reveal it itself, how we restore the gingival recession, we restore all the process of the alveolus, and the one restoration at the delivery by, but the laboratory was pretty well. Okay, so how we, this is CBCT show, this is the restoration of the bone wall, and you can see after 1 year, this is the stability of the bone wall with the implant placement, and let's check the patient with the high smile, how they look. As you can see, this is an entire restoration of the upper jaw with gingival recession treatment, with coronally advanced flap, with the immediate restoration of the gingival margin with immediate provisionalization, and let's check how the patient goes. This is maybe the summarizing what we have to keep in mind with this kind of treatment. Okay, this is for 3D position, it's mandatory. The material selection, the bone fill have to be mineralized. I always use allogenic biomaterial because of what maybe give me some support because of the mineralization of the tissue can support the compression of the flap. Okay, the prosthetic design is important, so the macro and micro design is important, but most important here is the abutment. The abutment and bone grafting, connective tissue, and long-term provisionalization. And you can see how resolve every situation in the stage approach with this kind of treatment. You can see the local finding, the surgical, the restorative, and of course, it's more important, the prompts, the patient outcome and satisfaction. Okay, so the patient was well, so the team of us were well. So for my message for me is things different, maybe rethinks everything, and hope you enjoy. My name is Pablo Urrutia, and thank you all.
Great job. Great job. Thank you. All right. There you go. I only do this for the very first and the very last, okay? Good job. Good job. Thank you. Wonderful presentation. Well, the level has been set, everybody. Okay, so that's what you have to compete with, right? Thank you so much. You know, it doesn't matter how long I've been doing implant dentistry, I always learn something from each and every one of you. The next speaker represents China. She is a very well-known oral surgeon in her city, and she's also a faculty member of a Shandong University Hospital in Department of Stomatology. This morning, she will also talk about anterior implant therapy, and she's going to focus on the significant role of soft tissue grafting in order to achieve the predictable outcome, and also why the workflow is so important. Let us welcome Dr. Zhu Zhenkun from China. Thank you. Come on, listen.
Thank you so much. Good morning, everybody. So I think it's truly my honor to be standing here. In fact, maybe this is the first time to stand on the international stage to show my case. So today, I will just show you a case in aesthetic zone. And this case just accept immediately implant placement with connective tissue graft. And here is the it's a 41-year-old woman present to the clinic, and with a primary concern about the mobility and a slight inflammation around the maxillary right incisor. After the clinic evaluation, we found that this tooth just had a grade 2 mobility, and we can see that there was a chronic inflammation surrounding with the margin. And besides, we can see that there is a slight of the middle buccal mucosa recession. And for this kind of the patient, and we know that sometimes they have just a very high expect. They just expect to accept immediately implant placement and restoration if possible. Of course, the patient is a young woman. She just wishes to have a high aesthetic results. For this kind of patient, we know that we need to do the first thing is a good plan. And there are 5 keywords we need to consider when we do the plan if we want to achieve a good or better aesthetic results. And we know that the timing, we know that immediately implant placement, this procedure or this approach is defined. We just insert the implant inside of the extraction socket immediately after the tooth extraction. But we know that the immediately implant placement can shorter or reduce the treatment, the surgery procedure, and shorter the treatment time. But already we know that we need to select the patient very carefully. That's because, the patient should be the indication. Indication should be under the indication of the implant immediately placement. And we just emphasize that aesthetically, a position of the implant is required. That's because it can help to maintain the soft and hard tissue. And we know that if the wrong position of the placement of the implant may be lead to the aesthetic complications. And we also know that the future restoration and the soft tissue level just determined by the 3D of the implant position. And we also know that the implant depth just determined the ideal length of the crown, right? So we just emphasize the correct position of placement. And we also know that once the tooth has been extracted, the buccal bone start to absorb, right? So we need to do the bone augmentation at the same time of the dental implant. And we also emphasize that, the adequate design of the restoration is needed. That's because we know we need, especially the transgingival area should be designed. Why? That's because it should be developed to maintain our influence of the final presentation of final appearance of the soft tissue. So, I think the design of the restoration is a really tough and very important task for our clinicians. That's because we need to do the good design to achieve very stable and optimal outcomes. But even if we just have done very well the first 4 key steps, in fact, immediately implant placement, maybe is enable ability to predict the final soft tissue level. So what should we do to just reduce the soft tissue changes? Just as we know that the soft tissue augmentation kind of a good choice. But our question is that, does the soft tissue augmentation just can help to reduce the soft tissue changes? So we need to just consult the literature to find the evidence-based support for us if the soft tissue augmentation is helpful or not to maintain the soft tissue changes, right? So, in fact, the first thing we worry about, the primary worry about the soft tissue changes after the immediately implant placement is what? Is middle buccal mucosa recession, right? So my question is that is the CTG graft is helpful to maintain or just reduce the middle buccal mucosa recession? So we can just find the answer from this lecture with RCT. It just can give us a conclusion is that after 1 year follow-up, you can see that the connective tissue graft combined with the single immediately implant placement has a less middle buccal mucosa recession. That is good, right? So much more from this systematic review with up to 74 citations also can give us this conclusion in that we can see that the middle facial vertical soft tissue changes or recession is 12 times 12 times lower following immediate implant placement with CTG compared with the group without CTG. So it's also recommended that, especially in the patients with thin gingiva biotype, or the patient have a buccal bone thickness less than 0.5 millimeters, is recommended to have CTG when they just accept the immediate implant placement. So another thing we just worry about the soft tissue changes is that, does the CTG graft can just help us to get much more, increase the soft tissue thickness or maintain the soft tissue thickness and have a better profile outcomes? In fact, we can say if we think up to 2 years follow-up is not enough to indicate a long-term stability of soft tissue magnetization. Here is another CTG with a 5 years follow-up. We can see that compared with the baseline after 5 years follow-up, the soft tissue thickness got 0.3 millimeters increase. And at the meantime, we can see that the rate counter changes compared with the original level. The group with LCTG only got 0.3 millimeter decrease. Let's just give us a conclusion is that if the implant site just have the procedure, underwent the procedure with the augmentation of the soft tissue, can have a long-term stability of the soft tissue surrounding the implant. So with this very useful information, we just back to the clinical case. In fact, finally, the case just accept those procedure. First of all, we just do the extraction, minimal invasion extraction. I do the immediately implant placement and the CTG, bone augmentation, and accept the restoration, immediately restoration. And up to today, it has also more than 1 year follow-up. Just as the patient personally said, she just very satisfied all the whole treatment process and the aesthetic outcomes. Okay, let's just review the whole treatment in detail. First of all, we need to do the minimal invasion extraction. And in this step, we just emphasize that the use of the minimal invasion extraction instruments to ensure the integrity of the buccal bone. Besides, we just emphasize that we need to keep the integrity of the gingiva margin, especially without any tearing in the papilla area. Once the tooth had been extracted, just according to the 3A, 2B rulers, we know that the implant should be placed just 3 millimeters apical and 2 millimeters in the palatal position to ensure the implant has been positioned in a correct way. And in this case, the implant is placed with a high torque. After that, we just make a superior envelope flap is prepared, and we know that the superior steel envelope flap can just help us to preserve the original exciting the gingiva. And we know that this is the minimal invasion surgery on the recipient area, and fix a very firmly fixture of the CTG, and to help them to survival. And the intimate contact with the biolaminar or the soft tissue complex just achieved, and this permits and help to maintain and help to formation of the graft survival and the post-operation bleeding of the soft tissue. So Once this step is done, we just harvest the connective tissue graft from the palatal. The first step is that we use it to de-epithelial by using a high speed rolling bar, and then you may just tracing the graft with the tips of the blender. Why we just use this method? That's because this method can guarantee we can get a free CTG with a very high dense connective tissue layer. Then next step, we can trim the final shape according to the need of the recipient area. Then next step, we just firmly suture the free CTG, an internal accept of the flap, and just in the perio-marginal area position. And the next step following, we just put some bone particles, biomaterials inside of the bone counter and under the mucosa margin. Here is another. Here is the immediately the restoration. Just as what we mentioned in the last presentation, we already know that there is the two distinct areas can be identified. And the first one is the critical counter, and the next one is the subcritical counter with a S-curve. Why we should just design the surface just like in this strip? That's because there will be a regeneration space can be created between what? Between the surface of the restoration and the soft tissue. And this space just can permit the formation of blood, very stable blood clot, just in combined with the soft tissue we just insert into it and the bone particles. And we can see the clinic outcomes. Just after 1 year follow-up, we can see that with the help of the restoration design and with the CTG graft, we can see that the margin of the soft tissue just can be maintained very well. And besides, another very interesting finding is that we can see that this is X-ray pictures before and after, compared to the original bone counter. You can see, in fact, after 6 months post-operation, in fact, there is a slight resorption of the bone buckle. But we can see from the clinic pictures, we can see that even after 1 year post, the soft tissue counter has no changes at all. That is why I think everybody already get the answer. That's because we said that with the CTG, with the soft tissue graft augmentation, and with the especially design of the restoration, give the soft tissue regeneration possible and the area. So all of those choices just compensate the buccal bone resorption. Okay, that's all. That's the case today. Thank you for your attention, and welcome to China. We just expect one day we can just communicate with the connective tissue graft in China one day. Thank you so much.
Thank you. Thank you so much for the presentation. How's everybody doing so far? I can see that no one's falling asleep, so that's great, right? Exciting topic. Whenever we hear about the anterior therapy, my ear goes up, because I know that it's something that we all struggle as clinicians, and we're still looking for that perfect solution. So thank you so much for sharing your knowledge and your wisdom. Our next contestant is where we need to put the earplug. Okay, yeah, so this is going to be done with simultaneous translation, okay? So the next presenter also represents his country of China, He has been an implantologist since 2006 after he graduated from University of Zuni Medical School of Dentistry. His area of special interest is in solving edentulous patients with severely atrophic resorbed ridges. Can't wait. I think this is going to be a very exciting topic as well. Let's welcome Dr. Liu T. Liang from China. Welcome.
Thank you. 大家好，我今天可能会用中文给大家做今天的汇报，所以我非常感谢我的朋友李医生来做我今天的翻译。我是来自中国北京的刘体亮医生，然后是一位开业医生。然后我今天汇报的这个题目是极度萎缩的无牙颌，我们采用了全种植体和下牙槽神经移位术的应用来帮助患者。这是我们的一位女性，64岁，然后呢，她的情况是，她整口的牙齿都没有了，只有她的下颌还有3颗种植体。然后呢，她曾经佩戴过活动假牙，但是吃东西非常困难。那这样一位大概64岁的女性，我们可以看她面下1/3的状态是面部的面下1/3是凹陷的，然后呢，她的垂直距离也会有降低。那这样子的话会严重影响她的美观和功能。这是我们在术前记录了患者口内的情况，我们可以看到他的下颌还有3颗原有的种植体，但是上颌是无牙颌，然后整个的上颌的骨头的萎缩呢，也相对是非常严重的。我们通过术前的 CPCT 做一个检测，我们会发现这个患者他的术前3到3的地方的骨头还是不错的，但是他的前磨牙和磨牙区的骨量非常少。OK， 我们可以通过这个 CPCT 的影像可以检查，会发现患者的上颌窦腔是健康的，但是他的前磨牙和磨牙区的骨头非常少，在他的前牙区1区的骨量还是不错的。就这样一个极度萎缩的病例，我们会给他一个什么样的治疗方案呢？我们根据2010年的一个文献可以记载，如果在前牙区1区的有骨头，2区和3区没有骨的时候呢，我们会把它假定为它是一个全种植体的适应症。OK， 这是我们在上颌的一个影像。在它的下颌，我们通过一个文献的系统综述可以发现，大概289个病例里面，我们会发现只有5%的病人，也5个病人大概是1.73%的病人会有出现下牙槽神经损伤的这个风险。所以介于这个病人，我们会给他2个治疗方案。他的第一个治疗方案是我们可以给他一个活动的假牙，然后呢，下牙我们可以用种植体支持的这样一个 locator 的修复方案，或者我们可以给他一个上颌给他进行种植，但是我们会使用全种植体。他的下颌呢，我们可以给他使用神经移位的方式来进行种植，完成一个固定的修复。那这个患者他不太希望自己有更多的治疗周期，而不接受植骨，所以我们给他选择了方案2的方式来完成他的治疗。这个患者我们在术前给他做了 CPCT 的3维重建，那我们在上颌植入5枚种植体，下颌植入2枚植体。我们根据这样一个方式呢，给他完成了上颌的 on5， 下颌的 on5 的一个固定义齿的一个修复。这是我们在术前记录了他的这个1/5牙位的这个手术的照片。那我们可以在他的颧骨区域找到最好的 BIC， 然后呢去寻找他的方向，之后把整个的外侧壁打开，然后呢完成他的这个全牙槽脊的前方的这个骨板的去除。那在这个里面比较重要的一点是我们把上颌窦外侧壁的骨板进行内侧的移位，然后呢我们进行了骨移植材料的植入，然后我们在里面植入了骨移植材料还有 CGF， 帮助患者能够完成他的 GBR。这是我们手术过程中的一个记录，我们可以看到我们在患者的颧骨区可以在体表找到他的一个最佳的 BIC， 然后我们再进行软组织的处理。软组织处理以后，我们把上颌窦外侧壁打开，打开了以后呢，我们在牙槽基顶偏腭侧的地方来完成它的这个牙槽基顶的预备，然后呢进行植体的植入。那我们在它的整个上颌窦腔侧植入了粘性的骨，那这样的希望我们的全种体在上颌窦腔侧有骨的再生，然后我们完成了1/5牙位的全种植体的植入。这是我们在它的左侧2/5牙位，同样的方式，我们帮它完成了另外一侧的全种植体的植入。 然后在这个地方，我想强调一点是，我们希望能够在全种子体的上颌窦腔侧植入骨再生材料，希望全种子体能够离开我们的上颌窦腔。这是我们在术后的一个曲面断层和 CBCT 的检测，我们会发现我们在两侧的全种子区域使用了40到42.5的全种子体，完成我们的初期稳定性。这是我们在术后给病人进行了冠状位和水平位的 CBCT 的检测。那我们在它的整个的上颌窦腔侧的全种子体周围都有了新的骨的再生。我们通过术后的 CBCT 可以进行检测，在全种子体上颌窦腔侧会有骨的环绕。我们希望未来全种子体周围尽可能不要去刺激我们的上颌窦腔。这是我们在它的下颌的右下的位置，我们对患者进行了下齿槽神经移位术。那我们在下齿槽神经移位术的时候呢，我们希望通过外科的方式，将我们神经的前部、神经的后部还有神经下部的骨皮子去掉。那我们可以把这个骨皮子去掉以后呢，很小心的让我们的神经进行往后方的移位。然后在神经移位以后呢，我们在5号牙位进行近中倾斜的植体的植入，这样可以让植体离开我们的神经的转折处。然后呢，在这个植体的夹侧，我们可以进行 GBR， 然后完成这个植体周围骨再生的这样一个治疗计划。OK， 这是我们的 video， 可以看一看整个手术的过程。然后在整个手术完成以后，我们把前面3颗植体的 locator 基台把它更换为多元基台，然后进行桥体的这个修复。同样，我们在另外一侧，我们也是选择同样的方式，我们先暴露我们的这个颌神经，然后呢，把颌神经前方、后方和下方的骨头这个骨皮子去掉，然后呢，我们再近中倾斜植入种植体，然后完成它这一侧的 GBR。OK， 我们对这一侧也做了影像的记录，我想向大家展示一下。那比较重要的是，我们希望在下面中间的那一幅图上，我们希望通过胶原蛋白能够隔离游离的神经，而不要被我们的骨移植材料所刺激。OK， 这是我们术后的这个 CBCT 的影像。那我们在两侧的这个5号牙位进行了近中倾斜的植体的植入。这是我们在患者这个术后戴上肌颌过渡义齿21天以后患者复查的镜像。我们通过完成了这样一个极限病例的全种子体和神经移位的手术，帮患者做了一个肌颌负载的过渡义齿，来解决他的临时的美观和功能的问题。这是我们在术后3周，就患者在我们黑色点标记的位置是代表神经移位的麻木现象，那病人会有轻微的麻木，但是不影响他的生活，感受还好。然后这个时候我们会发现他双侧的这个后牙区的骨是正常的，但是前牙区会有麻木的现象。然后患者在3个月做复查的时候完全恢复感觉，那他的一切都变得正常。这是我们在术后6个月的时候，我们希望对患者进行永久的修复。我们记录患者口内的这个软组织的和种植体周围的愈合的状态。然后这是我们给患者完成他的永久修复的取模。我们将植体和植体之间进行刚性的连接，然后呢进行了硅橡胶的印模。然后这是我们给患者又重新做了一次新的临时牙。那我们希望通过这个临时牙重新确定它的合平面，还有珐琅区的大小。还有它微笑起来的一个健康的状态。有了这个牙齿在它做指导以后呢，我们给患者进行面弓的转移，希望把这样一个正确的颌关系转移到颌架上去，然后呢，给患者进行永久修复体的制作。这是我们给患者使用这个钛支架加上氧化锆的一个桥架，给患者完成了上颌和下颌的永久修复体。这样子呢，我们可以将这个修复体带入患者的口内。 那我们再来记录患者的咬合的状态和他的整个的这个面下1/3的丰满度，我们可以给患者带来一个新的美观和功能。那我们可以看到，在面下1/3，我们的患者已经有了基础的美学上的恢复。那同样，我们在和术前做对比，我们对他的正位和2个侧方进行面部的记录。我们可以通过这样一个新的修复体恢复他面下1/3的美观，还有包括和平面恢复一个正确的微笑和他的笑线。那这是我们在术后给他做了新的这个3维的这个 CBCT 的一个检测和这个3维的重建。那我们的曲段可以帮我们显示患者获得了一个新的义齿。那我们对他的这个术前和术后做对比的时候，我们发现这个新的这个义齿可以帮助患者稳定他的新的咬合关系，同时呢，我们给他增加了垂直距离，让他变得更加的年轻。OK， 这是在6个月以后，我们通过 CBCT 去做对比，我们会发现全种植体的周围，特别是全种体在上颌窦腔侧有了新的骨的再生。那这个呢，最大的好处是未来上颌窦炎的发生和我们的全种体之间没有关系，没有关系。OK， 这是我们在上颌窦腔的骨量的增加的一个现象。那这是我们的下颌，那我们在术前、术后和6个月以后，我们对神经移位处的植体，然后进行了 CBCT 的这个复盘，我们进行了这个横向的对比。那这是患者治疗前和治疗后的一个状态。那我们可以看到，这样一个无牙颌的固定修复，可以帮助我们患者恢复很好的美学上的恢复和功能上的恢复。这是他的治疗前和治疗后的一个对比，治疗前和治疗后的一个对比。那通过这样一个病例，我们想做一个总结，就是关于这种极限萎缩的病例，我们会有一个什么样的考量？我想从下面的4点来做这样一个总结。那如果在上颌窦区域，我们在后牙区骨量不足的时候，我们在上颌窦区域进行全种植体植骨的优点是什么？就是这是第一个问题。第二个是我们全种体周围如何能实现它软组织的稳定，能不要出现生物并发症？第3个问题是在下颌极限萎缩以后，我们如何通过下齿头神经移位术可以合理的避开神经的损伤？第3个是在上颌使用全种植体，下颌使用下齿头神经移位术，它可能给我们的固定修复带来什么样的好处？那第一个问题，我们通过 ITI 的一个全种植体的共识，我们会发现一个非常重要的问题，在整个上颌窦炎是全种植体治疗过程中最大的并发症，就是最重要的并发症。那它在5年的回访过程中有了14.2%的一个这个并发症的发生。那我们可以通过这样一个2013年的一个文献，一个德国医生他把全种植体的牙槽基顶、上颌窦腔侧和颧骨区分为 Z1、Z2、Z3。那如果我在 Z1、Z2、Z3的地方都有新骨的重建，那我们可以避免全种植体导致上颌窦炎的发生。那我们可以看到这样一个文献的这个结论是，那我们在全种植体进行上颌窦腔侧的这个形状的改型以后，可以合理的避开上颌窦炎发生的概率。所以我们这个病例，我们通过这个进行上颌窦腔同期的植骨，我们获得了全种体上颌窦腔骨再生的这样一个条件。所以我们在这样完成以后呢，我们全种植体在牙槽基顶、在上颌窦腔侧和颧骨区不再会有出现因为全种植体而导致上颌窦炎的这样一个风险。那我们回避了它的中长期的一个问题。这是我们在整个关于全种植体软组织周围的一个考量。那我们希望全种植体周围的颊侧，除了骨的保护以外，我们还希望能有牙龈的保护。所以我们在整个的外科植入过程中，我们希望全种植体的位置在牙槽基顶的入点的位置，它能够尽量偏向于腭侧，能够完整的保留它颊侧的骨板。然后在它内侧如果有植入的骨头，外侧有天然的骨板，它就可以尽可能保持我们种植体颊侧的角化龈的质量。但是明显可以发现，我们右侧的角化龈很好，但是左侧的角化龈偏薄。这个病人因为常住在加拿大，我们希望有机会再见到他的时候，可以帮他再做一次结缔组织的增厚，来帮助他解决更好的种植体周围的并发症的问题。OK， 这是我们在手术以后，我们希望能尽量保证它外侧的骨板，能够希望它能获得软组织的稳定。这是我们在模型上做的一个练习。那我们希望在种植体是偏腭侧植入，然后在植体植入以后的外侧，我们会有好的骨板，能够保持结缔组织和这个硬骨板的这个存留。OK， 这是我们的神经移位的一个影像。那我们可以看到，我们会希望打开我们的神经以后呢，希望把它的前方、后方和下方的骨板去掉，然后在髁神经前部的5毫米 截掉我们的神经之后呢，我们移动我们的神经，然后完成我们的植体的倾斜植入。在神经转弯处，我们用胶原蛋白，然后呢植上骨粉，盖上膜，完成我们的整个手术。这是我们完成了以后，我们希望通过全重植体和下齿槽神经移位的植体来解决我们修复体远中悬臂的问题，而给我们的修复减少未来的螺丝折断和桥体折断的风险。这是患者术前术后的对比。我想我们通过这样一个治疗，我们也很开心可以帮助我们的患者重建他的美学和功能。那这是我们团队能够帮助患者解决的问题。这是我今天的汇报。然后呢，非常感谢大家，谢谢。OK，Thank you. Thank you. OK. Thank you. OK. Thank you.
Oh, I think somebody wants to take a picture.
Is that right? Okay. Yeah. Okay. Fantastic.
I feel like a Santa Claus, taking a turn. That's how he feels like. Thank you very much. Wonderful presentation. Almost make me want to go back and do more zygomas now. So next presenter represents the United Kingdom, but he also obtained his master's degree in 2018 from Italy. Now, for the next 15 minutes, he's going to take us to his world of molar implant therapy, specifically more of an immediate molar therapy. How to do it right, and more importantly, how to do it predictably. The title is Predictable Results for Immediate Molar Implants. Let's welcome Dr. Yusuf Ashafi. Did I pronounce it right? Is it good? Close enough?
Yeah, close enough. Thank you very much. Thank you very much. So, I'm talking today about immediate molars, basically immediate implants in the molar zone, in the molar socket, and how to do this predictably. And the reason I've chosen this topic was because, I'm not ashamed to admit, I actually had a little bit of trouble with this particular procedure. And I was having more failures than I would like, and I basically stopped doing it. And I thought, let's just leave everything to heal. It's not a big deal, it's just a molar. But I'll talk you through why I changed my mind, what led me to go back and look at this again, and how I learned to do it more predictably. So, just to briefly outline what we'll be talking about today. Firstly, we'll look at the evidence for this procedure. We'll look at the advantages of doing it, so basically why it's done, and then also how to do it. Okay, so we'll look at the classification for the sockets to ensure that we gain our primary stability, briefly touch on dual zone grafting, and then the thing that really changed it for me, which is the custom healing abutment. That's what changed everything for me. Right, so the evidence. So it's not a new thing. We've had published papers for over 35 years on this topic. More recently, systematic reviews showing that the survival rates are actually the same for healed sites and immediate sites. So obviously, it was something wrong that I was doing. And what we also found was that the bone levels were better in immediate molar sites. And interestingly, the Urrutia study in 2020 showed us that grafting the socket really helped with our survival rates. So we'll take that on board. But then the question is why? Why are we doing this procedure? Why not wait? So obviously the sockets collapse when we take the teeth out. We lose hard and soft tissue. We also can save time. We can reduce the number of appointments and obviously reduce cost. It's often a flapless procedure, so there's less morbidity for the patient. But then, when you get failures, and it wasn't every single case, but you end up losing more hard and soft tissue, you end up using more time, using more appointments, costing you more, and actually the patients are in more pain. So again, I thought, well, let's just park this here and we'll come back after 3 months. What changed it for me was actually understanding that using a custom healing abutment ensured that the treatment firstly worked, and we ended up with much better soft tissue profile. We ended up with the papilla maintained. Now, you might be thinking, well, it's a molar tooth. You know, who cares about the papilla? We're not talking about the aesthetic zone. I care about the papilla. I'm sure most of you care about the papilla, and also food packing cares about the papilla. Because what we often, and I can only speak of my own cases, when I leave sockets to heal, and I then try to restore them, in the molar side, often end up with a slightly compromised result where you give the patient an incidental brush for free and you say use that after every meal and just make sure you clear everything out. But by maintaining the papilla, we can reduce this complication and this problem for the patient and give us a much better result. So let's look at the principles for immediate implants. Now, I won't bore you with the details, but essentially we need to, in the same way we look at single-rooted teeth, ensure that the socket is suitable. We need to ensure that the implant is placed in the correct 3D position and that we're gaining our primary stability from somewhere. Now, with single-rooted teeth, we end up using longer implants and preparing beyond the apex of the socket. We obviously don't want to do that for molars because of the vital structures, the ID canal, the sinus, etc. So this Smith and Tarnow classification helps us to kind of understand our different sockets and understand where we're going to achieve our primary stability. So they split everything into 3 different types of sockets. A type A socket is where that interradicular bone, the bone between the roots, is wide enough to house the implant. So the implant goes completely into that bone. Unfortunately, we don't get many of these. The most common type of socket is a type B socket, which is the case I'll be showing today, where the implant is secured into that interradicular bone, but some of those threads are exposed into the sockets. And then you have a type C socket, where hopefully it's not because of us, because of the surgeon, that the interradicular bone is missing. It's because the roots were fused. And you end up with a much wider implant. And you gain your primary stability, again, not apically, but from the socket walls. Now, we've got to be careful here, because that systematic review I showed in 2016 actually showed that using the super wide implants, anything more than 6 millimeters, had a slightly increased risk of failure, 3.67% compared to 1.45%. And the reason for that is most likely because those implants are compressing what could be a thin buccal wall. And what we often find with fused roots is that there is a little bit of bone where the roots furcate. And actually you end up with a situation like this, where there is a little bit more bone in the middle of that socket, and you want to use a wide enough implant to engage that bone, but not necessarily destroy everything. So this 67-year-old female presented to the clinic with a failing lower first molar. We can see the apical radiolucency, and that was secondary to a fracture. She had a vertical fracture right through the tooth, and unfortunately the tooth had to be removed. This is a section through the CT scan. We can see that fracture running all the way through. We discussed the different options as what to do to replace the tooth, and she decided on an implant, an immediate implant, in fact, for all the benefits that I've just spoken about. So I always break this down to the patient. I say, look, we've got 3 steps here when we come to do the treatment. We've got the extraction phase, we've got the implant placement step, and then we've got the custom healing abutment. It helps them to break it down. It helps me to break it down throughout that appointment. And they're all just as important as each other. So the extraction must be done atraumatically. Very simple. We just section through, separate the roots. We use fine luxators to gently elevate the roots out. Okay, in this case, the lingual fragment was removed and the tooth was sectioned. Once the tooth comes out, we want to obviously clean and remove the granulation tissue, and we can see we've maintained that interradicular bone. This is where we're going to stabilize our implant. So phase 1 is done. Tell the patient, okay, we're going to move on to phase 2. Let's prepare and place the implant. So we prepare into that interradicular bone using a very sharp lance burr, because we don't want to slip into the path of least resistance, which is into the mesial or into the distal sockets, of course. And the same applies when we're placing our implant. We want to make sure we're getting it into the right place. And we need to achieve a decent primary stability. So for this to be predictable, we know that we need at least 15 Newton centimeters. In this case, we achieve 45. So we know everything's quite stable. We've placed the implant deep enough to give us 4 millimeters of soft tissue height, and it's in the correct 3D position. Yes, I will graft. I'll come back to that. The next phase for the patient, I tell them, look, the surgery's done. Let's move on to making the custom healing abutment. So quite simply, a titanium cylinder is placed, and flowable composite is used to incrementally build up this web around the socket to outline the shape of the socket and slowly fill in so we form a socket sealing device. So this is going to help stop anything getting in, getting out, and also maintain the outline of the socket and keep what we have. This is then removed, and yes, I know it's not a pretty sight when you first take it out, but then you just fill in with some more composite. Way too bulbous. So we need to prepare this, we need to shape this, we need to think about our emergence profile. So we need to make a more concave shape to our temporary, custom healing abutment. And then we clean everything up and polish it and leave that to one side. Let's go back to the implant. So the implant driver is placed, and then we graft into the sockets. But we don't only graft into the sockets, we graft a little bit higher up into the soft tissue as well. The dual zone grafting technique, as described in 2012 by Chu, which actually was on an anterior case, talking about the jump gap and grafting up into the soft tissue zone and producing a much more aesthetic and stable result. Now, we're not looking for aesthetics here, but we are looking for stability in our soft tissue. A more recent randomized controlled trial done earlier this year compared this to connective tissue grafting and actually found the results to be very similar, but it's much simpler to do. So this is done. We then grab our custom healing abutment, secure that back into place, PTFE and composite to seal. Do you need sutures? Sometimes you need it. I like to do it just to hold everything together, and also it just reminds the patient that they've got to keep away from this area and protect the site. Immediate post-op radiograph shows that the implant is shorter than the apices of the roots of the socket. We're not going beyond the socket. We're securing it into that septal bone. We can see the emergence of the connective, of the custom healing abutment, and we can see the graft material in the soft tissue zone. Fast forward 3 months, nothing's really changed in the soft tissue aspect. Everything's quite stable. And when we remove that, we can see that we've got this beautiful emergence profile, maintained upper pillar, we've got a long running zone into our implant, really thick horizontal and vertical soft tissue, which will protect the implant and keep things more predictable in the long term as well. So we take the impressions and we send them to the lab, and we have to be clear with our laboratory, and we talk to them about the subcritical contour. Again, needs to be concave. And then the final millimeter, the critical contour, needs to be convex. This is what's going to help and support our soft tissue position. We also need to ensure that there's no glaze in that subgingival area, as per Lenkivicus. That we want to keep it zirconia, highly polished, or super polished as he calls it, with no glaze, for the hemidesmosomal attachments that will be achieved. Again, giving us that long-term predictability. This is fitted in a normal way, and we take a radiograph. Sorry, we can see that the papilla is stable. Nothing's really changed there. We take a radiograph and we compare that to what we can see a year later. The bone has matured. Sorry, I better get out of the way here. The bone has matured in the socket. We've got stable bone levels around the implant. And we can see that the contours of the crown are correct as well. And even when we look at it clinically after a year, we notice that the soft tissue has really matured around that zirconia crown. It'd be very difficult to probe around this area. So quite a stable result. And as I say, what changed it for me was this idea of using a custom healing abutment. Because the problems I was having was that graft was leaking out, food and bacteria were getting in, so it solved that problem. But also we know that we have better papillar indices, and we have much better bone levels as well, reduced bone loss. This is what I was doing before. I was placing a healing abutment, quite a wide healing abutment, onto my extraction site, and wrapping up with loads of sutures and trying to bring everything together. Not ideal. It worked. I mean, it does work sometimes, but we're talking about predictability. We want it to work every time. And some of you might be thinking, well, Megagen do a 10 millimeter healing abutment. And they do. And it is better, but it's not ideal, because still it doesn't really seal everything properly. And if that implant was slightly more lingual, then we've got a bigger gap opening buccally, and we've got the soft tissue being pushed to the lingual aspect, which isn't really going to help anyone. And the same applies for the new anatomical healing abutments. Same thing. You can't really beat a custom-made healing abutment. It fits perfectly into the site, maintains the soft tissue exactly as it was, keeps the papilla, and stops anything getting in or out. So it was a real game changer for me. So in conclusion, I'll go over the 3 steps again, because these are the important steps that we talk to our patients about when we're doing the procedure, but obviously to bear in mind what's going to make this work. So the extraction, very, very important. We have to section the teeth. We have to take the teeth out atraumatically to maintain, obviously, the buccal bone, the lingual bone, but also the interradicular bone, because this really is where we're going to be placing our implant and where we're going to be gaining our primary stability. Keeps it flapless as well, which is really important, just in terms of post-op pain, etc. We then look at the implant placement. So we've got to understand that classification to know where we're going to place our implant, which implant to use, what size implant to use. We need to then ensure that we're getting that primary stability of at least 15 Newton centimeters. And yes, we need to graft. The evidence does show that we need to graft the sockets. It does give a much better result, and dual zone grafting, even better. And then finally, I said it already, but the real game changer, the icing on the cake, the holy grail, the custom healing abutment. Yes, it does take time to make. You get quicker at it, but it's worth every second. It ensures that nothing gets in, nothing gets out. It ensures that the bone levels are maintained. We have much better marginal bone levels and much better papilla index scores as well. Thank you very much.
Thank you so much for the presentation. Wonderful. We have one more presentation before we can take for a break. Okay? Yeah. So if you need to go to washroom, maybe you need to hold it for another 15 minutes. All right? How's everybody doing? Doing good? Those of you already done the presentation, now you can relax, right? Now you can enjoy the show. All right. The next presenter is an oral surgeon from Vilnius, Lithuania. She too will highlight the efficacy of a clinical application of immediate molar therapy. We often ask the question, is immediate molar implant predictable? How far can we really push the boundary of immediate molar? It's a clinically relevant topic, isn't it? Let's hear from the expert. The title is The Power of Now. Let's welcome Dr. Evelina, let's see if I can pronounce it properly, Dr. Evelina Giniviciute. Giniviciute. Okay, there you go. Welcome. Let's welcome. Thank you.
So, hello everyone. And my name is Evelina Gineviciūtė, and I'm oral surgeon, yes, from Vilnius, from Lithuania. And I was actually planning to say that it's a big honor to be here, but honestly, now when I'm standing here with you all, it feels much more. It feels just amazing. So now let's enjoy this time together. So look at this. A successful tooth extraction with big inflammation previous. And in the end, we have bone resorption like this. Is that what we want? Is this our success? And I hope that all of you will say no, because infection and implantation is two different things, yes? But look at this molar, look at this infection. If you want to look a little bit closer, so it's a CBCT scans. And as you can see here, how big inflammation we have here. It's already touching our alveolus and nerve here. So how large it is. And we always are saying that we have infection, yes, after healing we have bone resorption. And it's normal for us, yes, it's unavoidable. But what if I would say for you that implant placement in infected site can even improve your results? Sounds risky, yes? Yes, I think yes. But I want to be today and talk about infection, because for us, infection is right flag, yes? It's something that makes us to stop, to reconsider, or even to delay our procedures. And when we are talking about infection, when infection meets implantation, we usually are saying no for it, yes? But today I want to be like this black sheep and to say yes. I want to say yes for infection. And this is my patient, Sarah. And this is the same molar I showed you before, this. So I'm saying yes for this infection, and I'm saying yes for immediate implantation. So you cannot agree with me that we have to put implant there, yes? But I think that all of you will agree that we have to extract that molar, and we have to make it carefully and atraumatically, yes? And the next step, super important step, is to clean and to disinfect our socket. Because when we have infection, so socket cleaning becomes critical for us, yes? And a question for you, is this site still fresh from infection? It can be good for implantation. And what science is saying? I want to show you two main papers that are demonstrating that infection is not contraindication for implantation. For example, in this study, we see that we have almost 98% of success when we are placing implant in infected site. In this paper, we see that it's even no significant difference. So with this information, we can go back to our case, and after extraction, after cleaning, what we have here, we have 0 bone apically. It's just a nerve below. So I wanted to illustrate how deep it is. So I took one of drills from surgical kit and I put it in the socket, and we see that it's real deep. It's 20 millimeters. It's 2 centimeters hole. So in this stage, we are dealing not only with infection, we are dealing here with questions like how to make implantation here and how to get primary stability here. So for help, again, is coming white implant. And yes, someone is saying that white implants is not good. Evelina, stop using this because you will have failure and etc. But I don't agree. Why? Because if you know how to use it, it's safe and predictable. So, for example, in this study, we see that after 7 years, 7 years, when we are using white implant, bone loss is just 0.19 millimeters of bone loss. So it's nothing. So as you can understand, yes, I'm using white implant here, and I'm placing it just in the middle of the socket. What about primary stability here? And it was perfect. It was 50 newtons per centimeter. And I want to highlight one more time. White implant is safe, but you have to know how to use it. So you have to place it a little bit deeper, at least 5 or even 6 millimeters below the gingival margin, and then you will be safe. So it's immediate implantation, yes, and if you want to preserve our soft tissues, so bone grafting is must. And okay, you can ask me, is it not risky and is it safe to use bone here when we have such a big infection and acute infection? And I can answer you that if you clean properly and if you made disinfection properly and if you want to have a good profile later, you have to do it. So in the end, yes, it's healing abutment. And yes, I could make individual healing abutment, or I could use anatomy healing abutment. But in this case, I use just a standard white. Why? Because it fits perfectly. So it's a question again. Do you want to look how it looks after surgery? And it looks like this. And yes, I agree that it looks risky. It looks dangerous. It looks, I don't know, it looks crazy because the implant is hanging just in the ear, but be patient. So after 4 months, what we have this. So no absence of any infection, just perfect healing. You can see that we could manage to keep our profile, to keep our papillas, to keep everything. And even patient is happy. He's saying, I'm not a bubble, thank you very much for no pain for me. So it's 4 months. And a lot of you are will be not doing this operation. Why? Because of infection, because we don't have bone here, yes. But look what we have when we make it. So now just final crown, and we are making final crown from zirconia, screw rattan, and I'm repeating myself again. 4 months, easy, I can say surgery, fast surgery, and we have this. So what about X-ray? Yes, our implant is still here. It's integrated. Our graft is also integrating. But look, I'm so happy about this. Our bone is healing. Our infection is healing here. 4 months. And what about 4 years? So after 4 years, you can see that it's healed. It's totally healed, and we have no bone loss, nothing. So 4 years and results like this. Could you answer me? Can we have and enjoy these results without doing this surgery instead of making difficult surgeries? I think no. And I'm sure that some of you are thinking that, yes, it's incredible, but it's just a one case and maybe it's just a lucky outcome, yes? So I want to save myself a little bit. So it's another case. I will show you quickly. And again, another patient, similar situation, even bigger inflammation here. And again, patient, he is coming, and with pain, with inflammation, with everything, with big, big eyes looking at me, doctor, help me. And we have 2 choices here: to extract, clean, and wait, and become a best friend with this patient for 1 year, or to make immediate implantation. So as you can understand, yes, we made it, and it was the same approach. Again with white implant, because without white implants, I cannot make this. And the same. In the middle of the socket, much deeper than usual. Again, bone augmentation. And in this case, I made individual healing abutment. And it's 2 weeks after surgery. What we have everything still is here and no absence of infection. Yes? So it's 2 weeks. Do you want to look how it looks after 2 months? So it's like this. 2 months, and we see that our soft tissues is perfect. But what about implant? Is implant still there? So we tested it, and we tested it with ISQ, and the result was 72. It means that our implant is also fully integrated. So 2 months, and we started our prosthetic part. And 2 months and delivery. Again, I'm showing the results that with that big infection, with that pus, we can manage to do this. So I would be not happy with results like this. So I called this patient last week. I said, Yelena, please come, I need to see you. No, doctor, I'm not coming. Yelena, please, you need to come. No, doctor, you need money or what? Everything is okay, why I need to come? Yelena, please. So she came, and I understood why she didn't want. Why? Because look, everything is really perfect, yes? Why she need to came? But yes, we have results like this. What about X-ray? Again, everything is healed, no bone loss, and implant is still in the place. So from this to this in 2 months. So in the end, I want to say maybe one thing. Try your contraindications, make your success. And if you will be enjoying what you are doing, you will be happy, your assistant will be happy, your patient will be happy, your family, friends, and everything. So enjoy and not be afraid to take a risk. Thank you.
Great job. Great job. Thoroughly enjoyed it. So everybody, that marks the finish of the group one. First bracket is done. I don't know about you, but I'm very, very impressed by all of you. Because I cannot help myself but to go back when I used to be doing my early competitions or presentation. I can tell you right now, all of you are way better than me in way back years ago. So thank you. Before we take a little break, I want to give opportunity, because I'm sure a lot of my judges here, they're also impressed as well. They have the hard task of scoring, which is not is quite challenging. So I want to give Professor Christian Dinu, would you want to stand up and just give your remarks so far?
Thank you, Mark. I intended to wait a little bit and to have the remarks at the end, but what I see that we have very nice photos, very well documented cases, comparing with other years. I'm in this process for 10 years. Zurich, 2014, first time annual reach day. So I have a long image behind me. I'm impressed about the delivery, about the documentation, but I still keep my words until the end. Thank you.
Also, it was really a great pleasure to follow this morning session. The 4 contestants were really wonderful, beautiful cases, very good and very nice communication skills. We can tell that you've been coming from a long way because of the fierce competition that brought the best out of you out here. I looking forward for the second, the third, and the fourth session to see who will be our 6 winners. But I'm sure that all of you are winners today, so no stress. Enjoy the day and give us the best that you have. It's really a pleasure.
I really thank the presenters, because I see the development, improvement of the presentations. Eyes contact, body language, storytelling, and videos, all of these, I see really big difference comparing with the previous presentations and right now. Of course, some small mistakes and small things, but overall, the presenters' level is really improving. I appreciate all of you. Thank you very much.
It's hard for us as judges to assess these presentations. We are looking for the potential of the speakers. Your skills as surgeons and restorative doctors is always impressive. What we as judges are looking for is the potential for you guys to grow and to excite the audience. And we have seen much of that so far. Congratulations.
Yes, I agree with my colleagues' comments. The level is going up. I see perfectly from the past 2 years ago, the level now is increasing. I don't know where we are reaching in the future. I don't know. I am a little bit scared about that, you know. After seeing you all in this morning, I have a lot of respect to you. I am excited to see the rest of the speakers. And yes, as Dino say, I reserve my words until the end. Thank you.
Thank you for my colleagues in the judge area, and especially congratulations to the finalists at this really fabulous stages. So I really enjoy what you guys are saying. And then this is actually my first time to be a judge in this prestigious stage. So most of the people just look like senior speakers. so so it's really fantastic to see what you guys are talking about, especially the implant dentistry as a whole. So thank you for your kind attention and your active, proactive engagement in the world of the Megamind, the Megamind 2024. Thank you.
Let's take a little break. Okay, thanks for not going to the washroom and holding. Okay, so we have a washroom break, and let's be here before 11 o'clock. We're starting here at 11 o'clock. Door closes at 11 o'clock. Okay, I'll see you then, guys. Thank you.
Kika. I'm Dmitry Ivanov. I'm a board-certified periodontist and dental implant specialist. I practice in Los Angeles, California. Went to dental school at UCLA School of Dentistry and the residency program at the VA hospital, UCLA VA hospital. I do truly love dentistry. I love surgery and the periodontics. I love teaching as well. So I have a organization that I founded with my partner is from Washington, D.C. It's called Perio Amigos. It's kind of a brand of mine. We're focusing on soft tissue surgery, soft tissue management, manage things around implants, kind of a little bit of a more advanced level of education for general dentists and specialists.
Following the massive success of 2023, the upcoming global event, the Megamind, will be even bigger and more exciting in 2024.
Megamind has been fired up my passion for teaching. Last year, I got intimidated a little bit by, even though I have a lot of material and I do all of the work that the competition shows. So this year he's encouraged me again. To me, the most rewarding part would be maybe meeting other people across the world, or if I get to travel and meet other professionals or specialists within the field, or dentists per se, that's sort of the most rewarding. Maybe collaborate with others, someone that maybe I can be a part of something bigger in the future.
If so, you're gonna win.
Oh, you can do it. For the doctors that are considering joining the Megamind, I think you're going to grow more. Okay, you're going to grow more because you're going to learn more. You're going to learn how bad you did because someone's going to say something, and you're going to show work how great it is. So you're going to get encouraged to do more of the same good work, right? Well, I would like to be the best. It's impossible to be the best because there's always someone better than you. We just have to accept it. But you just have to be able to provide that kind of level of care that you're comfortable with personally, that you are very successful to yourself.
My name is Kanika Murikanjan. You can call me Dr. Joyce. Since childhood, I have a dream of becoming a dentist because my mother bring me to hospital and I saw the dentist is so kind. I want to be like her. I graduated as a dentist in 2016 and subsequently worked at a government hospital for 2 years. After 4 years of performing dental implants, I graduated last year with a specialization in oral surgery and implantology. I attend the seminar and symposium in every year for treating to my patient because I want to help my patient in even better. Currently, I am working at Tung Song Hospital in Nakhon Si Thammarat province and at a private clinic in Hat Yai district. I believe that a professional dentist is one who combines both scientific knowledge and artistic skill to treat each patient uniquely. It's not only about having excellent treatment skills, but also about showing empathy and learning new techniques and knowledge to achieve the best result for patients. When I help a patient, it makes me happy because I see that I help them bite better and feel more confident with their smile. It's like with friends and family, where we wish each other well and want them to be happy in their life. Even if we are just a small part of their journey, this alone brings us joy. I want everyone to see that a university in the south of Thailand can effectively handle complex cases. It also allows me to undertake new challenges that I have never encountered before, providing valuable experience. I believe Thailand offers freedom because female dentists can work alongside male dentists. My colleague is so kind and everyone helped me. I am getting married soon. My partner is someone who cares deeply about every detail of my life. He supports me in my work and career, listens attentively to my concerns, and is aware that to help. I am grateful for his presence and how he completes me. I'm pleased to have him by my side.
I'm Rudy Garona, a 38-year-old period. Why have I decided to lecture on this topic at the Megamind competition? Well, I feel very strongly about immediacy in the world today. Time is precious, and scientific advancements enable us to offer quicker treatments to our patients. I believe it's our responsibility to provide this benefit whenever possible. My 4 years with Megagen have been extremely It's our responsibility to provide this benefit whenever possible. My 4 years with Megagen have been extremely fruitful, and I've had the opportunity to really get to know the Megagen ethos and their DNA, and immediacy forms a strong part of that. Their commitment to innovation and swift solutions has truly empowered me to meet my patients' needs more effectively and probably make me a better periodontist. I'd like to thank my team and my family back in South Africa for their unwavering support. Thank you. Unlock your potential. Test your mind. Megamind.
A lot of what I've done so far has really fulfilled my dreams. I've always wanted to work in implantology and not so much in the rest dentistry, and I've sort of achieved that. I've always wanted to be involved in teaching and have achieved that as well. But there's always a desire to do more and to learn more as well. There's still so much more to learn. My name is Yusuf Al-Shafi. I'm a dentist that graduated in 2007 from King's College London. I live in London with my family, 3 boys, so a bit of a handful. So I started this practice in Beaconsfield, which is just outside London. It's a small market town, and it's been great here. I'm still here 15 years later, and I've never really looked back. I think it's been an amazing career so far. I really enjoy what I do. Yeah, especially now with my focus now in implantology and oral surgery. It's just getting better and better. So I've been working with Megagen UK for about 8 or 9 years. You know, more recently I was involved with some teaching for them as well, and you know, when they introduced me to Megamind and they sort of spoke to me about Megamind, I thought this was a great concept. I was quite excited for the challenge, to be honest. But it's been a tough one, you know, to sort of see very experienced colleagues from around the world, you know, showcasing their work, and also sort of pushes you to improve your game, improve what you're able to achieve. And that's been the best thing about it, helping me to get better as well. Of course, with Megamind, you know, we're all in it to win, I think, and that will be the aim. But just the experience and just being on stage with these very experienced colleagues, you know, is an achievement in itself, and you know, for that I'm really grateful.
메가마인드 뉴스를 전해드립니다. 최근 한국에서 주목해야 할 인물이 메가마인드 도전장을 내밀어 화제가 되고 있습니다. 한국의 유명한 가수이자 프로듀서인 박진영과 이름이 동일해 주최 측에 혼란을 불러온 인물이기도 한데요. 제3회 메가마인드가 주목하는 한국의 도전자 박진영 연세대 교수를 소개하겠습니다. 안녕하세요. 연세대학교 치주과 교수 박진영입니다. 메가마인드 주최 측의 관심과 환영을 받아 더 좋은 발표 자료를 만들기 위해 노력하고 있습니다. 저는 치주과 의사이자 또 한편으로는 연구자인데요. 임상적인 결과뿐만 아니라 환자와 술자의 편의성을 증대시키는 좋은 진료를 하기 위해 노력하고 있고요. 학문적인 기반을 제시하고 구축하기 위한 공부도 꾸준히 열심히 하고 있습니다. 저 같은 젊은 임상가들이 평소에 쌓아온 진료 경험에 대해 발표하고 토론할 수 있는 기회가 아주 많지는 않습니다. 그래서 이런 좋은 자리와 국제적인 무대는 일단 너무 좋은 기회인 것 같고요. 제가 경험을 얻고 배우는 한편 또 다른 분들에게 이런 자극과 아이디어를 심어줄 수 있다는 점에서도 매력적이라고 생각합니다. 사실 작년에도 참가했다가 워낙 쟁쟁하신 분들이 많아서 떨어졌는데요. 올해는 두 번째 도전인 만큼 더 잘 준비해서 꼭 좋은 결과 얻고 싶습니다. 저는 진료를 하면서 연구도 병행하고 있기 때문에 임상에서의 맹점들에 대해 좀 더 분석하고 파헤쳐 봄으로써 여러 사람들이 들었을 때 도움이 되면서도 재미있는 발표를 하면 좋지 않을까 생각합니다. 최종 목표는 이제 한국 내셔널 리그에서 우승자로 선발돼서 국제적인 무대 경험을 쌓아보는 것입니다. 더불어 이제 세계 각지에서 저와 비슷한 생각을 가진 임상가나 연구자들을 만날 수 있다면 역시 너무 즐거운 일이자 큰 행운일 것 같습니다. Unlock your potential. Test your mind. Megamind.
Once I started doing more implant dentistry, I built a really wonderful relationship with my patients. Usually, even the most nervous patient, after having gone through implant dentistry with me, they're okay with anything. That relationship becomes to almost like a friend and a trusted advisor. They take my recommendation on things like, seeing their doctors and nutrition. So that relationship goes up to another level. So that was something I did not anticipate, but that was an added benefit and makes me motivated to continue doing implant dentistry.
What inspires you? Unlock your potential. Test your mind. We are Megamind.
In North America, where we practice dentistry a certain way, Megamind opens it up to the entire world. And it's not necessarily associated with a particular regulatory body. It's not the AAID or it's not the ICOI where they're trying to say, hey, we're a regulation body. But no, it's dentists who really love and passionate about their work and gathering together and sharing. So I think Megamind is just the perfect name. My goal is to go far in the competition, but my expectation is to enjoy myself and to challenge myself, just to have fun and learn from all the other clinicians that are part of this competition together, and perhaps to be part of the community. I don't expect much, but my goal is to make it to the end if I can.
All right, everybody. You know, I was just telling myself, and I was talking with some of my friends here who are doing the judging. And I say, you know, Kyuhan, I'm almost feel embarrassed to stand up here. Who's judging who? You know, my slides are not as polished, as good as theirs. You know, my stage manner is not as good as some of theirs, you know. But also, they told me that, you know, this is why we do this, so that we don't stay stale, we don't stay stagnant. We too need stimulation from you guys and learn from you. So I thank you very much for that, okay? Yeah. Now, you guys ready for the second round? Who's ready? Woohoo! Woohoo! All right. So now we're heating up, okay? Now we are heating up. There you go. Where did I put it? Here it is. Okay, okay. So we're going to do a 5 more presentation, okay? Yeah, so 6 more presentation, sorry. Okay, 6 more presentation before we take for lunch break, okay? Yeah. As I was going through the list of bio for many of the contestants, I come to soon realize that many of you are more educated than I am. You have more degree than I am, more PhD than I am, and certainly our next presenter, he's loaded, okay? Yeah. The next contestant has not 1, but 2 PhD degrees. 2, as if one's not enough. He's a prosthodontist representing China. The title of his presentation is Multidisciplinary Treatment for the Bone and Soft Augmentation in the Aesthetic Zone. No further ado, let's welcome Dr. Sa Yu.
Okay, welcome back. Thank you very much. Thank you for the previous presentation in the last session, and also two of my friends that gave a very good example. So today it's my honor to stand here to give you the presentation. The title is Multidisciplinary Treatment for the Bone and Soft Tissue Augmentation in Aesthetic Zone. My name is Yusuf. I'm from China. I'm a prosthodontist. I'm an implant surgeon. I'm from School of Stomatology of Wuhan University, China. So first look at a video. This is a video from our university. It is called one of the most beautiful campus in the world. So I like to, you know, walking on the road. Sorry, a little bit so fast. Okay, once again. Okay, I want to share this video because this is more important than my presentation. Okay, because I like beautiful things. I like walking on street. I like walking on the road to appreciate, you know, the flowers, the trees. Why we like this kind of videos? Because they are beautiful. Everyone likes beautiful things, beautiful world, beautiful campus, beautiful road, beautiful city, beautiful country. So this is my city. This is my university. So I think aesthetic is very, very important for everyone, not only for us, especially for the patient. So when we look at the patient, we there have you know, aesthetic problems. We have to face challenge. The challenge, we have to find out where the patient wants to be in the zone, in the aesthetic zone. So let's talk about the patient for today. For my presentation, this is a patient several years ago came to my office. We found the patient was not so happy because he has good. He was not so has a good appearance. He has you know, a symmetrical appearance for the facial, and when he smiles, we can see his mouth lifted to one side. And also when we check intraoral examination, we can see even worse things. We can see the poor oral hygiene condition. We can see the crowded dentition. We can see the maxilla and the mandible was not so good. So how to solve the kind of problem? This is a big challenge for us. So, and also I checked for the space for the missing tooth. We can see the 2-1 was missing, and also was not sufficient space for the 2-1. And also we can see the 2-2 was crossbite. So this is a complicated question, how to solve it. So we have to make a complicated treatment plan for this patient. First, we need to improve the patient oral hygiene. Then we need to do the periodontology treatment to improve the condition and the environment for the following treatment. Then we need to do the orthodontic treatment to move the situation and to move the location of the teeth. Then we need to do the implant placement for the missing tooth. And then we need to do the prosthetic way to do prosthetic treatment to follow for the anterior teeth. Then we need to do the review to keep everything stable. So because of the limited time, because we talk about only have 15 minutes, so I can only show you the key points for the whole case. The orthodontist referred the patient to my clinic, and he said, okay, you can just study to do your implant placement because we just fix the anterior location for the anterior region for the teeth. And we can see the leave a space for me here. And I also can know there the space is enough for me, but I think it's more than enough because it looks like it's a little bit wider than the 1-1, I mean for the contralateral space. So I do the DSD, I mean the digital design, smile design for the patient. The first is only we can change the direction, we can change the shape for 2-1, especially a little bit too wide. So maybe we can change 2-1 to 2-2. We just copy the shape of 1-1 and 1-2 to the contralateral side. And we think there's still a gap between 1-1 and 2-1. So that means this is not the best solution. So the final way is maybe we have to choose the 3 different, I mean the shape for 1-1, for 2-1, for 2-2. All of the 3, we have to change them together. Then we can have the best solution. And the patient accepts this kind of treatment plan. So the first thing is we have to check the bone condition. What is bone condition? We can see, because we can see there's a bone deficiency, the horizontal bone defect. And also the big challenge we can see here, there is a huge incisive foramen here. This is why the orthodontist said he cannot move the adjacent teeth to the missing part. So what should we do? The first is we have to do the aesthetic risk assessment. Then we have to do the aesthetic classification. Because the patient has a high aesthetic expectation, and also he has, the low deficiency of the bone, and also for the efficiency of the tissue, and also complexity is very high. So I think the patient is very difficult. So we think this is a aesthetic classification should be referred to the complex one. So the first option is we need to choose a proper implant. What kind of implant we should choose? We know if we face the root extraction, we will face the phenomena, and we have to find the bone resorption. So we can like this. So if we place the implant like a normal size, I mean a standard size or standard diameter, we can see the exposure for the surface. That means we increase the exposure, we increase the failure risk for the patient for the implants. So can we use the diameter of the implants with a narrow one? That means we can decrease the surface exposure, we can decrease the failure risk. But work is safe? This is a question. So we checked the systematic review and the meta-analysis, and we found actually the narrow diameter implant can be divided into 3 categories, especially for the third one, from 3.3 to 3.5. If we use this kind of diameter of the implants, it can be used in anterior region, even to the posterior region for the single one restorations. And they have the similar successful rate with the normal size. So that means that we can decrease our difficulty. So I use the 3.5 diameter of implants. And to promote our accuracy for implant placement, we design a guide, help us to facilitate the implant placement. And we print it out like a metal one. We use a metal for alloy, for the 3D printing, for the implant guide, and we're fitting and we're trying, and then we open the flap, and we notice we can see there is a very narrow bone. And we fit and we check everything. We can notice, compared with the resin one, compared with the normal one, we can see the metal one has a lot of advantages, like more stronger, right? Smaller size. So it's easily for us to see the direction of the drill, and easily for us to see the water cooling. It's easier to judge what is accuracy is right or not, to see the drills of the angles. And then it's easy to guarantee all the direction is good. And then because the incisive foramen interfere the placement of implant, so we need to remove the nerve, we need to remove the blood vessel, we need to remove the soft tissue inside the hole. Then we get preparation for implant placement, we do the tension release, we do the bone perforation, we clean everything. And then we do another things. We use the patient blood, because we can use the patient blood to get used for the concentrated growth factor, I mean the CGF, and also for the AFG, autologous fibrin. Because with these two different components, with CGF, AFG, we make them together with the bone particles, we can make a particle more stable. We can see this is all particles, what we call sticky bone, like a bone block. We make it together with a human own blood. It's very safe. So we packed everything, and this is a sample from SEM observation. This is why I have to do the PhD, right? So I have to do the SEM observation to check everything, to check the sample from my patient. This is also my patient. After 3 months later, we check the sample we made before the surgery. We can see even after 3 months, all the particles connect to each other together, and all of them will connected by the network of the blood. So it's easily for us to pack the sticky bone into the incisive foramen, and they place implant, and then we use a steady, or we mean a sticky bone onto the surface of implants. So we mean the membrane to protection, and then we use the CGF to help protect the membrane, and then we close everything. After the situation, after the surgery, we can check the common CT. We can see the implant was surrounded by the bone graft. It was great. So what will happen after 6 months? After 6 months, when we check from the facial view, we can see everything was good. But from the occlusal view, we can see there's slightly collapse. This is normal because of the normal phenomenon, because of bone collapse. But what should I do? We have to open the flap. We open the flap, we check the bone condition. Actually, the bone is good. The bone has a very thick thickness for the bone. We cannot improve further for the bone condition. But how to improve the contour for soft tissue? Actually, we notice there is a very thick bone, very thick palatal part for soft tissue. So very easy. We just move the palatal part to the facial part. This is a minimal invasive concept. Then we just close it, fix it. And when we remove the suture, we can see the contour with soft tissue was improved. That was very easy. We don't need to do the second surgery for the patient. And then we have to do the restoration. Don't forget, I'm also the prosthodontist. So I need to do the impression, but because it's kind of metal thing, so I have to do the digital impression for the patient. Otherwise, the people will kill me because we cannot get the normal, conventional impression for the people. And then we did the impression for the patient, and then we deliver the immediate provision into the patient. But notice, there's a little bit wider for the 2-1 than 1-1. If we compare the width, we can see there's a little bit wider, only a little bit, but we need to do the best. So that means only 2-1 can be a better result, but not the best one. So what should we do? We should change the direction. We should change the size. We have to change the ratio for 1-1, 2-1, and 2-2. Don't forget it. So this is why we have to do another provisional, even after we create the emergent profile for well. We need to prepare the 1-1, we need to prepare the 2-1, we need to prepare the 2-2 together. And then we made another provision into the patient mouth. After that, the orthodontist said you can use a retainer to keep everything stable. That was smart. So I use a retainer to keep everything stable for 1 month, another month. So that means 3 months later. We found everything was good, so we made the final prosthesis for the patient to copy the emergent profile, to copy the shape of the margin. Then we make the final ones. Because of the aesthetic way, we need the orthoceramic materials. We make orthoceramic abutment. We need to make the veneer. We need to make orthoceramic crowns, all of them together. Then can make you better results. Then we deliver all the components into the patient mouth. We can see in this way, patient get a better result than before. And even after 3 years follow-up, we can see the stable bone condition, and also for the condition for the prosthesis. So if we compare before and after, even after 3 years ago, for the anterior region, you can see we changed a lot. There's a big difference between before and after. Okay, I still have 2 more minutes. So I will say, if you ask for me today, how to solve this kind of complex solving the hard tissue problem in aesthetic way, in the aesthetic zone, how to solve it, I will answer you if I give you some take-home message. The first is you have to do the multidisciplinary treatment concept. At least you have to do the periodontal treatment to improve the oral condition. Then we need to do the digital technique to help us. In this case, we use the digital guides. Even actually right now, we can use the navigation, we can use Robert to help us. Then if possible, you can use a narrow diameter implant. It can decrease the failure and it can decrease the risk for you. And then you can use a bone graft like sticky bone, like sausage technique, like bone blade, whatever, BBA. Then you can use a connective tissue graft to increase the counter for the bone condition. But all of them, we have to follow the minimal invasive concept because we don't need to do more harm to the patient. Why? I also like my job because I'm a dentist. Also, dentist means 3 different words, right? You agree? We are doctor, we are engineer, and we are artist. We have to build a bone. We have to build soft tissue. But we are treat patient, but we have to smart. We have to use a minimal invasive concept. We have to treat our patient with little or no harm. Use a smart way because we are artists. And among all the steps, I think for me, because today this is the final competition for the implant placement. So for me, implant is the most important thing. What is implant for you? Implant also for me is 3 words. And plan to. And planning to. We are planning to make the beauty for the patient. This is our further aim. This is further questions. This is further destinations. So finally, I will welcome everybody to visit our hospital. This is our hospital. This is my office. I'm living here. This is the whole city of Wuhan. This is East Lake. So it's very near for me to go to the office every day. So thank you very much to give me the opportunity. And also, lastly, I will say one sentence because before the competition, you said a little giant said one thing, don't build a wall, right? Just build a table. This is why I want to share this kind of QR code of me because I opened a channel in China. I have more than 50,000 dentists follow my channel to share classic literature, to share the classic cases. I want to share my technique to give the patient, to give the young dentist to discuss with them. So thank you very much. Thank you all.
Thank you. Great job. Great job. Thoroughly enjoyed it. Thoroughly enjoyed it. You know, some say 15 minutes is too short, and some may say it's long enough. And when I talk to everybody, it says it's so difficult to put things in 15 minutes with the message, the photo, the literature, and everything. I agree. In my opinion, the shorter presentations are by far more difficult, by far more difficult. And some of you are asking, you know, how does a penalty goes and things like that? We've sent you all the information, the videos and everything. There is a little leeway. There is a little leeway. I mean, the earth is not going to shatter if you go 1 second over 15 minutes. Okay, so you know, as long as you don't go over 15 minutes and 59 seconds, you're fine. Okay, yeah. But once you go over 1 more second, yes, the sky's gonna fall down. Okay, so just want to let you guys know. All right, yeah. Okay, this is all about the 1 second. All about the 1 second. Next presenter represents Canada. Represents Canada. He brought his own personal cheerleader team right there. Okay. He's a full-time clinician at his private practice, and his passion for implant dentistry is second to none. Not going to say too much about his presentation. I'll let you guys find out for yourself. The title is "The Beauty is in the Eye of the Beholder. the ultimate mission of anterior implant therapy. Let's welcome Dr. Scott Jung from Canada.
Hello. Hello, everybody. Bonjour. I hope everybody has been enjoying this beautiful Mediterranean Sea of Cannes, France. Unfortunately, the weather isn't helping us, but I know everyone says there's always a brighter tomorrow. I am really honored and thrilled to join this journey of inspiration of knowledge, which is the Megamind. A quick introduction of myself. My name is Dr. Scott Jung, and I come from Canada, a city called Vancouver, located in the West Coast. And I am a dentist with a heart and passion for implant dentistry. And I practice as a general dentist at my own clinic called Cloverdale Dental Center. And I also teach a little bit of implants to other general dentists as well in my city. And I love implants, and it's my passion. And the reason why I love it is because it opens up a new chapter of rehabilitation for my patients. Many times, my patients will suffer from loss of mastication or low self-esteem due to their broken teeth. But now with implants, I can restore their form, function, and longevity almost instantly. And that is an amazing tool to me. And I've done ranges of implants from simple to complex, from immediate and delayed, and I've done them all. But out of all these things, my favorite ones are going to be anterior cases. And I like them not because they're easy. It's quite the opposite. I actually like a little bit of challenge. Anterior cases always brings a unique set of challenges that we need to overcome. And we talked about anterior cases all morning, but I come with a question that I want to ask all of you guys. And the question that I think is, what is an aesthetic anterior implant? And to answer this, let's go to a case together. Rob is my favorite patient because he's always full of smiles and he always makes everyone laugh in my office. Unfortunately, he's been suffering from an intermittent fistula on his front tooth, which was diagnosed as a vertical root fracture on tooth number 11. And knowing that this has to be extracted, the patient is aesthetically concerned about missing his front tooth and wanted the best option to replace it. And everyone in this room now knows that the best option nowadays to replace a tooth is immediate implant therapy. There's many articles out there, and I'm just going to mention one. We know the immediate implant has the best option to preserve the peri-implant tissue without actually increasing the failure rate. We talked about this. So now we live in the days of immediacy as a standard treatment. And for anterior cases, what we talked about, we talk about because we all want predictable aesthetic outcome. And one of my favorite mentors, Dr. John Coyce, has set out these 5 diagnostic keys that we need to look out for. And Rob scores 4 out of 5 with the tooth coronal to the adjacent teeth, thick gingival biotype, oval and square tooth shape, and most importantly, the osseous crest, 3 millimeters from the gingiva, which all these making it for predictable aesthetic outcome. Another critical factor we need to look at for predictable aesthetic outcome is the buccal plate thickness. We know when the buccal plate thickness is less than 0.5 millimeters, there's a huge risk of mid-facial recession, and we need to be able to compensate that with some type of graft like CTG that we talked about. But fortunately for Rob, he has about 0.94 millimeters buccal plate thickness, so we're not too concerned about the buccal collapse. So as always, the surgery is started with the atraumatic extraction of the tooth and a full curettage of the socket to get rid of any infection. And this was done in the days before I was utilizing a surgical guide. So I used this surgical stent, which is clear and helps me visualize where the final tooth position is, which helps me, in turn, position my implant, a prosthetically driven surgery. And one of my favorite implant system for immediate implant, Megagen's Blue Diamond, 3.7 by 13 was placed here. Now, according to this article and many others, when the buccal jump gap is more than 3 millimeters, there's going to be incomplete bony filling of the socket. Therefore, we limit ourselves to position the implant about 2 millimeters, which was filled with allograft as a part of dual zone grafting in order to enhance the buccal contour maintenance. And as always, as we know, Dr. Linkovich's famous zero bone loss concept, we place the implant platform 4 millimeters below in order to achieve a proper biological width. And now for anterior cases, I love immediate loading, but unfortunately in this case, we actually did not achieve a good initial stability and ISQ. Therefore, we decided on the delayed loading approach with the healing abutment in place. And everything is healed for 3 months, and you can see how beautiful the tissue has been healing. And you can see it in this view, but unfortunately the emergence profile was quite less than ideal due to the healing abutment. In order to develop the better and the best emergence profile, I like to refer to the aesthetic biological contour concept, or the EBC concept. And this concept divides the transmucosal zones, the tissues, into 3 different zones, which is aesthetic, biological, and crestal. And depending on the different zones, we need to design the abutment and the crown a little differently. From the straight crestal to concave biological and convex aesthetic, we achieve this reverse S-curve that we talked about. And so I instruct the lab to create this provisional crown with this in mind. And when we insert it, you can see how blenching of the tissue is occurring. That's telling me that the tissue is being sculpted for the better emergence profile. And in just short of 2 to 3 weeks, we can see ideal emergence profile has been reached according to the EBC concept, and we scan this emergence profile to design into our final prosthetics, which was made from final zirconia crown with a customized anodized abutment. And when we finally insert that in, you can see how beautiful everything looks, which blends and harmonizes with the rest of this dentition. And even after 1 year, everything is being well maintained. Now, we talked about the aesthetics a lot. But when we talk about it, we can say, oh, it looks good or it looks bad. But instead, why don't we use an objective scoring method for the aesthetics? Article suggests the aesthetics of anterior implant is a harmony between a pink gums and a white tooth. Therefore, we developed a pink aesthetic score and a white aesthetic score. And when we use this to grade our case, we can see how high the scores, because we were able to follow the science and the biological rules in order to achieve this predictable aesthetic outcome. And so let me ask you again, what is aesthetic anterior implant? And do you think this qualifies for it? Now, there's a famous saying, the beauty is in the eyes of the beholder. What does this mean to you, and what does this got to do with our aesthetic anterior implant? Well, in the ages of social media, we share everything, and by those things, we're influenced. And this perpetuates an unfortunate side effect where we try to standardize everything, including the beauty and the aesthetics. And it happens in dentistry because we share our cases to Instagram and Facebook, and we share the most perfect smile makeover cases with bleach white, pearly, pretty teeth. Now, don't get me wrong, this is a beautiful result. And and my last patient wanted this too. But what I'm talking about is, what I have trouble is when we, the doctors, try to force everyone into this one singular aesthetic standard. This is when I have a problem. A very interesting research that I come across with tells us that the aesthetics from the patient's perspective and professional perspective is not correlate. Due to the subjective nature of aesthetics and incompatibility of the patient's perspective with what is considered as an objectively perfect implant, an implant with the perfect pink and white aesthetic scores may in fact prove to be unsatisfactory for the patient. So despite you doing a perfect implant, your patients could still be unsatisfied. So when we do these aesthetics implant and set up these aesthetic standards, who's it really for? The word aesthetic is from a Greek term called aesthetikos, which then translates into a sense of perception. Aesthetic is never a single rule that we need to apply for. The patient's perspective of their aesthetics is a true aesthetic itself. And we need to be mindful when we are working on these aesthetic anterior cases, because that's how we truly deliver a patient-centric care. So when I start on the anterior cases, I look at it as a mission to find the beauty of the beholder. And so let's look at another case here. Carlos puts a lot of trust in me because he followed me from my previous clinic. And he finally tells me about his loose front tooth. This was diagnosed as an advanced perio and a vertical root fracture, and again, deemed hopeless. Patient was concerned about missing his front tooth and wanted the best option. Same story, right? Now, according to Instagram and Facebook, there's so many aesthetic issues here. Gingival line is not harmonious. There's a big diastema. Incisors are malpositioned. The edge levels are all over the place. So can we still achieve a predictable aesthetic outcome despite all these aesthetic issues? Or are these really aesthetic issues? Now, other than the poor hygiene and all that, when I asked and pointed these aesthetic issues to the patient and asked, hey, Carlos, are these important for your smile? Patient said no. A single question can really communicate what is aesthetic between you and your patients. Communication is at the heart of patient care. Without proper communication of aesthetics, despite our perfectly placed implant with perfect pink and white aesthetic score, your patients could be unsatisfied. And so based on his aesthetics, we designed the case, and this is where digital dentistry really shines, helping us to visualize the future. And as for patient's request, we just duplicate the patient's tooth. And due to the asymmetrical spacing, we have to utilize the surgical guide, otherwise a malpositioning of the implant could occur. And with 0.89 millimeters of buccal plate thickness and a thick gingival biotype, I'm not too concerned about the buccal collapse. So again, we start with the surgery, remove the tooth atraumatically and correct the socket. And a surgical guide with R2Gate kit was utilized to prepare the osteotomy and place the implant. And this time, 4.1 by 13 megagens blue diamond was placed. And now it doesn't really matter if the prosthetic is atypical, we still need to follow the biological rules. Therefore, we place the implant 4 millimeters deep, buccal jump gap less than 3, and a dual zone grafting. And this time, the initial stability was good, so we performed the immediate provisionalization, where we make it out of the printed temp shell, picked up intraorally, and this still needs to follow the EBC concept for proper biological, proper emergence profile. And this is what patient goes home with. And 2 weeks later, everything heals up and it's beautiful. But the patient comes in and complains to me. And I was truly shocked because I couldn't understand. Everything looked right to me. But the problem was, it was a miscommunication. Patient wanted a diastema on the mesial and on the distal. I don't understand why, but that's what patient wanted. So we decided to correct for these issues with the secondary provisional, which was made by the lab now. And I talked with my lab guys to make this provisional using exocad and photos. And also, once I insert it in, my patient comes back for 5 times. 5 straight times in order to correct for little edges here, little rounded corners here, and more spaces here, until we finally find the beauty of the beholder. And so we use digital intraoral scanner to duplicate the final emergence profile and the crown shape. And when we make the final prosthetic with zirconia crown and custom anodized abutment again. And here is what it looks like after it's inserted. This final result may not be your typical Instagrammable case because it scores very low on our objective scoring board. But the patient is happy because this is his perception. And who are we to deny of his happiness? So when we have these both cases side by side, what do you think is more aesthetic? I've done many anterior implant cases, but I've done them all with the same mission, a mission to find the beauty of the beholder. And that beholder is always our patients. We talk about anterior implant cases because we all want predictable aesthetic outcome. Predictability comes from the science and adherence to the biological rules, whereas the aesthetic comes from our communication with the patient, and digital dentistry helps a lot in this situation. We need to give individualized attention to our patients to achieve the most patient-centric and a predictable aesthetic outcome. because we're here to serve our patients. And so I dare say my ultimate mission of dentistry is to serve our patients to the fullest. And so we're in France. So we, as the French would have said, sois belle à ta façon. I wish you be beautiful in your own ways, and I encourage you to find the unique beauty in your own patients as well. Thank you for listening to my presentation.
Wonderfully done. I thought I was watching a movie. Fantastic, fantastic. It's amazing sometimes how much we can put into that 15 minutes. Some of the creativity, a lot of preparation that's involved on these. Thoroughly enjoyed it. So next presenter, it took him over 24 hours to get here. He's a periodontist, and today he's representing his home country, Australia. He always has a very interesting title to all of his presentations. Today the title is Evidence in Action. No, what is it? Oh, hold on. My mistake, okay? I'm going to rewind a little bit, okay, yeah. As I get older, I cannot see my phone properly, okay? All right, the next presenter represents South Korea. He's a periodontist and an adjunct professor at the Seoul National University Dental Hospital. The title is Aesthetic Harmony Between the Natural Teeth and Implants. Let's welcome Dr. Jong Ju Kim.
Good morning. Good morning, everyone, dear colleagues and friends, and ladies and gentlemen. I hope everyone had a wonderful time here. It is a great honor to present at the final league of the 2024 Megamind. My name is Jong Ju Kim, and I'm from South Korea. Today, I'll be presenting on the title of Aesthetic Harmony Between Natural Teeth and Implants. To briefly introduce myself, I'm a board-certified periodontist, and currently I serve as an adjunct professor at Seoul National University Dental Hospital, and I also run a small private dental clinic in the city of Seoul. This is my clinic, which is Meister Dental Clinic. From this location, after a total travel time of 17 hours, it is a privilege to have arrived here at the beautiful Hotel Martinez in the city of Cannes. One hot summer day, in my clinic, a middle-aged man came in, almost dragged by his wife, holding her hand. When he arrived and sat in the unit chair, he barely opened his mouth and was filled with distrust and fear of dental treatment. I treated him very kindly with a bright smile as one treats a child. Eventually, he asked me, "Can you make my front teeth look more beautiful within 2 months?" Just 2 months. After an oral examination, even though it was a highly challenging case for me and I didn't have enough time and confidence, I said to the patient with a warm smile, I would give it a try. This is the initial panoramic X-ray, and let's first focus on the anterior region and discuss the treatment plan. Starting at the maxillary right anterior teeth 11 and 12, periodontally they were severely compromised with greater immobility and very thin buccal bone plate. I planned immediate implant placement and provisionalization with simultaneous bone grafting. Next, for the maxillary left anterior teeth, 21 and 22, they were far from the ideal arch due to severe rotation and crowding. Thus, I planned intentional root canal treatment along with soft tissue grafting. In the mandibular anterior region, we can observe heavy calculus deposition, and specifically teeth 31 and 41 were floating, and 42 was also periodontally compromised. I plan to extract all 3 teeth with immediate implant placement and provisionalization. The total treatment plan that I've talked about so far is as above: immediate implant placement and provisionalization, and intentional root canal treatment. Here, you can see the current status of crown width ratio, gingival line, and incisor line. For the gingival line, we plan to improve it using connective tissue grafting. The crown width ratio and incisor line would be adjusted using a PMMA provisional restoration based on diagnostic wax-up. For the mandible, due to space limitations, the final prosthesis was also planned as 3 incisors as it is now. In the current state, after taking impression, I performed diagnostic wax-up and fabricated provisional restoration, which will be used as a positioning guide for implant placement. Here, the fixture positions are planned, and we drilled holes on the provisioner. And we completed the extraction and fixture placement and final abutment connection. And I immediately set the prefabricated provisional restoration, which was used as a positioning guide. This is healed state after 2 weeks. In the maxilla, the initial teeth alignment was significantly deviated from the ideal arch. I plan to distribute the space for the central and lateral incisors like this. First, we intentionally fractured the crown of teeth 11 and 12 to induce slight gingival overgrowth. And next, for teeth 21 and 22, intentional root canal treatment was performed. After 1 week, slight gingival overgrowth could be observed in this clinical photo and also in a schematic drawing here. White arrows. In addition, I did resin buildup on the palatal side of teeth 21 and 22, guiding them into the ideal arch. From the front view, I simulated the delivery of the imaginary temporary teeth and fabricated the temporary shell by hand. Finally, I delivered the first maxillary provisional restoration. From the occlusal view of this provisioner, the width distribution is well balanced, and this provisioner will be used as a positioning guide for implant placement. We made holes in the proper position and extracted the remaining roots. And then placed the fixture and connected the final abutment immediately, not a temporary abutment. After slightly modifying the abutment, I planned the incision design for hard and soft tissue augmentation. An incision was made between teeth 13 and 23. On the right side, hard tissue augmentation was planned using GBR, and on the left side, soft tissue augmentation was planned using CTG. For the sake of predictable hard tissue augmentation, I used allograft for intra-socket grafting, xenograft for extra-socket grafting, and covered it with collagen membrane. On the left side, I performed connective tissue grafting with chronally advanced flap. After grafting on both sides, the flap was sutured at the desired level by releasing incisions. Then I installed the provisioner, which was separated between implant side and the natural teeth side. From this initial state, let's take a look at the process of hard tissue augmentation. This is the CBCT sagittal cut of tooth 12. You can see the very thin buccal bone plate. As shown schematically, the periodontal condition was very poor. First, fractured the crown. After 1 week, slight gingival overgrowth could be observed. Then extracted the remaining roots and connected placed the fixture and connected the final abutment. Then elevated the flap, and I grafted allograft into the intra-socket area. For the extra-socket area, the non-resorbable xenograft was used for volume maintaining. I used collagenated graft material, carefully compacting and shaping it, then covered the graft with collagen membrane. I made releasing incision for tension-free primary closure. Finally, the provisioner was set. Let's take a closer look at the bone regeneration mechanism in this area. Actually, I had a chance to write a paper on this subject as a first author in 2016. And this was published in Clinical Oral Implant Research, the COIR. According to my paper, a distance osteogenesis from the socket wall, here from the socket wall, and contact osteogenesis from the graft particles, here, graft particles, occur together. Then it accelerates the bone regeneration. In other words, the distance osteogenesis from the socket wall and contact osteogenesis from the osteogenic cells attaching the graft particle surface combine to promote the bone regeneration. And in addition, I expect the yellow allograft will be resolved over time and replaced by the autogenous bone after a long time. This schematic is my ideal goal. The auto bone consists of the area around the implant, and the non-resorbable xenograft maintains the buccal soft tissue volume. In this angle, we can observe how GBR increased the volume and CTG thickened the gingival tissue. When comparing clinical photo taken right away after surgery, 3 weeks later, clinical photo shows the slight stabilization of gingival margin. From this angle, there is still some redness and swelling in this area where CTG was performed. It can be seen more time is needed for further stabilization. In the front view of the 3 weeks clinical photo, when compared to the initial clinical photo, the overall alignment of teeth and gingival symmetry improved a lot. In the panoramic comparison, fixture placement and root canal treatment have been successfully completed. In 5 weeks clinical photo, gingival tissue was more stabilized than before. However, we are not ready to take a final impression because gingival maturation is not completed. But we had only 2 months. That's why we took the final impression at 5 weeks. The stump model of provisional restoration, which reflects the patient's requirements, could provide the detailed information to the dental technician. Using software, the shapes of the provisional were superimposed on the abutments and the prepared teeth. In reference to this morphology, the final restoration could be designed. These are post-sintered crowns, and after cutback procedure, first build-up, second build-up, internal staining and glazing were performed. Through the laboratory procedures, eventually, the final prosthesis delivered like this. I try to match the shade of the restoration naturally with the patient's original yellowish teeth. And I expect gingival maturation more. Here you can see the final panoramic X-ray. The total treatment plan was successfully completed. Now we're going to review the entire treatment process from the beginning and wrap it up. This is the initial state. After surgery, you can see the immediate loading and provisional state. 3 weeks clinical photo shows the slight stabilization of gingival margin. And we took the final impression at 5 weeks. And this is the final prosthesis. Gingival symmetry as well as teeth alignment in maxilla and mandible improved dramatically compared to the initial state. And the natural teeth and implants are aesthetically harmonious. Since the final abutments were connected immediately instead of temporary abutment, there was no disconnection after surgery, which can which prevented trauma to the mucosal seal from multiple connect-disconnect procedures. Now this is the end of my presentation. I'm truly grateful for the dramatic dental and facial improvements, but what touches me even more is how the patient's initial distrust and fear of dental treatment transformed into trust and relief. Thank you for your kind attention, and thank you for joining me in this presentation. Thank you.
Those of you who do anterior cases, you can all agree that this is a really tough case. You know how what I do before I treat this patient? I bring the expectation level as low as possible. Low as possible. And harmonizing natural teeth to implant teeth is like a marriage between zebra and a horse, okay? Yeah, there's always a limitation. But seeing how the case turns out, and absolutely true too. Who says dentists, we don't change people's lives? We can do it too, right? We can do it. Thank you so much for sharing your wonderful case. Okay, now I can go back to the next runner-up. Now, okay. I got your false alarm there, right? Okay, so next presenter, it took him over 24 hours to get here. He's a periodontist, and today he represents his country, Australia. There's one place I haven't been yet either, right? He always has a very interesting title to all of his presentations. Today the title is Evidence in Action, Tailoring Solution for Every Implant. Please, let's welcome Dr. Zhu Zhenkun. Quat?
Yeah, that's it. That's it. Okay, thank you, Mark, for the kind introduction. So, implant dentistry has really revolutionized the way that we can restore aesthetics and function for our patients. However, with emerging techniques and materials, it's important that we continue to critically appraise the associated evidence so that we can optimize predictability and success for our treatments. Today, I'd like to present a case which showcases how we can leverage evidence-based dentistry in implant therapy. So this is our patient. He's 73 years old and he presents to my emergency clinic and tells me his upper right tooth is painful and biting. Medically, the patient is healthy, only taking rosuvastatin for hypercholesteremia. He's also a non-smoker. When I ask him about the tooth, he tells me it's mobile, it's keeping him up at night time, and he's having to take pain relief for it. On clinical examination, the tooth is grade 2 mobile, it's tender to percussion, and there's also a buccal swelling present. When I take a radiograph, I can see that there's a crown root fracture, and on bone sounding, there's significant bone loss on the buccal aspect of the tooth. Elsewhere in the mouth, the tooth 2-2 also has a chronic draining abscess, and this tooth is actually treatment planned for an apicectomy in 2 months' time. The patient also has a number of other missing teeth in his mouth. So I diagnosed the tooth 1-1 with a crown root fracture, which are deemed as unrestorable, and the patient tells me that he's previously had an upper partial denture that he wasn't able to adjust to and requests that we look at implant replacement for this tooth. So we know the tooth needs to be extracted. The question then becomes, how do we stage any implant treatment if we decide to do implant treatment at all? So there are a number of considerations when making this decision. Firstly, we have a significant bone loss on the buccal aspect of the tooth, which we know increases the risk of aesthetic complications with immediate implant treatment. Secondly, this is the first time that we're seeing the patient, so we've yet had the opportunity to perform prosthodontic treatment planning. So taking into consideration these two factors, I deemed immediate implant placement not suitable in this case. We also have to take into consideration the 2-2 apicectomy that's planned in 2 months' time, which may have also complicated the timing of any early implant treatment performed. So in this case, I decided to perform alveolar ridge preservation and aim more towards standard implant placement, knowing that this would minimize the dimensional ridge changes in this region. So when it comes to alveolar ridge preservation, there's yet to be an ideal technique defined in terms of how this should be performed. And additionally, alveolar ridge preservation in sites with significant amounts of buccal bone loss have been seldom investigated. So in other words, what this meant was that I needed to tailor my surgical approach to the patient's clinical presentation. A number of studies have looked at flapped versus flapless alveolar ridge preservation and have generally found that both clinically and radiographically, there doesn't seem to be a significant difference in terms of dimensional ridge changes between a flap or flapless approach. So in this case, where there's a likely need for improved access for proper positioning of the membrane, I decided to raise a flap for improved access and perform the alveolar ridge preservation with more of a GBR approach. When it comes to grafting material, we now have a large range of grafting materials available with different specifications in terms of osteogenic properties, osteoinductive properties, and also their resorption rates. A recent systematic review by Villa-Ortiz found that investigating different approaches for alveolar ridge preservation found that the use of a xenogenic or allogenic bone with a collagen membrane produced the most favorable outcomes. Additionally, a network meta-analysis performed by Canalys in 2021, which allowed indirect comparison between different materials, also concluded that xenograft materials were one of the more favored materials for alveolar ridge preservation. Consequently, in this case, I utilized deproteinized bovine bone material with a collagen membrane. In terms of provisionalization or temporization of the patient's anterior tooth, he opted not to have the tooth replaced. So these are the photos of the alveolar ridge preservation performed as planned. So at this stage, I completed acute management of the patient's tooth 1-1, and the patient then subsequently returned 3 months later for definitive treatment planning. Medically, there were no major changes to the patient's medical history. However, at this point, the 2-2 apicectomy had been completed. And these are the patient's clinical photos from the treatment planning appointment. Thankfully, for the most part, we could see that the buccal contour as well as soft tissue height had been preserved. Periodontally, the patient had no deep probe and pocket depths, and full mouth plaque and bleeding scores were under 20%. And we could see that the 2-2 chronic abscess had also resolved after the apicectomy. Overall, we can see the teeth are heavily restored and worn. This is the patient's OPG, a little bit older, but it gives us a good overview of the patient's dentition. We can see that there's been minimal tooth loss in the mandible. We have impacted the lower third molars, and there's also a mucus retention cyst in the left antrum. And this is the CBCT taken at the treatment planning appointment, and for the most part, we can see that there's consolidation of the graft in this 1-1 site. So the patient has multiple missing teeth in the maxilla. We have a 2-2 crown with poor aesthetics, heavily restored and worn dentition, and we also classified the patient as with having periodontal stability consistent with more recent case definitions. So in planning for replacement of the patient's teeth in the maxilla, there's two options, main options that are available to us, either to fabricate a new upper partial denture or a fixed option involving some implants. When considering our upper partial denture, we have the tooth 17, which has loss of periodontal attachment and is also mesially inclined, which means that it's difficult for us to create a guide plane around this tooth. The tooth 2-5 is also heavily restored, and as well as being a lone standing abutment adjacent to a distal extension for a potential upper partial denture. Consequently, I deem these teeth as poor denture abutments. When considering the patient's suitability for implant treatment, he's medically fit, periodontally stable, he's a non-smoker, and he's also performing adequate oral hygiene. Consequently, I deemed him an adequate candidate for implant therapy with a low risk of biological complications. And together with my prosthodontic colleague, we planned a fixed bridge in quadrant 2 and 3 single unit implants. So after discussing both the pros and cons of the treatment, the patient opted to proceed with the fixed implant treatment option. And this is our final treatment plan. Full mouth rehabilitation, including a bridge in quadrant 2, 3 single unit implants, and a number of crowns and composite restorations, as well as 12 monthly supportive periodontal and peri-implant care consistent with the patient's risk profile. In placing the 1-1 implant, we plan to place this 4 months after the alveolar ridge preservation, utilizing a 12mm bone level implant. For the 1-6 implant, we plan to place a 10mm implant in this site and noted that we needed to perform guided bone regeneration due to the reduced ridge width in this site. And we plan to do this with deproteinized bovine bone material and the collagen membrane. So specific to the 2-6 site, there's also the issue of the sinus. So there's the residual ridge height in this site is approximately 6 millimeters. We also have the issue of the sloped sinus floor and a mucus retention cyst. In the management of this, we have three main options available to us. Either to use a short implant, perform a lateral window sinus lift, or a transcrestal sinus lift. When assessing the patient's suitability for a short implant, a systematic review published by Thoma in 2015 concluded that there is predictably high implant survival rates for short implants. However, this review only included randomized control trials with a follow-up of up to 18 months. And furthermore, most of the restorations were splintered in the included studies. A more recent systematic review concluded that there was good survival up to 3 years, however, conceded that the long-term effectiveness of short implants remains to be further studied. So in this case, I opted not to use a short implant, instead using a standard length implant and then having to make a decision between either a lateral window sinus lift or a transcrestal sinus lift. When making a decision between these two options, studies have generally shown good survival long-term for both of these options. However, we also have the issue of the sloped sinus floor in this case, which increases the risk of perforation when performing a transcrestal sinus lift. And although the long-term consequences of perforation are still debated and controversial, there is data to suggest an increased risk of failure as well as chronic sinusitis with membrane perforation. Consequently, I opted to not proceed with the transcrestal sinus lift and instead performed a lateral window sinus lift. When assessing the sinus, overall, there were no anatomical impairments or pathology associated with the sinus, but obviously the mucus retention cyst. And we know that mucus retention cysts don't represent absolute contraindication for sinus augmentation, provided that the procedure is not predicted to interfere with the osteomyelial complex. So what I decided to do was perform the lateral window sinus lift with no specific management for the mucus retention cyst, perform it with simultaneous placement of the implant considering the residual ridge height and utilizing deproteinized bovine bone material with a collagen membrane. So we completed the treatment planning, and at this stage, I was confident to proceed with surgery. So these are the photos of the 1-1 implant. We can see slight fixture exposure in the coronal region of the implant, and consequently, I performed additional guided bone regeneration, again, utilizing DBBM and a collagen membrane. These are the photos immediately post-operatively and at the 2 weeks post-op. For the 1-6 implant, these are the photos, again with the implant placed as planned, with guided bone regeneration for contour augmentation. And again, the photos immediately post-operatively and at the 2 weeks post-op. And the 2-6 implant was also placed uneventfully with the lateral window as well. And again, utilizing DBBM and a collagen membrane to cover the window. And these are the photos immediately post-operatively and at the 2 weeks post-op. So the patient then returned 3 months after the implant placement for second stage surgery, and these are the photos at the time, as well as the corresponding radiographs. My prosthodontic colleague was then able to provisionalize the implants, and then again we have the radiographs at this stage of the therapy as well. I then was able to see the patient 12 months after for a 12-month review, and at this point the patient had all the definitive restorations completed. And again, these are the radiographs at that point in time. So just an overview of the patient's progress. This is where we started from with the missing 1-1 and acute management, and then the photos at the provisionalization and the 1-year follow-up. Okay, so I'm sure we all spend a good deal of time mulling over our patients' records and scans, reading a lot of literature, but at the end of the day, sometimes, just as Taylor Swift says, just because you made a good plan doesn't mean that's what's going to happen. And however, I do believe we owe it to our patients to at least be comfortable with the scientific rationale of our surgical approaches. Thank you.
Thank you very much. That Taylor Swift part just totally came from nowhere. Okay. I don't know what's going on in the next room, but they're having a more fun time than we do. Come on, okay? You know, we got to do some yelling too, I guess. All right. So we have 2 more presentation before we break for lunch. Okay. Yeah. The next presenter received his implantology fellowship at Brookdale Hospital Medical Center in Brooklyn, New York in 2010. His nickname is the Captain America. And as his nickname represents, he's representing United States of America. The title is Full Arch Freedom. And for the next 15 minutes, he will take us into his world of full arch therapy. Please, let's welcome Dr. Danny Domingo.
Thank you. Yes, my presentation is full arch concepts, and this PowerPoint is basically me. I'm a general dentist, and I started lecturing about 6 years ago on full arch implant rehabilitation. In 2017, I wound up opening up my own dental lab, so everything you'll see here in the presentation is from our laboratory. In that laboratory, we were able to develop the full arch screw, vortex screw, which is now just patented about a week ago, and we'll talk at the end of the presentation about the Smile Mission Foundation. Social media is a big thing, so I'm Implant Diplomat, and I'm LA Dental Implant Lab. But today's presentation is going to be on the diagnosis, digital planning, full arch, reconstruction concepts, and also taking into consideration soft tissue concerns. So I did my residency in Brookdale Hospital in Brooklyn, New York, where the population was 8.5 million people, and a single person made $100,000 in New York. So planning an implant is very easy, and people can afford it. But I moved back to Louisiana, in my hometown, where the population is 150,000 people, and for a single person, they can only make $30,000 a year on average. So it's very difficult to give people treatment and have them afford it. So what we try to do is strive to bring down the cost and provide the level of dentistry of what they need, right? This lady was missing a tooth, and we're recreating the biology around the natural tooth concepts. This is the day of delivery of her tooth, an FP1 tooth, or give back a tooth that was missing, you know, recreating FP1 tooth for someone that never had a tooth. And it's true, you really do change people's lives whenever you do this, but nobody talks about key concepts for full arch and recreating FP1's concepts. All of this, keep in mind, all of this that we do is facially integrated, prosthetically driven, digitally performed, but biologically integrated. Right, so this is why I lecture. This lady has been in treatment for 3 years. This is how she started, and this is where she is right now after treatment for 3 years. You see, she had her teeth taken out, and she had 4 maxillary implants and 2 mandibular implants placed by very talented dentist. And then he referred her to someone else to get teeth made, right? And this is the teeth that she has in her mouth. Man, please put your teeth in your mouth. This is what she starts to look like. And this is her smile. Mind you, she spent $20,000 on treatment, and this is the final product of her smile. The reason why I'm showing you this is because she went to go see another dentist because she was unhappy with her smile, and the other dentist said, oh, you need more implants. We're going to put more implants. So we put 2 more maxillary implants and 3 more mandibular implants in her mouth. Not yet working the patient up for prosthetics. He said, let me just go ahead and remake your denture over again. So this is her new denture that she had made for herself, right? This is the second time she's had a denture made, right? And if you look at her x-ray, she's got subcrestal implants placed, crestal implants placed, and supracrestal implants placed, but yet we haven't looked at the aesthetics of her case or driven this biology speaking. So they made another denture, and this is the final denture that they made for her. And at this point, after 3 years of service, she was ready to, she said, this is going to be my smile, and this is how I'm going to end. It's hard to understand how someone can look like this for the final treatment plan. And what I'm telling you guys is this room is filled with talented surgeons. And we need to drive the education for the future dentist so we don't have issues like this with our patients, and we don't have issues like this in our clinicians. And things can happen, right? Things happen, but we have yet, or any clinician has yet to look at the biotype of this person and look at where the implants are placed, and they haven't even considered the soft tissue considerations for a case. So she went from looking like this, terrible, to this, to that's her final treatment plan after 3 years. I'll get back to this, but I want to really talk about this key concept, and it's the wettability of the implant surface. Reducing the hydrocarbons, and there's literature after literature after literature to talk about how prevalent is this in the implant world. This is what a hydrocarbon is. Hydrocarbons are hydrophobic, right? So if you remove the hydrocarbons off of the implant surface using the plasma X motion, you increase the wettability of the surface of the implants. So we know that 26 to 55% of implants contain hydrocarbons the day that you open them up from the package, even if they're really well cleaned. And if you look at literature, just plasma X treated reduces the hydrocarbon load off the implant, right? Which increases the wettability of the implant surface. Wettability of the implant surfaces is critical on our long-term success of our implants, and we have studies that show that plasma-treated implants, increasing bone concepts, you get more bone faster around an implant. Why is that clinically significant? You have a patient like this who comes into you for treatment. Her husband just passed away. She has not been a dentist in any years. She's been the caregiver for her husband. She has extreme amount of bone loss. She has no bone available for implants in her maxilla, and she's asking you to take her teeth out and place a full mouth of implants because she saw a commercial from a TV. And so she thinks you could. Now, in your clinical practice, if you say, look, this is too difficult, I'm taking your teeth out and I'm putting you a denture, you're going to heal. There's so much bacteria and infection. I'm fine with that. And then come back and place the implants. In cases like this, it's very difficult to work these cases up without proper planning. And look at the photos. Look at the massive amounts of bone loss, the infection. She hasn't brushed her teeth in 40 years, right? Look at the bone and soft tissue consideration. She's got no keratinized tissue. All of her tissue is loose and friable, right? And so if we're taking teeth out and we're going to have to place implants, what about the soft tissue considerations for this patient? But also, she's bimaxillary protrusive. So when placing implants in the bone, we're going to have to bring her back aesthetically and prosthetically to be able to recreate her bite in the proper position where it never was, but where it needed to be. So this is basically what I showed her. Ma'am, this is how many teeth you should have. This is how many teeth you do have. Pretty much everything's a loss. We're going to have to take your teeth out, put 6 implants at the top, 6 implants on the bottom. But how am I going to go about do this? There's a step-by-step method for this. Step 1 is data gathering. I'm going to take upper and lower intraoral scans, but I'm also going to start taking some facial photos and do facial analysis to try to figure out where I'm going to bring her case or where we're going to finally drive her case. Studying for her face, we're going to do a smile simulation and figure out where she can look, what she can look like. Now, this is really good for her, but this really doesn't help me out because I need to take the 2D world and bring it into the 3D world. So the 3D world, we create an ideal aesthetic wax-up based on where the teeth should be in the patient's face, right? Facial scans, facial photos, intraoral stitching. Plan our implants in step 4 in the correct ideal tooth positions based on available bone, whatever bone we have, what minimal bone we have. This is going to be our maxillary implant positions and our mandibular implant positions. And where do we go here? Prosthetic considerations, FP1, FP2, FP3. For her, since there's so much bone loss and there's 20 millimeters of prosthetic space, she's going to be an FP3. So surgical guide design. I've done advanced bone segmentation in my maxilla and my mandible. I'm going to create a tooth positioning index guide for my maxillary and the mandibular arch. Remove that guide. I'll have a bone reduction guide to level out the plane for the bone, and then take a superstructure drill guide on top for both the maxillary and the mandible to be able to place my implants in. Because once you take those teeth out, you lose all references, and it's a bloody mess, and you can't see anything that you're doing from the surgery. So having a surgical guide for these cases is critical. Step 5. After designing surgical guides, we're going to design our immediate 3D printed prosthetics. They're going to be chairside delivered. Keep in mind, when you design the provisionals for this case, you need to make sure that you're off the bone by 2.5 millimeters to allow for soft tissue keratinized gingiva involvement. So this is the day of the surgery. Bone reduction guide in place. This is going to be how our guide, take it out, and we're going to reduce our bone, place our implants through our guide, and plasma X motion every single implant. We need to get great bone-to-implant contact immediately if we're going to media load implants in this patient's mouth. We're going to do a pickup conversion for her, top and bottom, immediate load provisionals. She walks out the door with upper and lower fixed provisionals in her mouth. After healing for 3 months, we need to evaluate the soft tissue. Now, keep in mind, I did no soft tissue grafting. All I did was recreate biology, using PRF and biological factors to be able to get thick band of keratinized tissue around our full upper arch and lower arch. We'll take our facial photos from the provisional that we 3D printed in advance, and we're going to digitize her face and her smile and be able to bring her back, her envelope of function, back into a FP1 position. Now, it's hard to do this with normal screws in today's technology. So we use the Vortex screw, which uses angulated screw channels direct to multi-abutment without a tie base. We milled upper and lower provisionals, actually milled 2 custom abutments from the anterior. We created an exocad library for Megamind to be able to mill directly to implant platform. This is our abutments in place and provisionals in place for the upper, lower, and her bite. Bite is key. We're in the correct CR VDO position for this lady. This is going to be, if she accepts this case, we're finished with our treatment plan. All we have to do is mill this in final zirconia, but we've completely changed and given her teeth that she's never had before. And this is her before and after smile. And we're done. She accepted the case. She loves it. So for her upper arch, we're actually going to mill this in zirconia, monolithic, with no cutback. This is going to be stained zirconia. On the lower arch, we're actually going to mill a titanium bar substructure because we had a molar cantilever off on both sides. And then we deliver our final upper and lower. It's been 1 year in function now. This is her final result. This is her final result. You guys remember that lady that I showed you guys at the beginning of the lecture? What do we do for someone like this? Keeping in the same concepts, how do we drive this? Now, if we could open up her bite and get her in a better position, but we can't because her VDO is correct. She actually is in a decent CR position. So we're going to digitize her upper and lower denture. I'm going to take an intraoral scans. And we're going to mesh those scans in exocad using her face and alignment. This is the pre-op, and this is her digital wax-up. This is the pre-op. This is her dentures stitched to her mouth in exocad, and that's her final prosthetics that we're going to deliver for her. Mounted bites in exocad. I'm going to do FP1 over FP3. This is the next day. This is actually last year, October the 20th of 2023. We delivered an upper and lower provisionals. Now, you see that concept and you think, do we take out all the implants? Do we start all over? Is this a surgical intervention? Just using the concepts of biology to recreate her smile and give her an FP1. This is where she started. This is where we finished. This changed her life and changed her perspective on implant dentistry. And all we did was harmonize her soft tissue and give her back biology. I said, ma'am, smile. Smile as big as you can. Smile bigger. Smile, 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 smile. And all I did was ovate ponic. Use ovate ponics on our provisionals to scalp the soft tissue to be able to give it a FP1 on top and FP3 on the lower arch. These are the final photos and a comparison of where we started and where we're going to end and where we ended for a case. I'm going to end my presentation, but I'd like to share with you one thing since I have some time. Once a year, I take dental students to Mexico. And we do so much in our private practices, it's important that we give back to the community. This is an orphanage. These kids don't have a home. They don't have families. They were abandoned. And this was a room in the orphanage. It actually had a dental chair in it. And these 8 girls did not have a bedroom. They didn't have a bed. So while we were there in Mexico, we saw them as patients and we did dentistry on them, fixing their teeth because they haven't seen a dentist in their entire life. And by the end of the project, we were able to create the girls a bathroom, 8 12-year-old girls. And we also changed that room and built a bedroom for them. This is giving back. We've gotten so much. Give back to other people. Do better for others. That's what's really important in life. Thank you.
Danny, thank you so much, my friend. Thank you. We ask ourselves questions time to time. How to do good dentistry? What materials to use? What to do? How to make more money? But I think if we rewind back long enough, all of us, there was a time that we asked ourselves question why we became a dentist. I think that's very important. I think event like this is more than just going for the gold medal. It's more than just trying to see who can do better case than others. I think it's important that we partake in together in an event like this to remind each other that dentistry has a higher purpose and we truly can change people's lives. So Danny, thanks for reminding all of us for that. Thank you very much. One more presenter, okay, before we take for the lunch. You know, can't believe it. It's lunch break now, right? Seems like we've been here forever, right? Okay, so just one more to go. And I tell you, this is the last presenter before the lunch break, but not the least. The next speaker is from Spain, and he is renowned for 100% digital workflow. Began his career at the San Pablo CEU University in Madrid, Spain. But then later he also obtained a postgraduate degree in implantology from University of Central Lancashire in United Kingdom. He also has a passion for full arch therapy as well. The title is Zirconia Monolithic Reliable in Full Arch Treatment? Let's welcome none other than Dr. Felix Wer. Okay, I tried, okay.
Good afternoon, ladies and gentlemen. I'm here today representing my clinic, Cruz Laguna, in Malaga, the south of Spain. And it's a pleasure and honor to share my experience with zirconia monolithic on full mouth rehabilitation. Zirconia, you can love it or you can hate it, but you can love it if you treat it well. First thing is to ask ourselves, what is our challenge on a full mouth rehabilitation? Don't forget that we need to have a plan, we need to have a protocol, because if we don't do properly our job, our planification, we can lead into bigger problems. So make sure that we treat these patients because they have a disability in their mouth, okay? So it's very important to ask ourselves. My challenge is that I work in Malaga, in the south of Spain, but once a month I go to the UK because we have a lot of connections with them. But I have to deliver long-term solutions and I have to deliver good quality treatment. Thanks to digital dentistry, I can achieve those. I thought, okay, for Megamind, to collect all my full arches done by myself and the same technician. These full arches are 100% digital, and the results are great, because out of 148, we just got 11 fractures. And the good thing is that we find out why those fractures happens, okay? So, again, zirconia is a really good material, but you need to identify if there is any problem, because it's a strong material, but it doesn't have flexibility. Out of those fractures, 5 of them were my fault, because I didn't do properly the protocol, because I didn't place properly the multi-unit, and then after 3 months, I tied it up a little bit more, and then I didn't provide the right impression. So when I received the final restoration, I placed my zirconia and it broke. The good thing of zirconia is that if we have attention, the fracture will happen on the same day, on the same month. It will happen soon, okay? The other 5 fractures were because of my lab. My lab decided sometime try to individualize too much this zirconia, and sometimes not leaving enough room in anterior areas for this zirconia. So you need to respect those. And we have one of the fractures that we don't really know. It was a really atrophic maxillar, and it was an over 10 millimeter block of zirconia. That one, I think we are studying what happened and give some millimeters and see how we can improve that. So every single case we do in 3 steps. Okay, every single. We will have more difficult cases, less difficult cases, but all of them we treat it the same. The first step is to collect the data, which is impressions, photos, and a CBCT. Once we have all that, we will sit down and we will diagnose with our technician to do the job, our job, the plan for the patient. Once we have all that, we'll go to step number 2, which is the surgery, with a guided surgery, and we will deliver the immediate loading. The patient has the immediate loading after 24 hours with a PMMA. The PMMA is being mild machine. And the third step will be 3 months after the step number 2, and we will create the final smile. So in order to remember, this is to me is the most important step, because that's when we meet our patient. Okay, Daniel is a 47-year-old patient. He has lost confidence. He heard that we can do immediate things. We can fix his problem. He travels a lot, but he's a heavy smoker, is scared to the dentist, and the solution for him was to do an all-on-6 because of the mobility. Everything was broken. We'll see in a minute. We asked him to give us the biggest smile, but this is his biggest smile. So I'll say to him, okay, don't worry. We will improve this smile. So we can go nowadays from real to virtual, taking an STL. So immediately we email that to the lab, and we can start to do our project. We can start to improve the situation. I need to rectify the functionality and the aesthetics. But don't forget that as well, while we're thinking the 3D implant position, as Gallucci described in 2022, we have to respect the tissues. The implant 3D position is crucial. Apicocoronal, mesial distal, and bacal lingual, of course. If we don't place and we don't respect the tissues, we can end up like this, because the implant position will lead with a wrong prosthesis design. This patient is not a dirty patient. It's our fault. We have created this. Patient cannot clean those. So if we don't deliver properly this treatment, the treatment is not going to last. And we are all here to provide long-term solutions. Also, we cannot deliver these non-parallel implants. Okay? Nowadays, there is lots of implant program to design. So guide your implants. By using R2Gate, I can combine everything that I said. I want my technician to design the smile, and I want this smile into my program design. Why? Because I need to guide my implants through the teeth, not the other way around. So with R2Gate, I can clear out the teeth, place my implants, and guide the implants through the teeth. Not like before. We used to place all the implants, take the impression, and then the lab will have the problem. Also, we can check that we are respecting the 3D position of the implant, and also we can choose the multi-unit abutment. So before the surgery, we can have the implants that we're going to use, the multi-units, and the surgical guides. Same thing happened at the bottom. We can clear out the teeth, and we ask our technicians to give us the design. And we place the implant, everything parallel, avoiding nerve structures, and making sure that we can do a plan like this. Again, checking where the implants position are, and to last, for the treatment to last in time. So we go to step number 2, the surgery, okay? And at this stage, we can decide if we're gonna do a type 1 or a type 2. In his case, he lost a lot of gum and volume. So I said to him, look, we're gonna end up adding some gum, but you don't have a high smile, so it will be fine. Once we have done the implant position, with R2Gate, we can collect the model and design the guide. In this case, we like it to do some anchor pins and left a molar in there in order to create the stability. Same thing at the bottom. At the bottom, we don't have the palatal, so we have less stability. The canines had stability and the molars as well. So we left them for the surgery in order to be able to provide the plan of the implants that we want in the bone level. In every single case, thanks to the kit that I use for any rich surgical kit, I can collect bone, using with plasma, and keep the alveolar, filling all those gaps with them, and it works fantastic. This is the surgery day. We place all the implants, we place the scan bodies, and this is ready. Daniel is ready to take impression. Same thing happened at the bottom, minimum invasive treatment, and he was really scared, and the surgery was done in 2 hours. This is the medial loading. On the top, we didn't want to do the extension on PMMA because it can break. So I said to Daniel, don't worry, for the final, we will do the extension. But don't forget, because in 24 hours, we have changed Daniel's life. And 80% of your treatment is done. We just need to, if the bite is right, we just need to improve the situation, and let's see what we can do for him. The important thing of today's presentation is how I did it. Every single case was done with a lab. It's called Medical Fit, and they have a passive test. Zirconia has to be passive. If it's not passive, if we have tension, it will break. So for this reason, we do Medical Fit 1, which is just taking an impression over the 6 scan bodies. And if we do that, if we do only that, then we will have a deviation of 2.5 millimeters. So it is not valid. We need to rectify. We need to correct the deviation. How we do that? We take a CBCT, and we can make the teeth passive. If for any reason we don't have a CBCT, or the CBCT is being moved, or the patient doesn't want to have another CBCT, what they have done is they have created a tray, which is called Medical Fit 2, and we do a pickup. The good thing of this is that we don't have to post this. We can put analog, and then we can take another intraoral scanner and send it to them, and we will rectify the deviation, okay? I know with tomography, we can do that nowadays, but this was done in 2017 already. Back then, tomography wasn't that advanced. So I think if we bought an intraoral scanner 4 or 5 years ago, by using this system, we can use it. Also, for us, it wasn't valid to work with T-bases because it increased the width of the platform, and also, I don't like to rely on cement, okay? So as well, we didn't want to work directly with zirconia over the multi-unit. For this reason, the lab increased the height from 0.6 to 1.1 millimeters. No using T-base in this way, and using a longer screw. This is the image of an analysis element of the zirconia without the modification. So the areas are easy to be broken. There is a tension. But in the other hand, when you modify the base, you release the tension up to 6 times. None of the fractures that I had happened on the connection. It happened in the middle of the teeth, okay? I know that some people are asking me crazy not using T-base, but none of the fractures happen on the connection. If you compare the multi-unit T-base, when you go from provisional to a final one, first of all, the T-base of the multi-unit is too short, so sometimes it's easy to uncement. For sure, to use it with PMMA, forget it, because they will be uncemented for sure. But also, we will increase the diameter. In anterior areas, we're going to leave the structure of the teeth really weak, so you can lead to a fracture. And also, in aesthetic zone, it will make our life very difficult. The only benefit that I see is that the fitting with the connection, you will have less leaking, okay? In the other hand, when you don't work with multi-unit, we will have better emergency. We will leave more room for the tissues, okay? So we're going to leave as well better zirconia structure on the outside. So anterior zone is going to be much easier to work. But what happens if we have to work with this? Are you going to use the T-bases in the middle, where laterals, they have the same width than the central incisors? We're going to see that, because in these cases, sometimes we don't have a space for a titanium base. Sometimes we have to work directly with a T-base. But what about if I'm telling you that this is being used from 2017? We are in 2024, okay? But I'm not saying just this. This is my own experience. All these papers, they've been done since 2016, okay? So they are there, but it's a Spanish company, and we are happy we've just been tested through the years with them. But what happened with Daniel? After 3 months, what we see is that because we respect all the tissue areas, we have stability, we have long-term solution. Same thing happened at the bottom, beautiful. And we said, Daniel, I'm going to make another temporary just to give you an extra molar. And then he said, fair enough, Felix. I trust you. I don't know what else are you going to improve for me, but I'm sure that you will. But this is Daniel. Remember the smile from before. This is a new person, but he is now an ambassador from my clinic. I know that out of 10 people, he will refer people to me just because he knows that I do everything that is possible to do. But for us, it's the bone stability, such a gum stability, okay? So this is absolutely perfect, stunning. Daniel, you're keeping a good care, okay? And he's part of the team now. This is my nurse, and now we have a photo. So it's like a party nowadays. Daniel didn't want to even take photos first time. So 6 months later, he comes back. He said to me that he stopped smoking. I said, well, this is not, I don't really believe you, but anyway, resin is not a final solution, especially not for Daniel. He's young. How can he will have to change this maybe every 5 years? So I don't want to provide this as a final solution. So let's go for the final smile. Look at beautiful zirconia can be done. On the top, because we have an extension, we use titanium and zirconia, and then at the bottom, we use directly zirconia, but with a modified base, as I explained. So we have to respect, as Gallucci said, the prosthetic design. There is a clean design, okay? The tissues, the soft tissues, they love ultra-polished materials. But when I was about to do the final, then my technician told me, look, this area on the premolar, you can break. So why we don't use the structure of titanium? I say, fair enough. We have room. There is no problem for me. Daniel is not going to notice. And at the bottom, because we have everything parallel and nice, we could do the zirconia straight away. But it's not a regular multi-unit base. We have increased the height in order to not have fractures into the connection, because everybody's scared of this. Okay? This is the analysis of the bottom teeth. No problem to do that because there is no tension. And this is the delivery of the teeth. It's an FP2, it's an FP2. Not all the patients are FP1s. They are FP2s, they are FP1s, but it's not a failure. I explained this to Daniel before. And going back to this, Daniel doesn't want to see this picture, but this is a new person. He doesn't recognize himself, and he's part of my team, as I said, and he always wants to take photos, and I know that he will be the big referral. But this is the picture that he wants. The picture that we want is that after a year, I unscrew everything, and I see stability. I see long-term solution on the top, on the bottom, and the structure of the teeth is totally fitting. The fitting of the teeth they are perfect because we have done the same protocol in every single case, upper and bottom. But at the end of the day, I'm just part of the team. Every team and every job needs somebody guiding. So just guide everything. Guide your implants to your teeth. You have to be surrounded by your musicians, your implants, your programs, but just guide it, okay? Because nowadays there is no excuses. Finish.
If I were to give him a prize for a perfect finish, 15 minutes right on the dot. Right on, bravo, okay? Right on. Huh? You know, I've been doing implant dentistry for almost 30 years, and I make a living doing full arches every day. When I'm about to think that I learned everything, here I come and I'm being humbled by you guys, you know? And that's the wonderful thing about dentistry, especially implant dentistry. I've been contemplating to retire in the next few years because my back is not giving up. I'm going to get some referral to a good physiotherapist because I need to do this a little bit longer, okay? So thank you very much, Felix, okay? I really, really enjoy that, really. All right. So those of you who finished the morning, I congratulate you. Okay, I congratulate you. And before we're gonna break out for lunch, any few words from the judges? Any remarks, Jordy? Yeah, I want to come and say something. Come on, Jordy, say something with me. Say something with me. I've been talking too much. You know, you're the better looking of us. So, you know, Jordy, say something nice.
Okay, I told you after the first round that I was shocked and a little bit with fear. But maybe now I am more relaxed and happier that the future of dental implantology could be better than the past and even than the present. Thank you very much for all of your presentations. I am still excited to see the next rounds. Thank you.
Any of you guys want to say a few things? Yeah, yeah. Okay, come. Yeah, they want to see a good-looking guy talk. Okay, all right.
Okay. Again, it was a wonderful second round. Actually, for us as judges to be able to judge the best lecture, it's not easy. You need to find a balance between a clinical and scientific rationale, between communication skills, between iconography, beautiful iconography, between proper follow-up. And it's not easy for one lecturer, mainly for you to be able to do all of those. But really, we were amazed to see that most of you could handle these topics. Some of you were very high graded on some of these criteria. But I can say that for me, if I look at my grade, I cannot yet say who are the best, because all of you are really, really very good speakers. So, bravo.
Well, I think the level is very good. What is different from previous years is that everybody so the level is closer. Some of you have a very good scientific part. Some the clinical cases are very well prepared. The photos, the videos are very nice. So it will be very difficult. And we don't have the perfect speaker. We have to admit that the market needs people who can do perfect education with very good communication skills, very good explaining the techniques and the materials, but also we need more scientifically based speakers. So I think we have a range of speakers. We don't have the perfect one. That's why we are now you are now 21 people, and the level is amazing. I think everybody will have their own place. You are already there, but we have the responsibility to pick only 6 finalists, and this would be very difficult because we have to keep this balance: education, science, communication. There is not one recipe. There is very, very mixed. This is my message until now. It's only the half of the day, so I might change my opinion. Thank you.
I just want to say a few words, not much, because a lot of my colleagues talk about the situation. I can say it's an important thing. I see guys more professional than the professional speakers inside you. And even maybe most of the lectures don't have this kind of delivery and pictures, sliding flows. So I can only say thank you for these great efforts to be here and show us how you improve yourself. And thank you all my colleagues that they bring a very, experience and creative organization, and all the day by day, all the quality of the Megagen is increasing. Thank you, all of us. Thank you, all the attendants and Mark and all the boards for these creative event. Thank you. Thank you very much.
Dr. Shu, you guys say something because they're waiting for lunch, so you guys say something.
Say something. I'll be fast. Nice to see so many young faces. I have been doing implants before many of you were born. Part of my judgment is, and I have been doing education for all those years. When I left school, even graduate school, we didn't, and that's what the new dentist now is doing. They're learning on the internet. And so this group of people will be training the future dentist. So very valuable stuff. I just make one comment. When you make us cry, it's harder to judge you.
Yes, as a university professor, judging the others' work is a kind of a daily work for me. So when I was asked to be a judge in this stage, it must be boring to evaluate the other people's work, especially I'm working on some of the National Research Foundation as an evaluator. So whenever I look at the others' research proposal, sometimes it's really boring. But this time, it is really positively entertaining to watch all you guys presenting here. Actually covering up all the things for the evaluation item, like professional way of speaking and covering up some scientific things might be really tricky, but so just the last word that I want to talk to you is just be bored. So thank you.
Thank you, Professor Kwan. So we all of us looking for lunch. I know some of you are very, very hungry. I don't know how much time we got. What time is it right now? Okay, so we are to be here at 1:45. 1:45. You know, I gotta thank everybody. We've been, you know, every time we create a schedule like this, we always worry that how much time we're gonna go over and things like that. And you know, as you know, Megamind event, we're notorious for going over, right? Okay, but you know, at Megamind, okay, we've really kept starting on time and finish on time. So on the behalf of Megamind headquarters, we want to thank you very much for that. So you guys have earned it. Go enjoy, have a great lunch, make new friends, okay? Be inspired and inspire one another. Thank you very much. We'll see you at 11:45. Thank you. 1:45, 1:45.
Hello, my name is Dr. James Cadigan. I graduated from dental school at the University of Manitoba in 2009. I moved to Vancouver and I bought a practice in Richmond. So I worked with both my parents. It was by design that I became a dentist because both my parents were dentists. So it was pretty hard to resist the draw of a life that I really understood well. One of the things that my dad really loved doing was dentures, whether they're complete or partial dentures, and that is the complete opposite of most dentists, in my experience. But I understood very early that if you're going to put implants in someone's mouth, you should know where the teeth go first. Implant dentistry and surgery in particular is kind of an exciting, it requires all of your attention. Apply yourself. You have to really prepare. That, for me, really engages me as a human.
Hi, guys. She's a dentist, so she's a terrible patient. And what? She's going to tell me how to do my sinus lift.
I'm not doing any sinus lifting.
Now, hush.
My mom has always been my champion. My mom would say, don't wish your life away. You know, you're always thinking, next year is going to be easier. Next year, I'm going to have this thing paid off. Or next year, I'm going to do things differently. And realistically, next year is going to be more complicated. Next year is not going to be any easier. Okay, I'm ready to make the next step in my career.
Each competition is composed of 15-minute clinical case or research presentations.
Okay, so you can see down here that lower left 38, this is our 6-year follow-up.
Yeah, Megamind, it pushes you out of your comfort zone. And as much as you were sweating and as much as it was stressful, when you go back and you look at the ultimate result, you have grown. And so my goal for myself is that I'm going to find some personal growth. And having those moments where it's not just about teaching other dentists, it's about teaching your patients. And, you know, it is about a legacy. And what do you leave behind?
Surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water and found my faith because I don't want to be stuck in.
So hello, my name is Evina and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, after one painful and as she said, very expensive appointment, she looked at me at the baby and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy, and I'm grateful for my mother because I love what I'm doing. And what I'm doing if I'm not working, so I love food very much, and also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water, and I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and I can be a top expert and still live and enjoy life. I think that Megamind is not just a competition. Yes, it's a competition and the winning is not a goal. I think that the most important thing that we are together and we are sharing ideas and creating that big, strong community. So how I'm feeling? I'm happy. I think I'm happy.
Oh no, you ain't seen nothing yet.
그날 되게 떨렸어요. 준비도 열심히 했고 그래서 좀 힘들었으니까 내가 돼야지, 내가 그 칸에 가야지 이런 생각을 갖고 들어왔었는데 이제 다른 선생님들 발표를 좀 듣다 보니까 오늘 많이 배워가야겠다라는 생각도 들고 실제로도 하루 종일 이제 앉아서 이제 20분 정도 이제 발표를 들으면서 되게 많이 배웠고요. 다들 너무 잘하셔가지고 사실 될 거라고 생각을 잘 못했습니다. 여기 서 보니까
정말 더 그날 기억이 다시 떠오르는 것 같습니다. 네. 저 빈 자리들에 앉아 계셨던 이제 교수님들, 다른 참가자분들 다 기억에 남는 것 같아요. 위너가 됐으면 좋겠다고 생각하고 왔는데 위너가 될 거라고는 생각을 못했습니다. 네. 솔직하게 진짜 될 거라고 생각을 못했어요. 그래서 발표가 났을 때 더 기분이 좋았던 것 같습니다. 네. 저희 부모님께 꼭 감사를 드리고 싶습니다. 저희 부모님은 이제 임상을 하신 지 한 30년 이상 되신 두 분 다 치과 의사세요. 그래서 제가 치과 의사가 되는데 롤모델이 되어주시기도 했고, 제가 이제 치과 의사로 또 성장할 수 있도록 항상 지원을 아끼지 않아 주셔서 꼭 감사하다는 말씀을 드리고 싶습니다. 이번 그 메가마인드를 준비하면서 더 나은 치과 의사가 되기 위해서 더 많이 배워야 된다는 그런 깨달음을 얻게 됐고, 환자를 위해서 더 좋은 진료를 하기 위해서 앞으로도 더 많이 공부하고 더 배우는 그런 치과 의사가 되고 싶습니다. 치과라는 분야 내에서도 배워야 되는 내용이 굉장히 무궁무진하다고 생각합니다. 임상 경험이나 지식들을 이제 공유하면 이제 세계적으로도 모두에게 윈윈이지 않을까 하는 생각에 조금 더 글로벌한 꿈을 꾸고 있습니다. 또 이제 제가 더 많이 아는 것은 더 또 나눌 수 있는 그런 연자가 돼야 되지 않을까라는 생각을 하고 있습니다. 이제 칸에서는 이제 또 새로운 주제로 이제 새로운 발표를 해야 되기 때문에 이제 준비를 하고 있고요. 사실 이제 두 번의 발표를 이미 했기 때문에 이제 더 좋은 발표를 준비한다는 게 꼭 쉽지만은 않은데요. 그래도 이 과정을 통해서 저 스스로가 성장을 했다고 느끼는 만큼 이제 더 좋은 모습을 꼭 보여드릴 수 있도록 하겠습니다. Unlock your potential, test your mind, Megamind.
My name is Domingo, and I'm a general dentist in Lafayette, Louisiana. I graduated from dental school in 2007. Upon completion of my residency program, I applied for a 2-year implantology fellowship with Brookdale Hospital in conjunction with NYU. I always felt the need to come back to the city that helped raise me. After practicing for 6 years, I eventually moved back to Lafayette, and that's where I've been for the past 12 years now. I practice as a general dentist. My practice is mostly limited to implants. We do have a referral-based practice where more difficult cases that require, I do most of the surgical aspect, start out with the prosthetic aspect, and in that, I've developed the Louisiana Dental Implant Lab that helps support me. So we're a full digital lab. We do take some analog cases, but that's like my playground.
No, I don't want a picture. I don't want a picture.
I want you to meet my wife. Yeah. This is my wife, Megan Domingo.
Hi, how are you?
Currently, she runs operations for the dental lab and all 13 employees that we have here.
So close.
How's it that your husband is your boss?
I'm the boss.
Oh, you're the boss. You're the boss.
I have a motto for myself: work smarter, not harder. You know, in my small community, it's we only have 150,000 people. Isn't as big as New York City, where I used to practice. Patients here can't afford $30,000 treatment plans. So my goal in this was to help be able to lower my overhead expense by having a digital lab. So being able to provide the best level of care for a least amount of out-of-pocket for the patients as possible, and giving them a wow factor at the end of their treatment plan. It looks good. Yeah, this is pretty easy. When I was in residency, my mentors were the guys that lecture around the world. I looked up to them, and I thought, one day I want to give back to the younger generation. So as soon as I got out of the residency program, I wanted to lecture immediately. But I was so young, the sales reps wouldn't let me lecture for their companies. So I documented my cases, and I was showing things that I was doing, and that's kind of helped me get some speaking engagements.
It's important to understand how to get a patient in from the 2D world into the 3D world.
And once the surgery is performed, we'll convert our digital wax up.
League America. Dr. Denny Domingo, United States of America.
21 of the best clinicians that I think are some of world-renowned clinicians, and me, just a general dentist in a small town, which sounds intimidating, to be honest. I'm expecting the best clinicians in the world to present their best cases on a very big stage. I'm gonna do the best that I can. I had a mission in life to do the best for others, and God really has a purpose for me. Creating that purpose and showing him what was possible for me.
We allow the biology to work for us, and her tooth 4 was broken palatally.
Dr. Scott Jung.
Because the buccal plate is primarily
Scott Jung, representing Canada.
Less than 20%, and reduction of sides with the concave.
Why? Because we have comprehensive problems.
It was a fierce competition. 20 contestants from all over the world, and they are the best, and they're representing their nation and their continent, and they're competing against one another in order to make the final 6th spot.
Did you disappoint that statistics?
Yeah, of course. I mean, we go there in hopes of winning. I don't think anybody's there just to enjoy the time. They want to win, right? And that's the part of the competition. I understand that as a dentist, we're good at being a dentist, but we're not trained and skilled enough to become a good speaker. There are people who it comes naturally, but most of us needs training. And I found that going through the 2 years of Megamind really has trained me, gave me a hard training in speaking. Now I know how to speak better. I know how to present better. I know the last Megamind made me a better dentist who can serve my patients better. I'd like to start off my presentation with this particular picture.
League America. Dr. Scott Jung, Canada.
Oh, I'm hugely honored, and I'm very excited to make it to the final round of Megamind again. Megamind, to me, it means 2 things. Number 1 is a dojo training for speaking, trying to encourage, educate other dentists about the potential and the future of implant dentistry. And second is also a platform to meet other clinicians and share the ideas in order to advance our career and our profession. My mindset going into the final round is to shoot for gold. You want to win, and I'm giving my best to win.
I'm Nabil from Lebanon. I live in Batroun. It's a coastal town known for its beautiful sea, water sports, and stunning nearby mountains. I'm the co-founder and periodontist at Dentist Studio in Byblos, Lebanon. It's a private polyclinic. We are a team of 6 dental specialists, including my sister and my wife. Since I was a child, I wanted to be a doctor. I was inspired by my father, who is a doctor and my idol. And I also had a deep passion for technology. And it is during my residency years in periodontics at the St. Joseph University of Beirut where I discovered digital implantology, and I felt that this is the perfect blend of my interest with my dental career. Since graduating, I practiced prosthetic and implant dentistry, and then became instructor in guided surgery at the same university, and later managed the craniofacial research unit at the Craniofacial Research Laboratory at the same university. I also founded a guided surgery service and training services for other dental professionals. Balancing work and personal life is definitely a challenge. However, I make it a priority to spend some quality time with my family and engage in some outdoor sports activities like windsurfing, biking and snowboarding. This allows me to recharge and stay focused and be more effective in my professional life. I'm grateful to the persons and colleagues that encouraged me to enter Megamind, since it is an opportunity for me to share my passion and the techniques that I've developed in digital implantology. I've collaborated on many scientific projects and studies, but I haven't yet shared some of the most impactful things that I've done with the broader community. So I think this is a chance for me to challenge myself, to learn from others, and to contribute to the ongoing evolution of the digital dentistry.
Hello， 大家好，我是来自于中国北京雅德家口腔医院的刘铁亮医生，非常高兴以视频的方式和大家见面。今年是我自己进入种植领域的15年，在过去的15年的工作中，我们也积累了很多的经验和一些成功的病例，所以我希望能够有这样一个国际的舞台，能够让我们去展现自己的病例，也希望在比赛的过程中能得到更多的成长。据我所知，美格真的一次病例大赛在中国有超过100名专业的牙医参加。我们在整个的这个比赛的这个筹备，还有这个备赛过程中，大家有更多的这种交流的机会，让我们共同去学习，共同去交流。同时呢，在整个比赛过程中，我们也看到了自己的不足，然后也这个借鉴了别的医生的更多的优点，然后实现了相互的成长。我自己在临床过程中特别偏好于关注重度部萎缩的病人，即可重组、即可负载这样一个比例，所以我在整个比赛过程中的3个病例都是全重组的病例。原因是什么呢？当我们通过一次手术为患者植入了全重物体，并且当天给患者完成了即可负载的过渡义齿的代入，我们可以看到患者可以恢复灿烂的笑容和良好的功能，这也许是我们临床医生最大的幸福。当我知道美格真通知我说我可以去参加戛纳这个比赛的时候，这是我人生第一次走向国际，能够和全球的优秀的牙医在同一个平台上交流，内心非常的激动。当然，我也希望自己在过去15年的工作中总结的东西，能够让全球的牙医看到，并且能够认可，能给予我们一些正向的这个评价和鼓励，能够激励我们在未来工作过程中不断的前行。如果要说最大的期待的话，本次戛纳之行，那肯定是希望能够在整个比赛过程中获得更好的成绩，能够证明自己。最后，我特别感谢美格登公司提供这样一个好的舞台，能够让我能够去展现我自己。当然，我也特别呼吁这个年轻的医生们能够加强我们的学习，然后去收集我们病人的术前、术中、术后的这一些资料，特别是做好我们完成以后病例的长期追踪。那如果有机会能够收集到完整的病例以后呢，为我们自己储备好这种机会，然后在未来可以参加更多的这样的比赛，然后呢，让自己可以走出去，然后也可以有更多的学习机会去展现自己。好的，预祝 Megamind 的全球总决赛圆满成功。
Kika.
I'm Dmitry Ivanov. I'm a board-certified periodontist and dental implant specialist. I practice in Los Angeles, California. Went to dental school at UCLA School of Dentistry and the residency program at the VA hospital, UCLA VA hospital. So I do truly love dentistry. I love surgery and the periodontics. I love teaching as well. So I have a organization that I founded with my partner is from Washington, D.C. It's called Perio Amigos. It's kind of a brand of mine. We're focusing on soft tissue surgery, soft tissue management, manage things around implants, kind of a little bit of a more advanced level of education for general dentists and specialists.
Following the massive success of 2023, the upcoming global event, the Megamind, will be even bigger and more exciting in 2024.
Megamind has been fired up my passion for teaching. Last year, I got intimidated a little bit by, even though I have a lot of material and I do all of the work that the competition shows. So this year he's encouraged me again. To me, the most rewarding part would be maybe meeting other people across the world, or if I get to travel and meet other professionals or specialists within the field, or dentists per se, that's sort of the most rewarding. Maybe collaborate with others, someone that maybe I can be a part of something bigger in the future.
If so, you're gonna win.
Oh, you can do it. For the doctors that are considering joining the Megamind, I think you're going to grow more. Okay, you're going to grow more because you're going to learn more. You're going to learn how bad you did because someone's going to say something, and you're going to show work how great it is. So you're going to get encouraged to do more of the same good work, right? Well, I would like to be the best. It's impossible to be the best because there's always someone better than you. We just have to accept it. But you just have to be able to provide that kind of level of care that you're comfortable with personally, that you are very successful to yourself.
Hello, my name is Kika. You can call me Dr. Joyce. Since childhood, I have a dream of becoming a dentist because my mother bring me to hospital and I saw the dentist is so kind. I want to be like her. I graduated as a dentist in 2016 and subsequently worked at a government hospital for 2 years. After 4 years of performing dental implants, I graduated last year with a specialization in oral surgery and implantology. I attend the seminar and symposium in every year for treating to my patient because I want to help my patient in even better. Currently, I am working at Tung Song Hospital in Nakhon Si Thammarat province and at a private clinic in Hat Yai district. I believe that a professional dentist is one who combines both scientific knowledge and artistic skill to treat each patient uniquely. It's not only about having excellent treatment skills, but also about showing empathy and learning new techniques and knowledge to achieve the best result for patients. When I help a patient, it makes me happy because I see that I help them bite better and feel more confident with their smile. It's like with friends and family, where we wish each other well and want them to be happy in their life, even if we are just a small part of their journey. This alone brings us joy. I want everyone to see that a university in the south of Thailand can effectively handle complex cases. It also allows me to undertake new challenges that I have never encountered before, providing valuable experience. I believe Thailand offers freedom because female dentists can work alongside male dentists. My colleague is so kind and everyone helped me. I am getting married soon. My partner is someone who cares deeply about every detail of my life. He supports me in my work and career, listens attentively to my concerns, and is always there to help. I am grateful for his presence and how he completes me. I'm pleased to have him by my side.
네, 안녕하세요. 박찬영입니다. 저는 치과보철과 전문의로 틀니, 임플란트, 심미보철 등 다양한 영역의 치과 치료를 전문적으로 진료하는 치과의사입니다. 저는 환자들의 저작, 발음 등 구강 건강의 기능적인 부분과 더불어서 심미적인 요소도 회복시켜 줌으로써 환자분들의 삶의 질을 높이는 부분에 집중하고 있습니다. 제 인생의 모토는 결과가 어떻든 후회 없이 최선을 다하자입니다. 최선을 다하는 동시에 최대한 즐기려고 노력하는 편입니다. 경희대학교에서의 긴 학업과 힘든 수련 과정도 이런 인생의 모토를 늘 실천해서 잘 마칠 수 있었던 것 같습니다. 네, 최근 1년을 돌이켜보면 작년 메가마인드 대회 참가 외에도 개인적으로 늘 인생에 있어서 정말 많은 변화가 있던 시기였습니다. 저 같은 경우는 결혼을 해서 이제 가장이 되었고 또 레지던트 과정 마무리와 함께 정식으로 치과 보철과 전문의가 되기도 하였고 어떻게 보면 수년 동안 머물렀던 모교의 품에서 처음으로 벗어나서 독립을 하게 된 그런 셈인데요. 치과의사로서 제 커리어를 어떻게 발전시켜야 할지는 지금도 사실 많은 고민을 하고 있고 계속해서 좀 치열하게 고민을 해봐야 할 것 같습니다. 두려움을 느낄 때마다 옆에서 항상 저를 지지해주는 사랑스러운 아내가 있어서 잘 해낼 수 있을 것 같습니다. 그리고 장기적으로 저의 목표 중 하나는 치과의사를 가르치는 치과의사가 되는 것입니다. 아직은 부족한 점이 많고 경험도 적은 그런 루키의 신분이지만 앞으로 끊임없이 공부하고 다양한 진료적인 경험을 쌓다 보면 언젠가는 인정받는 연자로서의 위치에 도달할 수 있을 것이라고 생각을 합니다. 그래서 그런 의미에서 작년 메가마인드 대회 참가는 어떻게 보면 저한테 굉장히 큰 인생의 터닝 포인트였고 굉장히 소중한 경험이었다고 생각을 합니다.
And thank you for listening to my presentation.
작년 7월 콘티넨탈 리그가 워낙 쟁쟁했었고 개인적으로 생각하기에는 저보다 뛰어난 발표를 하신 분들이 정말 많았어요. 네, 그래서 결과 발표 직전까지도 즐기자라는 마인드 위주였지 제가 한국 대표로 파이널 라운드에 갈 거라고 솔직히 기대하진 않았습니다. 그래도 돌이켜서 생각을 해본다면 치료를 진행하는 과정 속에서 제가 스텝 바이 스텝으로 얼마나 많은 고민을 했었는지 그리고 여러 가지 논문들을 근거로 최대한 에비던스 베이스드로 진료를 진행했다는 점을 어필했던 부분들을 심사위원들께서 좀 좋게 봐주시지 않았나 생각이 들어요. 작년 메가마인드는 참가만 하면 $300 상금을 주신다고 하길래 단지 그 이유 하나만으로 참가했습니다. 제가 한국 대표로 튀르키예에 갈 거라고는 당시에 전혀 생각도 기대도 하지 않았어요. 그런데 발표 준비 과정 속에서 과연 나의 한계는 어디까지일까 시험해보고 싶은 욕심도 조금씩 생기더라고요. 그렇게 차근차근 단계를 밟다 보니 감사하게도 좋은 결과를 얻을 수 있었던 것 같습니다. 다만 마지막에 최종 포디움에 들지 못했던 아쉬움이 계속 맴드는 건 어쩔 수 없었는지 24년도에도 재도전해보고 싶다는 마음이 남았어요. 비록 제가 다른 경쟁자들에 비해 나이가 어린 편이고 또 진료 경험도 길지는 않지만 저처럼 젊은 임상가들도 충분히 세계 무대에서 경쟁력이 있다는 걸 보여주고 싶었습니다. 그래서 올해는 목표를 최대한 높게 잡아서 최종 우승을 목표로 재도전을 해보고자 합니다. 저는 보철과 전문의로서의 강점이 있기 때문에 수술 외적인 부분의 임플란트 보철 임상에 대해 보다 심도 있는 이야기를 할 수 있지 않을까 생각합니다. 그래서 올해 경연에서도 보철적인 부분에 보다 집중을 하고자 하고요. 구체적인 내용은 스포일러가 될 수 있기 때문에 여기까지만 얘기를 하겠습니다. 저의 주제와 강연을 기대해주세요. Unlock your potential, test your mind, Megamind.
I'm Rudy Garana, a 38-year-old periodontist here in Bryanston, South Africa. Having been born and raised in this vibrant country, my academic journey started at the University of the Witwatersrand, located also in Johannesburg. I then decided to specialize in periodontics at the same institution, and thereafter moved into Bryanston, where I opened up my private practice, and I've been here since 2018. So beyond the routine responsibilities of a periodontist, I harbor a profound interest in implant dentistry. Additionally, I've developed a keen enthusiasm in dental photography and videography, which complement my professional endeavors. Outside of my practice, I'm a keen wildlife photographer, at least a striving photographer, a hobby that aligns perfectly with the unparalleled beauty and diversity of the African landscape. Being able to make a real difference in people's lives is really what life's about. If we've got the power and therefore the responsibility to take care of others, it's kind of the ultimate win, isn't it? Every day I get to do exactly that in my practice. I get to change lives, improve people's lives with a team that believe in me, a team that support me. And it's a journey that we go through one patient at a time. And it's something that I'm really grateful for. Why have I decided to lecture on this topic at the Megamind competition? Well, I feel very strongly about immediacy in the world today. Time is precious, and scientific advancements enable us to offer quicker treatments to our patients. I believe it's our responsibility to provide this benefit whenever possible. My 4 years with Megagen have been extremely fruitful, and I've had the opportunity to really get to know the Megagen ethos and their DNA, and immediacy forms a strong part of that. Their commitment to innovation and swift solutions has truly empowered me to meet my patients' needs more effectively and probably make me a better periodontist. I'd like to thank my team and my family back in South Africa for their unwavering support. Thank you. Unlock your potential. Test your mind. Megamind.
Once I started doing more implant dentistry, I built a really wonderful relationship with my patients. Usually, even the most nervous patient, after having gone through implant dentistry with me, they're okay with anything. That relationship becomes to almost like a friend and a trusted advisor. They take my recommendation on things like, seeing their doctors and nutrition, so that relationship goes up to another level. So that was something I did not anticipate, but that was an added benefit and makes me motivated to continue doing implant dentistry.
What inspires you? Unlock your potential. Test your mind. We are Megamind.
In North America, where we practice dentistry a certain way, Megamind opens it up to the entire world. And it's not necessarily associated with a particular regulatory body. It's not the AAID or it's not the ICOI where they're trying to say, hey, we're a regulation body. But no, it's dentists who really love and passionate about their work and gathering together and sharing. So I think Megamind is just the perfect name. My goal is to go far in the competition, but my expectation is to enjoy myself and to challenge myself, just to have fun and learn from all the other clinicians that are part of this competition together, and perhaps to be part of the community. I don't expect much, but my goal is to make it to the end if I can.
철강 도시, 불과 비수의 도시, 경북 포항에서 32년 동안 치과 의사로 살고 있는 강석기입니다. 메가마인드 도전자 중에서 현재 한국에서 제가 가장 연장자인 걸로 알고 있지만 나이는 숫자에 불과합니다. 마음과 생각이 젊고 임상 현장에서의 도전 의식은 젊은 연자들 못지 않다고 자부합니다. 저는 철인 3종 경기를 하고 있기 때문에 체력에서도 자신 있습니다. 때마침 글로벌 연자 발굴 프로젝트에 대해서 제 멘토이신 박광범 원장님이 추천하고 자극을 주셔서 오랜 시간 자부심을 가지고 치과에서 환자들에게 진행한 임상을 과연 잘하고 있는지, 그것이 글로벌한 진료인지 점검해 보기 위해 또한 좀 더 나의 발전을 위해 출사표를 던지게 되었습니다. (39년) 동안 한 길만 걸어오시고 대한민국뿐만 아니라 세계 치과계에 커다란 영향을 주신 박광범 원장님을 존경합니다. 치의학 발전에도 크게 기여하셨고 많은 제자들을 길러내셨고 그 열정이 39년 동안 식지 않고 한결같이 이어진다는 사실입니다. 이런 모습에 자극을 받아 저도 글로벌 연자 발굴 프로젝트 메가마인드에 이번에 과감히 도전하게 되었습니다. 치과가 어렵다고 조급하게 생각하지 마시고 치과 인생은 길으니까 부단히 노력하고 공부하십시오. 오랜 기간 동안 치과 의사로서 잘 유지하려면 일단 건강해야 합니다. 건강하려면 평생 운동하세요. 치과 분위기와 선생님들의 인생이 달라질 겁니다. 모든 분야에서 준비된 강석기, 꼭 최종 리그에 진출하고 싶습니다. 열심히 준비하겠습니다. Unlock your potential, test your mind, Megamind.
A lot of what I've done so far has really fulfilled my dreams. I've always wanted to work in implantology and not so much in the rest dentistry, and I've sort of achieved that. I've always wanted to be involved in teaching and have achieved that as well. But there's always a desire to do more and to learn more as well. There's still so much more to learn. My name is Yusuf Al-Shafi. I'm a dentist that graduated in 2007 from King's College London. I live in London with my family, 3 boys, so a bit of a handful. So I started this practice in Beaconsfield, which is just outside London. It's a small market town, and it's been great here. I'm still here 15 years later, and I've never really looked back. I think it's been an amazing career so far. I really enjoy what I do. Yeah, especially now with my focus now in implantology and oral surgery. It's just getting better and better. So I've been working with Megamind UK for about 8 or 9 years. You know, more recently I was involved with some teaching for them as well, and you know, when they introduced me to Megamind and they sort of spoke to me about Megamind, I thought this was a great concept. I was quite excited for the challenge, to be honest. But it's been a tough one, you know, to sort of see very experienced colleagues from around the world, you know, showcasing their work, and also sort of pushes you to improve your game, improve what you're able to achieve. And that's been the best thing about it, helping me to get better as well. Of course, with Megamind, you know, we're all in it to win, I think, and that will be the aim. But just the experience and just being on stage with these very experienced colleagues, you know, is an achievement in itself, and you know, for that I'm really grateful.
surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water, found my fate because I don't wanna be stuck in the...
So, hello, my name is Evina and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, after one painful and as she said very expensive appointment, she looked at me at the baby and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy, and I'm grateful for my mother because I love what I'm doing.
So I went down to the water, found my fate because I don't...
And what I'm doing if I'm not working, so I love food very much, and also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water, and I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and I can be a top expert and still live and enjoy life. I think that Megamind is not just a competition. Yes, it's a competition and the winning is not a goal. I think that the most important thing that we are together and we are sharing ideas and creating that big, strong community. So how I'm feeling? I'm happy. I think I'm happy.
Oh no, you ain't seen nothing yet.
Hello, my name is Kika. You can call me Dr. Joyce. Since childhood, I have a dream of becoming a dentist because my mother bring me to hospital and I saw the dentist is so kind. I want to be like her. I graduated as a dentist in 2016 and subsequently worked at a government hospital for 2 years. After 4 years of performing dental implants, I graduated last year with a specialization in oral surgery and implantology. I attend the seminar and symposium in every year for treating to my patient because I want to help my patient in even better. Currently, I am working at Tung Song Hospital in Nakhon Si Thammarat province and at a private clinic in Hat Yai district. I believe that a professional dentist is one who combines both scientific knowledge and artistic skill to treat each patient uniquely. It's not only about having excellent treatment skills, but also about showing empathy and learning new techniques and knowledge to achieve the best result for patients. When I help a patient, it makes me happy because I see that I help them bite better and feel more confident with their smile. It's like with friends and family where we wish each other well and want them to be happy in their life. Even if we are just a small part of their journey, this alone brings us joy. I want everyone to see that a university in the south of Thailand can effectively handle complex cases. It also allows me to undertake new challenges that I have never encountered before, providing valuable experience. I believe Thailand offers freedom because female dentists can work alongside male dentists. My colleague is so kind and everyone helped me. I am getting married soon. My partner is someone who cares deeply about every detail of my life. He supports me in my work and career, listens attentively to my concerns, and is aware that to help. I am grateful for his presence and how he completes me. I'm pleased to have him by my side.
메가마인드 뉴스를 전해드립니다. 최근 한국에서 주목해야 할 인물이 메가마인드 도전장을 내밀어 화제가 되고 있습니다. 한국의 유명한 가수이자 프로듀서인 박진영과 이름이 동일해 주최 측에 혼란을 불러온 인물이기도 한데요. 제3회 메가마인드가 주목하는 한국의 도전장, 박진영 연세대 교수를 소개하겠습니다. 안녕하세요. 연세대학교 치주과 교수 박진영입니다. 메가마인드 주최 측의 관심과 환영을 받아 더 좋은 발표 자료를 만들기 위해 노력하고 있습니다. 저는 치주과 의사이자 또 한편으로는 연구자인데요. 임상적인 결과뿐만 아니라 환자와 술자의 편의성을 증대시키는 좋은 진료를 하기 위해 노력하고 있고요. 학문적인 기반을 제시하고 구축하기 위한 공부도 꾸준히 열심히 하고 있습니다. 저 같은 젊은 임상가들이 평소에 쌓아온 진료 경험에 대해 발표하고 토론할 수 있는 기회가 아주 많지는 않습니다. 그래서 이런 좋은 자리와 국제적인 무대는 일단 너무 좋은 기회인 것 같고요. 제가 경험을 얻고 배우는 한편 또 다른 분들에게 이런 자극과 아이디어를 심어줄 수 있다는 점에서도 매력적이라고 생각합니다. 사실 작년에도 참가했다가 워낙 쟁쟁하신 분들이 많아서 떨어졌는데요. 올해는 두 번째 도전인 만큼 더 잘 준비해서 꼭 좋은 결과 얻고 싶습니다. 저는 진료를 하면서 연구도 병행하고 있기 때문에 임상에서의 맹점들에 대해 좀 더 분석하고 파헤쳐 봄으로써 여러 사람들이 들었을 때 도움이 되면서도 재미있는 발표를 하면 좋지 않을까 생각합니다. 최종 목표는 이제 한국 내셔널 리그에서 우승자로 선발돼서 국제적인 무대 경험을 쌓아보는 것입니다. 더불어 이제 세계 각지에서 저와 비슷한 생각을 가진 임상가나 연구자들을 만날 수 있다면 역시 너무 즐거운 일이자 큰 행운일 것 같습니다. Unlock your potential. Test your mind. Megamind.
My name is Domingo, and I'm a general dentist in Lafayette, Louisiana. I graduated from dental school in 2007. Upon completion of my residency program, I applied for a 2-year implantology fellowship with Brookdale Hospital in conjunction with NYU. I always felt the need to come back to the city that helped raise me. After practicing for 6 years, I eventually moved back to Lafayette, and that's where I've been for the past 12 years now. I practice as a general dentist. My practice is mostly limited to implants. We do have a referral-based practice where more difficult cases that require, I do most of the surgical aspect, start out with the prosthetic aspect, and in that, I've developed the Louisiana Dental Implant Lab that helps support me. So we're a full digital lab. We do take some analog cases, but that's like my playground.
No, I don't want a picture. I don't want a picture.
I want you to meet my wife. Yeah. This is my wife, Megan Domingo.
Hi, how are you?
Currently, she runs operations for the dental lab and all 13 employees that we have here.
So close.
How's it that your husband is your boss?
I'm the boss.
Oh, you're the boss. You're the boss.
I have a motto for myself: work smarter, not harder. You know, in my small community, it's you know, we only have 150,000 people. Isn't as big as, you know, New York City where I used to practice. Patients here can't afford $30,000 treatment plans. So my goal in this was to help be able to lower my overhead expense by having a digital lab. So being able to provide the best level of care for the least amount of out-of-pocket for the patients as possible and giving them a wow factor at the end of their treatment plan. It looks good. Yeah, this could use it. When I was in residency, my mentors were the guys that lecture around the world. You know, I looked up to them and I thought, you know, one day I want to give back to the younger generation. So as soon as I got out of a residency program, I wanted to lecture immediately. But I was so young, the sales reps wouldn't let me lecture for their companies. So I documented my cases, and I was showing them things that I was doing, and that's kind of helped me get some speaking engagements.
It's important to understand how to get a patient in from the 2D world into the 3D world.
And once the surgery is performed, we'll convert our digital wax up.
League America. Dr. Denny Domingo, United States of America.
21 of the best clinicians that I think are some of world-renowned clinicians, and me, just a general dentist in a small town, which sounds intimidating, to be honest. I'm expecting the best clinicians in the world to present their best cases on a very big stage. I'm gonna do the best that I can. I had a mission in life to do the best for others, and God really has a purpose for me. Creating that purpose and showing him what was possible for me.
Everybody, we're going to start. We're going to start. Everybody, good lunch. Now, this is where we have to watch out for, you know, with all the food and nice warm tea. And we'll start to find few of you start to do what we call the Asian nodding, you know, oh, I'm falling asleep, you know, how you doing? Yes, yes, right, nodding here. Okay, so get yourself some coffee and then we're gonna start. Okay, so bracket C, the third group. The first contestant that will be giving us the presentation, he represents the country Italy. He obtained Masters of Science in Oral Surgery from University of Milan. He also received PhD in Clinical Research from University of Milan. A highly decorated clinician, his presentation is titled One-Time Rehabilitation, iGen Technique versus Sausage Technique. Let's welcome Dr. Matia Manfredini.
Thank you. Thank you. Hello, everyone. I'm Matia Manfredini from the University of Milan. I'm honored to participate to the final competition of Megamind 2024. The topic that we are going to address today, as Mark told us, is iGen versus sausage in one-time rehabilitation. By one-time rehabilitation, I mean place the implants and do the reconstruction at the same time. I will begin with this picture. This is the dream of every implantologist. Good, native, well-vascularized, well-mineralized bone around our implants. But actually, dreams are sometimes hard to come true. And this is what we are going to see in our everyday clinical practice, and literature is confirming us that 50 to 60% of the implant requires a guided bone reconstruction. And the most common condition is enough bone to place the implant and to stabilize the implant, but not enough to completely cover it. And literature again is telling us that we need desperately bone around our rehabilitation. It doesn't matter how big is the atrophy, we can move from dehiscencies like these ones, from vertical reconstruction to maxillary big atrophies, but we need to give at least, especially in the buccal aspect, 2 millimeters of buccal bone in order to have a stable and reliable results over time. Well, if this is the condition and 60% of the implant requires GBR, it means that GBR is something that should be in the hand of every surgeon and every implantologist. And if we see a condition like this one and we check literature, the most common way that clinicians used to perform GBR is a simple membrane placed over a graft. But let's check, is this condition sufficient to perform GBR? Is this something that is stable over time? Well, the answer, my friends, is no. Because due to pressure of the sutures, pressure of the muscles in the healing phase, and due to gravity, especially if we talk about the mandible, we have a collapse of the graft in an apical position. And if this graft is dislocated in the apical position, well, we have a problem. And the problem is that this is what we want, and this is what we get. And again, literature is telling us that this is stable, this is not. If we have this kind of condition, usually our rehabilitation ends to resorption and then recession. And think about this. We are talking about the buccal aspect, the aesthetic one, okay? Especially if we talk about the anterior area. And if we have recession, I think that more than a dream, that's a nightmare. So the issue that we are going to address today is how can we recreate the correct buccal angle, and how can we provide a subcrestal position of the implant even in the critical buccal aspect? Well, the two techniques, there's other techniques, but the two techniques that we're going to analyzed today are fixture, one-time rehabilitation plus IGEN, and fixer plus sausage. And by sausage, I mean collagen resorbable membrane, but fixed with pins. And we're going to see why. Well, literature is giving us results in the two-time rehabilitation where we perform the guided bone reconstruction and then we do the implant placement. And analyzing the two techniques, the native collagen membrane and the tie mesh, literature is telling us that talking about a radiological point of view and checking the preoperative dimension, the postoperative dimension with CT scan, and the 6 months follow-up before the implant placement stage, the two techniques are quite comparable. If we analyze in this study, RCT on 10 cases, the histological results, again, bone area quite similar, residual particle quite similar, and marrow spaces quite similar. So if we go in a scientific background, we can say that these results makes the two techniques not statistically different, okay? And if we analyze the complication rate, well, here there is a difference. Of course, tie mesh suffers more about an exposure problem, and that makes the titanium mesh technique a more sensitive technique in the hands of the clinician. So the two techniques, two-stage approach, are comparable in terms of results by a radiological and an histological point of view, but titanium mesh is considered by now a more sensitive technique. But which is the best option? Well, if we talk about one-time rehabilitation, actually, the results in the literature are quite poor. So let's try to figure it out. Take into consideration the sausage technique before. As I told you before, sausage technique is performed with pins. Pins are mandatory. Fix our membranes is mandatory because we need to push the graft and to give stability to the clot in order to have a good outcome. And this is a study performed on poor animals where they made the defect, they place a graft and a collagen membrane, a graft and pins and a block, and they sutures, just sutures, no muscles action, no gravity here considered, and they check the results after the sutures with CT scan. Well, if we do not fix the membrane, at the end of the procedures, just the surgical procedure, we lose almost 50% of our reconstruction, and this is not something that is acceptable by now. So we need to fix the membrane, and if we fix the membrane, we lose 20%. So we need to consider also the collapse of the 20%, even if the membrane is fixed. Let's move to the technique. Let's see it in a clinical case. This is an occlusal view, and you can see the defect right here, an horizontal defect. The defect is confirmed also with the CT scan, where we can see that we have enough bone to stabilize the implant, especially in the posterior area, and in the premolar area, enough bone to stabilize the implant, and again, 60% of the cases not to completely cover it. So we decided to treat it in the, with the sausage technique. A mid-crestal incision, release the lingual flap, and the buccal flap is fundamental in every kind of guided bone reconstruction procedure. The flap should overlap in order to be correctly passivated. We harvest the bone, we place the implant. If you want to do it guided, do it guided. If you want to do it freehand, please try to do it prosthetically driven. And you have weapon to do it correctly. Place pins every time that you change the burr in order to check the position. Place a pathfinder in order to check the ending position of the implant. Then we can perform corticotomy, especially in the mandible, in order to provide blood supply to our graft. We mix 50% autogenous, 50% autogenous with a bit of hyaluronic acid in order to promote a more stable clot inside the graft. We fix the membrane on the lingual, we fix the membrane on the buccal aspect, and we push it as coronal as possible. As every kind of guided surgery, the suture is always the same, a double layer suture, horizontal matrices in order to let the connective tissue be in contact, and single dots. After 4 months, we perform a CBCT because we had to rehabilitate the other side of the patient's mandible. And we can see that we have 3.4 millimeters at the implant shoulder in the medial implant, and 2.9. So let's move to the iGen system. iGen was produced by Megagen, and there are studies to simplify the surgical procedure and reduce the cost. They were studied and published in the first prospective pilot study by me and the University of Milan team in 2020 on 8 cases, and now we are going to publish the results of the first prospective study on 25. They are quite simple to use. You place the implant. Of course, we are talking about one-time rehabilitation, so you need to place the implant and to have enough bone to stabilize it. iGen is fixed to the implant, so you need implants that gives you primary stability. We place a flat abutment that moves the system to a bone level and not over it in order to avoid exposure of the mesh. Then you place the graft, and then you can place your titanium mesh. Pre-shaped titanium mesh fixed with an healing cap to the flat abutment. You can also provide a transmucosal healing, if you wish, with special healing abutments. So this is a case treated inside this protocol, where again you can see the horizontal contraction. And again, we have enough bone to stabilize the implant, but we have an implant deficiency, 60% of the cases. The implant is stable enough. We place the implant as deep as necessary in order to have the correct supracrestal tissue height during the healing phase. We can fix the mesh simply to the flat abutment, and we move the system at the bone level and not over it. Otherwise, this healing cap gave pressure to the tissue and we can have exposure. So this is a iGen B2, and this is the RX post-op, where you can see that the implant is placed subcrestally, but the iGen and the mesh is fixed at the bone level. This is the CBCT after 6 months, and if you check in more detail, we have our buccal angle. We recreate a standard anatomy of the mandible in that area, and we have a subcrestal position of the implant even in the critical buccal aspect. Reopening stage. Simple envelope flap. Remove the healing cap. You see a pseudoperiosteum type 1, and you do not need to remove it because it's something that provides blood supply and nutriments to our reconstruction. It's easily, if we have this kind of pseudoperiosteum, also if you want to increment the soft tissue, to place a CTG at the time of the reopening. And here you go, the supracrestal tissue height established. Conditioned by the provisional, and we are ready to deliver the definitive restoration. You can see the provisional. You can check the final rehab after 1 year and the soft tissue maturation after 3 years follow-up. Soft tissue is stable. Let's check if also the bone is stable. This is the 6 months provisional rehabilitation, 1 year follow-up, and 3 years follow-up. So let's compare the results of these two techniques, because we had 25 cases treated with iGen in one-time rehabilitation and 26 cases, both approved by an ethical committee from the University of Milan. So we can take the results of each study, compare them, and check which technique is the best in order to promote a buccal angle. If we talk about marginal bone resorption, no big difference. If you talk about probing depth, no big difference. Also in bleeding on probing and keratinized mucosa, little better results with the hygiene, but nothing that is statistically significant. But here the thing that we wanted to know. Hygiene is a more predictable way to treat bone deficiencies in terms of buccal angle and augmented buccal bone. And this is statistically significant with a p minor than 0.5. So let's get to the conclusion. If we compare one-time rehabilitation flexure plus hygiene, one-time rehabilitation flexure plus sausage, of course we need implant stability if we talk about hygiene, because hygiene is fixed to the implant. Instead, with the sausage, we can delay it if we want. The number of surgical procedures is higher in the hygiene, because if we want to increment the keratinized mucosa, we need to do another surgery. Hygiene is non-resorbable, is more indicated for non-self-contained defect. It has a higher exposure risk, so it's a more sensitive technique in the hands of the surgeon. Sausage is more indicated for more than 2 teeth bone defect. And if we talk about buccal angle, hygiene is better and it's more predictable, and also for a subcrestal buccal position. Future research is something that should be in the head of every researcher, and these studies bring us the attention on how to improve the system, and how to improve the system could be to use higher Crove screw acting as a tending screw for the sausage, and fixing the hygiene mesh if the anatomy do not suit the hygiene shape. Thank you for your attention.
Thank you very much. Okay. Perfect timing. Okay. All right. The next presenter represents Slovakia. He's a graduate of University of Pavlo Joseph Safarik Kosce. I don't know if I'm pronouncing it all correct. And received his master's in oral surgery and implantology from Danube Private University. The title of his presentation is 15 Minutes That Might Change Your View on Daily Implantology. Let's welcome Dr. Maros Kopaka. Did I do it right? Close enough? Okay.
Close.
Let's welcome. Thank you.
Okay. Good afternoon, ladies and gentlemen. Let's imagine everybody inside this room have one missing tooth, just single tooth gap, no less, no more. According to research, 50% from all of you need bone augmentation right now. There's no written about the exception of dentists. We are also patients. Which material, which technique would you like to get inside your body as a patient? Will be artificial material coming from animals or chemical industry? Or would you prefer your own material, your own cells, antigens, your own immune system? Guess, what advices did I get when I started with augmentative surgeries? Come on, man, do GBR. That's the least invasive method. Okay, sounds cool. Why not to try it? Come on, man, forget on bone. Take care about soft tissues. That's the key. Sounds differently. Why not to try it? But wait for the best one. It should be done immediately, right now. That's super helpful for each patient who doesn't have the tooth anymore, right? Please, don't get me wrong. I fully respect GBR, soft tissue management, immediacy, and all other fields of dental implantology. It takes its place in recent dental implant treatment. There's no doubt about it. But there is no universal pill, no universal medicine solving all problems of missing tissues in dental implant treatment. And that's the beauty of our job. Agree? Ladies and gentlemen, please fasten your seatbelts. There's not going to be a romantic story today. My name is Dr. Maros Kopaka. I came from Slovakia, Europe, and today I'd like to show you how does the most of my patients look like. And they look exactly like this. What do you think? Disaster, right? There is thin crest, there are missing teeth, already healed crest, so no chance to place implant immediately. There is thin biotype. There is shallow or even no vestibule. There is also muscle pull from the cheek. Everything's wrong. When we took X-rays, there is no doubt about it. We need to think about doing something with bone volume there. In 2/3 of the crest, we need to do something with it. So it's time to start to think about bone augmentation. Please look at this picture. There are two different worlds, two different places close to each other. One, the place which is very poor in bone, and second one on the other side, very close to it, which is very rich in bone. Actually, that's the most important, most attractive harvesting site from all intraoral harvesting sites at all for intraoral bone augmentations. It's called retromolar area. I always like autogenous augmentations because it gives me feeling like Robin Hood. Still the same story. Taken from the rich and given to the poor. Again and again and again. We'll grow again. So, let's describe our playground. That's retromolar area or external oblique line, as I mentioned. No worries, there are very few rules we have to keep to stay on safe side. First of all, we have to project the occlusal plane to the anterior border of the ramus, and that's the most distal point of our preparation. From that point, we go deep down perpendicularly to the occlusal plane, and that's the border between mandibular body and mandibular ramus. We don't want to cross that line, cross that border. Otherwise, we go closer to the nerve, inferior oval nerve and both vessels. We don't want to injure them, of course. Then we have to keep free of preparation at least 5 mm from the base of mandible and from the mental foramen. The rest is created by convexity of anatomical structure. It's balconel-like structure, external oblique line. It's not a secret, I love piezo. I use one straight and two curved piezo tips, surgical hammer, and surgical chisel. That's it. Let's show it clinically. So I usually start with horizontal crestal bone cut with straight piezo tip, no pressure and sufficient coolant. Then I continue with distal vertical bone cut with angled piezo tip, again sufficient coolant and no pressure. And now comes the time to slow down, to think and to measure. We created also the most distal border which shouldn't be crossed, and from that point we can enlarge our preparation mesially till we want, till we need. It's very easy to scrub the whole case by harvesting a tiny bit smaller bone block than we really need. It happened to me. It's not a secret. So after we have to harvest at least 20% bigger bone block than we really need to avoid it. So after estimation, proper dimensions of future bone block, we can continue with preparation. And we're closing the preparation with mesial vertical bone cut with angled piezo tip, with sufficient coolant and no pressure. And then horizontal apical bone cut. Again, angled piezo tip, no pressure and coolant. Now we got predetermined fraction lines. So now comes the time to bring a little bit more drama into the operatory. And it's time to take our hammer and with few energetic hits on the chisel, we can break the rest of connection between mandibular body and the bone block. That's the way how we got the situation. Look at this, please. Now I'm going to ask you very few questions. Is there open sponges bone? Come on, wake up. No, So please, don't try to ask me about invasivity of this procedure. It's optimal invasive. Is it painful? No, it's not. The whole procedure was done under infiltration anesthesia, and even after the procedure, patient doesn't have any pain. Why? It's not a secret. We all know it. Cortical bone doesn't have any sensitive nerves. Will be missing there the bone volume? No, will not. It will rise again exactly like a grass on your backyard. So, isn't it beautiful? I found it. Here is everything what we really need for the whole case, for the whole bone augmentation. We don't need membranes, we don't need pins, we don't need antibiotics or mixing with antibiotics. We need just this one bone block, no more. Because it's quite thick, it's time to split it, to thin it. I use for that step diamond-coated disc, very thin and very flexible, with sufficient coolant. And in that way, we got these two beautiful bone plates. These bone plates are even next source of our future gold, future bone chips. So we can thin them even out with bone scraper and collect all bone chips, all gold inside bone scraper. Immediately after it, they go inside the bowel, surgical bowel, under sterile saline solution to protect them against drying out. After giving a proper shape to our bone plate, we have to fix it. We have to create some stable situation. It has to be stable. We don't want a resorption. So it's time to fix it. I use for that step 1 millimeter screws in diameter in different lengths, of course. And we create container. Just a frame. Please look at this picture. Now I'm going to ask you again. What's the most important here? Is it the residual bone? No. Microscrews? No. The bone plate? No. It is the space in between, because that space will change into new baby bone even after 4 months. Because that space has to be filled up with all collected bone chips. Then we need, of course, some hermetical closure, tension-free closure. I use for that step double-layered closure, as our colleague and friend mentioned already. First layer done with horizontal mattress sutures, then single interrupted sutures over it to get contact surface to surface. And we all know, it's not surprising for you, every single bone augmentation destroys vestibule. No doubt about it. So my next step is creating new vestibule, together, done simultaneously with implants placement. So we can see here no sign of vestibule. And I continue with Kazengenplasty. Kazengenplasty means doing it means separation, non-keratinized mucosa from muscles underneath. Then cutting all muscle fibers away from the periosteum. And of course, we don't need more that screws, micro screws. Okay, ladies and gentlemen, I'd like to introduce you new baby bone, just in 4 months. It was not an issue to produce 3 holes for 3 implants. I used Megagen enriched implants, and then I sutured periosteum to periosteum at the top of the crest, and non-keratinized mucosa to periosteum deep down in new vestibule. The healing was super fast. Even after 2 weeks, we got this beautiful result. So we have now bone, we have implants, we have attached mucosa, we have vestibule. And what's missing here? I drive Porsche, I don't drive Vespa. I'm not satisfied with the result. We need keratinized tissue. So again, Robin Hood style, I stole a piece of tissue from the heart plate. I modified it with vertical cuts. It allowed me to stretch it from the canine to wisdom tooth. And I sutured it to the naked periosteum, got rid of muscles with modified horizontal matrix sutures according to Professor Gluckman. And here's the result just after 2 weeks of initial healing. This is the result after maturation of soft tissues. So we have now bone, we have implants, we have attached mucosa, we have keratinization, we have sufficient height and width of the soft tissues. So we can continue with prosthetic phase. In prosthetic phase, I chose 3 multi-unit abutments. I placed over them scan bodies. This is X-ray fit and check. Took a scan. We sent all data to the lab, and they produced the bridge, and in between was patient wearing this protective caps. So here is full zirconia bridge coming from the lab, and the bridge was fixed to multi-unit abutments then. So, ladies and gentlemen, now prosthetic and surgical phase is over, and I'm going to ask you something with what we began. Would you rather sell pieces of animals in bone substitutes, membranes, or would you rather sell your skills, your experience, your knowledge? It's up to you, you decide. But I'd like to encourage you, this is the most forgiving technique at all. You can start, even on Monday, with the same or even better results than here. Thank you for having me here, but I'd like to mention one more thing. The most important thing is not to take apart, it is to win, of course. That's the reason why we are here. But I already won. I already won this beautiful wife sitting over there and this amazing princess. Thank you, honey.
I don't know if I should thank you or blame you. Now I got to go back home and take out my old block kit back out again, okay? That's the beauty about implant dentistry. You know, my mentor taught me, Mark, you will go through your career of learning, and sometimes you'll come back in a circle, you know? And there's more than one ways to sell your ship, right? Yeah, I think that's the wonderful thing about it. Okay, thank you so much for enlightening presentation. You know what's amazing? The level of documentation this year. I think I was talking with Jordy. I think the level of documentation, the photography and everything, just one level up. It's amazing. It's just amazing. And we all know that the harder thing is to stop in the middle of the surgery, take your gloves out, take the photo, and put a glove back in. That's the only way to do it, right? We all done it. And that takes a lot of discipline. And I'm very impressed with everybody's documentation. I certainly enjoyed the high level of documentation presented by Dr. Maros. Yeah. Next speaker, okay. Next speaker represents her country, Thailand. She has received master's degree in oral maxillofacial surgery from the Prince of Songkhla University, Thailand. She's a newlywed, so congratulations. Congratulations, everybody. Yeah. So this is almost like honeymoon in France. This is one of my favorite topics, complication management. The title is Corrective Strategies in Severely Aesthetic Dental Implant Complication. Let's welcome Dr. Kanika Burikananchan from Thailand. I messed up the last name again. I'm so sorry.
Thank you. Good afternoon, everyone. I'm Dr. Kanika Murikansan from Thailand. Today, I'm very glad to see you all here in Megamind 2024, and I would like to thank my next Megamind for this great opportunity to bring me the final round. First, I would like to thank Professor Nalit, Dr. Umaporn, Dr. Kongkiat, and myself for treatment this patient together at Prince of Songkhla University in Thailand. Today, my topic is corrective strategy in severe aesthetic dental implant complication. This is my patient. He is 28 years old. His chief complaint is long tooth appearance and gingival recession. He denied medical disease and no drug allergy. When he smiles, the smile line is average smile line. This picture shows intraoral and radiographic examination. You can see long tooth appearance and loss of dental papilla between tooth 11 and 21 correspond to radiographic examination. This picture presents implant malposition in more mesio-angulation of tooth 11 and unequal platform of tooth 11 and 21. Next, CBCT shows malposition implant in axial and sagittal view. You can see the red line show the malposition implant in more facial position of both teeth, and tooth 21 to shallow implant malposition. But it should be the green line show the right implant position. In summary of this case, the problem lists are 1. Long tooth appearance, 2. Loss of dental papilla at the midline, and 3. Aura bone deficits. That can be diagnosed as severe malposition implant and hard and soft tissue deficits. Then we will plan in the following step. 1. Explant of both teeth. 2. Aura augmentation. 3. Implant placement at tooth 11 and 21. And 4. Soft tissue augmentation. Let's get operation 1. We explant tooth 11 by reverse torque and another one by elevation technique. After that, we close the socket orifice with the suture and insert denture temporarily to my patient. Follow up 2 months, you can see the tooth 11 and tooth 21 present the horizontal and vertical bone loss, especially the midline of the anterior ridge. First of all, I would like to brief a short introduction about implant aesthetic hierarchy. It emphasizes that aesthetic success is not only about depend on restoration itself, but also the underlying support includes site development, implant placement, soft tissue form that support the aesthetic and functional success of the restoration. Before bone performing augmentation, we should analyze aura defect before treatment plan. Based on Allen classification, he was classified aura defect in 3 types. Type A, apicoronal bone loss, Type B, buccolingual bone loss, and Type C, combined A and B. Moreover, he introduced a classification with subgroups to indicate the severity of crestal alteration in millimeter in 3 levels: mild, moderate, and severe defect, more than 6 mm. Finally, we summarize our bone defect analysis table for help us to treatment plan decision. For this case, this case is a severe vertical defect and moderate horizontal defect, especially at the midline of the upper anterior ridge. Normally, aura bone augmentation have 4 major techniques. 1. Osteotomy technique. 2. Guided bone regeneration. 3. Bone block grafting. And 4. Distraction osteogenesis. But normally, the guided bone regeneration and bone block grafting are commonly used in the bone augmentation in dentistry. A systematic review from Dr. Trost et al. Show that aura augmentation with particulate material can be achieved maximum was 3.7 mm in vertical and horizontal bone augmentation. But if you want more than 3.7 mm, you can augment vertical augment with titanium reinforced or titanium matte.
Why bone block provides significant more than 5.8 millimeter due to the deeper integration through clipping substitution. A study from Dr. Merton et al. Showed that vertical bone gain was significantly higher when they used iliac bone graft were placed outside the bone contour. Because iliac bone graft is autogenous bone, it has three major characteristics: 1. Osteogenesis, 2. Osteoinduction, and 3. osteoconduction. Moreover, we should consider about the distance from the interproximal bone peak to the contact point of the final restoration that can support IDP in the future. From a study of Chanel, he found that this distance is 3.4 millimeter can be expected to the cover inter-implant crest bone. Another study from Bowen et al. Showed that 1 millimeter ulnar bone height loss after iliac bone graft augmentation, and after that 3 months, the implant placement and follow-up last visit record in the 5 months, he found that 0.6 millimeter bone resorption after follow-up. And the study concluded that the bone protective effect of implants without implant only bone graft resorption almost 100%. And they found that implant survival was 97.5% in 5 years. From the previous study, we select the iliac bone graft case for vertical and horizontal augment for this case. Let's get operation 2. We design the trapezoidal flap for iliac bone augmentation. You can see the midline of upper anterior rib present the vertical defect was 8 millimeter. This is a big problem of this case. We need to augment it for regenerate interproximal bone cleft for support the IDP. We harvest the iliac bone graft of my patient inside bone height 23 millimeter and bone width 20 millimeter. Before the placement of bone graft, we prepare the recipient site with partial decorticated and place the iliac bone graft as you can see in the picture and stabilize iliac bone graft with microscope. After that, we harvest the cancellous bone graft from iliac augment to the palatal side of my patient and close with collagen membrane, releasing fat and suture in everything. This CBCT shows immediate post-op after iliac bone graft. You can see the iliac bone graft like a J shape that I mentioned before. And follow up 2 weeks, no wound dehiscence and moderate swelling. Follow up 4 months after iliac bone graft, you can see this area present the high mucosal attachment at the upper anterior wrist. We decide to vestibuloplasty with mucoderm for repositioning high mucosal attachment to the vestibule position. And follow up 8 weeks. This time to implant placement, follow up 6 months after iliac bone graft. We plan the implant following the final restoration. We use the Straumann bone level taper diameter 4.1 millimeter in length 10 millimeter. After that, the flap was elevated. You can see the left picture show the iliac bone graft resorption at the tooth 11 labial side, and we place the implant following the treatment plan. And we create the alveolar scallop for the final restoration by bone lamping technique. After that, we augment with GBR technique to compensate the iliac bone graft resorption. This immediate post-op shows the implant placement and simultaneous GBR. You can see the interproximal bone graft that we regenerated it for support the ITP in the future. And follow up 2 weeks, the wound present the slightly dehiscent at the upper anterior rib, and we not do anything at this time. We follow up 6 weeks and remove the extrude bone particle. And we waiting until the soft tissue complete healing. You can see this area lack of keratinized tissue and soft tissue dimping in this area. We design to the paracrestal triangular flap. This is a partial thickness flap for soft tissue augmentation. We harvest the soft tissue from the palate of my patient with an epithelium band and connective tissue. After that, we place the epithelium band close to the palatal flap and place the connective tissue at the labial of tooth 11 and 21. After that, we close in everything. And follow-up treatment, you can see the picture show high mucosal attachment. We decide to the vestibuloplasty with mucoderm again. And follow-up 8 weeks post-vestibuloplasty. The contour is good, present keratinized tissue and no high mucosal attachment. This time, to modify state 2 with provisional crown, we create the paracrestal flap and split the finger flap for the create the interdental papilla of distal side of tooth 11 and 21. And we suture this finger flap to the palatal flap and insert the temporary crown. This picture shows final impression. You can see the good Imogen profile, and we insert the final crown. We use the screw retain zirconia crown on variovates abutment. This picture compares pre-treatment, post-treatment 2021, and post-treatment 2024. You can see everything look good, and especially the interproximal bone peak that we regenerated it is stable. Conclusion, for me, strategic consideration include 1. Need to have tissue reconstruction for implant placement and support soft tissue are important. 2. Implant position must be accurate in 3D dimensional. And 3. Once the implant was placed, the soft tissue must be managed to ensure the proper contour and natural health to support the final restoration. If we plan all aspects out well, the final restoration became much easier, leading to the long-term success of implant. Thank you. ขอบคุณค่ะ
I have an honest question to ask all of you guys. One of the challenge last year was that a lot of the finalists who came to present ran out of good cases because they used up on the second round. You know, because you got this dilemma. If you save your best case for the final round, if you don't get chosen to go to final round, then you get to waste that. Remember we talked about it? So a lot of the strategy, okay, you know what, they end up using their best case during the continental round, just so that you make it to the final round. And then once you go to final round, oh my God, I made it. I'm going to say, but I don't have the good case anymore. But you know what I'm talking about, right? Yeah. But this year, something different happened. You guys saved for the best for the last. I truly believe that you all saved your best game for the last. You know, I'm so amazed. I'm so amazed. Now I have a dilemma. You got me go back to a block graft, which I haven't done since 8 years ago. Now Kika is going to get me to go back to my garage and pull out my hip graft kit, which I haven't done for, last time I went to the hip was 15 years ago. Okay, yeah. So, you know, it's almost like a going back, you know. It's amazing results. One of the most significant clinical case I've seen. So I'm thoroughly impressed. Okay, yeah. Next presenter represents his country, Poland. He's one of the leading speakers in the field of digital dentistry. And his topic today is one of the most sought after. The title is Partial Extraction Therapy versus Standard Approach. What should be a 21st century standard. I'm very excited. Okay, everybody, let's give a warm welcome.
Thank you very much. It's very tough to put everything together in the 15 minutes, but partial extraction therapy versus a standard approach. What is the 21st century standard? I will show you the journey since 4 years and the last 2 Megaminds when I always focus on the partial extraction therapy, especially that I do it guided. So once we plan to extract the tooth, we should choose a treatment. So with high predictability of success outcome to meet the patient expectation and the low risk of complication. So it's this kind of motto which we should all know and we should think about it. So when we do something, especially in digital world, we can plan everything. We can plan when we extract and how we extract. Because the clinical results of dimensional bone and soft tissue alteration post-extraction aesthetic sites from Chavascus, we know after 8 weeks after extraction, we will lose 62% of the bone or 7.5 millimeters. It's a huge amount what we lose after we extract the tooth. So there are some strategies which we can implement in our daily practice to get the best result. From the evidence-based perspective, there are 4 strategies which we know there are valid to do it. So the first strategy is that what we actually didn't want to do nowadays is to extract and to wait. So we lose the volume, but we have to graft it with the GBR, we have to do soft tissue augmentation. Second one is extract graft with immediate implant placement, dual zone therapy from Professor Tanov, what we very good know. Third one is extract and graft with implant placement like veneer graft. So these techniques are well known for all of us. And the fourth one nowadays is a partial extraction therapy that should be considered as evidence-based. I will show you why and why it is a fourth option, which for me is the first way to go. In aesthetic zone, from the premolars to the premolars in upper jaw, this is the best way to go for me with the results which I want to show you. So the guided partial extraction therapies, what I do in my daily practice in aesthetic zone if it's possible. So starting from the literature point of view, Howard Gluckman, we all know how he is the extraordinary dentist. What we know that after they have a retrospective study with almost 4 years follow-up, they have 96.1% of the success. It's a very good result, which you all know, because sometimes we lose the implants because it's the nature of the implantology. So another thing, from the Charles Schimmer, the very well-known studies that's unplanned socket shield done, they remove it with the root. And what they did, they make a histology evaluation, and there is the clue of it. The clue of the success that we have between the implant and the root, we have the bone formation. So that's what we want. We want to have our implant in the native bone. We don't want to have in any augmentation materials which can lead to some kind of the complication in the future. So we want to have it a native bone. Another thing is, we know now what are the socket shield parameters. So there are 2 things that are non-negotiable and negotiable. So the C shape of the shield, line angel to angel, that requires to intact class 1 bone. Custom healing abduction of provisional crown, especially in aesthetic zone, is the standard nowadays. No mobility of the shield. Create the S-curve for the future prosthetics. Remove the apex and all of the RCT material. No periodontal diseases. No fracture of the shield. That is a must. What we can consider of some changes, and due to the different case selections, we have a fill the jump gap with the bone. We have to all take off care that it's not a xenograft. It should be autologous or allogenic bone if it's available in your country. Implant depth at the base of the S-curve, so we go deeper with the implant, and we go with our shield a bit below. Avoid touching of the shield. It's possible, as I said, depends on the case selection. Shield preparation on the bone level or subcrestally. 2 millimeters of minimum shield thickness depends on the case too. and 2/3 of the buccal sheet should be remain. So my case for today is the gentleman who came to our office with the situation of the mobility of the central incisors. There is a frenulum with a spool effect. On the right lateral incisor, there was a tooth extraction, there's a breach. On the left one, we have the root canal treated teeth, so we decided to place 2 implants and make to the breach on the placement of the lateral incisors. And what we have to understand is how looks our position of the root in the bone and what we consider as a position of the implant. So in this case, first of all, I will always go with the first guide, because as my concepts of the partial extraction guided, it considers of the 2 guides. So the first guide is the plan to remove the apex, to remove the all endodontic material, and to have the size of the shield as we want to have here. So we always plan to go around 1 millimeter above the apex to remove everything what's possible. The second thing, after we knowing the anatomy, knowing the placement of the root, how it looks in the bone, we will know, thank you to the great group from Gluckman Institute, where we have to make our osteotomy, in which direction, because it's the thing which we sometimes forget, what the indication for the ostomy in which direction due to the depth placements of the root. So in this case, we have 2 implants. One is a native bone, and another one is placed more palatally, and there is a longer implant to gain primary stability. So, of course, before the surgery, my dental technicians prepare me the temporary bridge, which is a bit like a Maryland, because we have these hands which are amazing on the teeth which we are leaving. So I have the best possible prosthetic position. It's not movable because the holes are bigger. We start with very easy extraction, removing the mobile teeth. We remove the coronal part of our prepared further socket shield place. We make the flap rise additional to the place how we plan the surgery. We did the socket shield preparation, so we leave the labial aspects, we remove it, everything is done guided. We place a second guide where we place our implants. So in this case, 2 implants, very easy, very good positions according to our prosthetic position, and of course the smart pack. So if you go immediate loading without ostel, there is no way that you will have a success, because you need a guidance. And the guidance is to use the ostel, it's non-invasive method, and after that we can check what is the value on the ostel. 74 ISQ, it's more than enough in this case, because it's not single case, it's a breach case, so we can have a lower value of the ostels. We have lots of data where we can do different kind of the loading protocol. In this case, we can very surely go with the immediate loading. Another part is, as is a breach, we cannot prepare it before that is screw-retained. We have to cement it intraorally. There is no precision at all that it's possible to do. So in this case, temporary abutments with the hex. Why with the hex? Because with the hex, we have more engaging of the abutment to the implant. So we have a lower risk of the micro movement there, so we have a better stabilization. With suture, we deliver our temporary restoration. We leave the patient for around 6 months with it. After 6 months, we have removed our temporary. You did the intraoral scannings. We have a nice soft tissue outcome, especially the patient hasn't the best hygiene, but it's common to us. Not all people are taking care. We have a good volume of the tissue around the implants, and we deliver our final restoration. Our final restoration, this is the monolithic zirconia with the zero bone loss concept with the high polished surface from the soft tissue. This is how the patient looks in the mouth. This is the CBCT after 9 months. So here we have a presentation of our socket shield, which is present. Here we have the neighboring implant. And what is the best way to check how the tissue response, how the bones respond. There are the studies which are showing about the facial contour preservation anterior immediate single tooth replacement with the socket shield versus connective tissue. They make the scans and they superimpose both of them and they check it. So actually with the intraoral scanner in our daily practice, we can easily do the same. So I check before the removing of the teeth, so in the day before the surgery, the first scan, versus the scan with the implant and how it's changed. What we have, so day of the surgery, it was 9.9, 21 millimeters, and now 6 months later, we have 9.63. So it's a minimal change of the contour. So we are sure that it should be as a standard because we are not losing it, and this is a minimal invasive procedure. So what are advantages and disadvantages of the partial extraction therapy? Because we have to take it as a concept, so to say, both sides. So advantage is the minimal resorption of the labial bone of the soft tissue, require less grafting and soft tissue at the time of the implantation, and minimize trauma in difficult extraction cases. What are the disadvantages? New technique must be learned by the doctor. It's a learning curve, which we all know. Root shield must remain stable during and after procedure. That's always we are praying during this procedure. Must educate the lab technician regarding subgingival space and contours for provisionals, abutments, and final restoration. So after the journey of many years, I have lots of cases which I present in the previous Megamind, where are the extraordinary results from the treatment. For me, the partial extraction therapy is a standard in aesthetic zone to achieve very good results and the stable results in the future. And to make it very comfortable for the patient. As I always want to treat my patients as I would treat myself. So there is always this thing that I don't want to make super traumatized procedure. I don't want to push the treatment for the very long time. There are the CBCTs from the cases. Their average is 4 years of the implant placement. They are stable. There are no any issues with it. And there is a very, very good outcome result. For the home message, we have to think about our primary objective is to achieve long-term aesthetic stability of both of hard and the soft tissue that we want as the implantologist, that we want to have the best outcome and the healthy tissue which will be the stable. But what is our secondary goals? I think this is the clue. The least number of the surgical intervention, reduce open flap procedure, the least pain and mobility for the patient, the shortest overall treatment and healing time, the most cost-effective treatment. In my daily practice, the partial extraction therapy, doing guided, fits to all of these goals that we can give our patients best outcome, shortest treatments of the time. In most cases, it's a one surgery only. It's not 12 months of treatment, and very stable results. Because the trick with the partial extraction therapy is that when we're leaving the part of the root, it's tricking our brain. There is a still root, so there is no bone resorption. So we are taking the advantage of losing it, of leaving it, and we have to know that nowadays it's really evidence-based technique, starting from 1967 when there was the idea of leaving the tooth under the dentures. So with all of the studies from Howard Gluckman, the Matia's group, we can safely say that is evidence-based, that we can consider it as a technique next to the techniques which we know since many, many years. Ladies and gentlemen, thank you for your kind attention, and try do it guided.
Wonderful. I have to mention something. if there was a special award, he definitely should win it because he's the only one remaining contestant who has participated season 1 of a Megamind, which was in Korea, season 2, which was in Antalya, Turkey, and season 3, he's here. So I personally want to say congratulations, okay? Wonderful, wonderful. Okay. All right. So we have one more presentation before we take our break, okay? Yeah. The next contestant is a renowned periodontist from Johannesburg, South Africa. For the next 15 minutes, he is going to take us into his world of tissue regeneration. The title is Mimicking Nature in an Implant Dentistry. Let us welcome Dr. Rudi Karana from South Africa.
Good afternoon, ladies and gents. Just before we get started, I'd like to say thank you to MegaGen and the team behind Megamind. I think in a world where we all pulled apart, we need more events like this that brings the world together. So it's a big honor to be here, and I'd like to say thank you for this opportunity. Secondly, I'd just like to say thanks to my colleagues and mentors at the Implant Aesthetic Academy in Cape Town, Study Group 1. If you guys are watching, thank you very much. It means a lot, everything you've done for me. My role here today is not to show you a technique and tell you that this is the best. This is what you must use. This will win every case that you try. And I'm going to quote my colleague and mentor here. You need arrows in your quiver to win them. It's that person that can choose the best approach for that case that will win most battles. When we look at anterior aesthetic zone, the nature that we're trying to recreate, what is it that gives us this result? And it's not always the same thing. We need to do different things. Just like managing a football team, your tactic needs to be different to get the same result at the end of the day. So what's the formula? Well, it kind of depends what you're trying to achieve. I'm going to show you a series of 2 to 3 cases where we approach the cases differently to try and achieve the same ideal, natural result that we're looking for. Just like Mikhail, my colleague, spoke before, he spoke about everything about socket shield. Now I don't have to mention anything, thanks. That's okay. So in a single tooth replacement where there's a high aesthetic demand and the patient otherwise has a generally sound dentition, we want to look for a technique that's going to allow us to get as close to gold as possible. In a case like this, there's a failed apicectomy and it's a single tooth. There's only a little bit of bone. We know from Chapuis studies, Danny Booz's group, that in 85% of Caucasian patients, when you extract an anterior tooth, you will lose 100% of the buccal plate because of the bundle bone makes up the bulk of that bone. And so we opted for socket shield. I also utilize the Versa technique and the Versa burrs to osteodensify the site because not 100% of my implant is sitting in native bone when we're doing immediates. And so I want to osteodensify, and it helps me get that primary stability that we need. This is very, very important, the distance of the implant shoulder to the shield. I want sufficient distance so that I can get collateral blood supply, so that I can actually have bone in that area. I want bone there. I graft the jump gap, And then I use the patient's own tooth as a provisional where I can, because I don't get a better provisional than that. And I use an index for that. Su et al. In 2010 spoke about critical and subcritical contours, and Gomez-Meda in 2021 followed up on that, talking about the biological and aesthetic zone. And this is the S-shaped curvature of your provisional. Your provisional is going to support the tissue around which you're going to get your aesthetic result. So this is the patient's original tooth. I've added some composite to build a connection onto the titanium cylinder, and I've seated it, and I've taken it out of the bite. Yes, it doesn't look great, but the patient's got a tooth. I want you guys just to follow. Look at where the gingival margin is in relation to the composite. And after healing, can you see how we've got gingival creep there? This is because we've got an optimal design of the provisional restoration, and the tissues are responding adequately. It's like holding a plastic bag with water in. You put pressure on that plastic bag, it molds around your hand. This is what the soft tissue is going to do as well. We then can scan the original tooth with our scanner. We can get very fancy now. We can do just almost anything these days with digital dentistry. And we can manufacture an almost identical provisional to place into that site. And that's the provision. This is a provisional restoration, by the way. I don't do any of my own final restorations. I work as a referring practice. So this case is now ready to refer back and restore at my restorative colleagues. What about adjacent teeth? Two adjacent teeth, high smile line, demanding patient. What are we going to do here? Well, in these anterior aesthetic zones, there is, to my knowledge, there is no technique that will allow us to preserve 100% of the buccal bone after tooth extraction besides partial extraction therapy. And so once again, if I can manage to utilize the remaining root, and I can foresee that I'm going to be able to place the implants in an ideal position so that socket shield is the way to go, then that's what I want. Here we had to do a apicectomy bilaterally as well, get rid of the infection. We placed, and after we provisionalized, that is the result, and this is 3 years later. That amount of buccal bone, at least in my hands, is possible because we are preserving bundle bone and that very, very thin buccal plate. What happens if we can't use the shield? Because I have cases, I have patients that come and now we can't do a socket shield. Well, not all is lost. We need to remember to look at the case as a whole. In this case, certainly, we opted to do some clinical crown lengthening. The patient was hesitant to do a lot of treatment. The patient came to me and wanted a single tooth restoration. She needed crown lengthening, and she needed 2 crowns. It was difficult to get the patient there. I couldn't carry out socket shield, and I opted for surgical veneer graft. And this has proven, at least in my practice, to be a very predictable approach as well to these cases where we need some augmentation, almost to preempt the inevitable cascade of physiologic events that will follow tooth extraction. And this is where we land up. A lot of this result depends on us getting the emergence profile of the crown correct. And a much happier patient ready for final restoration. Now, what about when we get complete loss of tissue? I'll send it to one of my friends over here. These guys all know how to do this. Just want to run away. This is a young 23-year-old patient that had her lateral extracted somewhere, and she came to me for an opinion after they said they can't place an implant there. And I said, well, they're right. You can't, not at this stage. The other problem is that we've got teeth without bone on either side. This doesn't give us a lot of hope. Have a look at the CBCT slices. We don't have a lot of buccal bone here. We've got nothing over here, very little over here, and nothing interproximally. I opted to extract those teeth because I couldn't predictably and reproducibly graft that area with avascular root surfaces on either side. But now we're left with a massive defect. Tough one, tough one. Just want to run away. Just to give us an idea of what we had to achieve is, and I like doing this often, is I just mimic what's happening on the other side and I try and draw it in, and it kind of gives me an idea, kind of guides me as to what I'm actually missing and what I'm trying to achieve here, because it speaks to the kind of techniques that I want to incorporate. And obviously in my mind I'm thinking curry plate, and I'm thinking this, and I'm thinking that, and you know, curry plate, yeah, that's the way to go. And I take a CBCT, and guess what? She just actually doesn't have bone. Nobody ever speaks about that, you know. I want to do it, but what when there's no bone? So I did something a little bit unconventional. I used GBR using OSSX membrane lasso technique as described by Neve et al. Although this is for fenestrations, not for massive grafts like this, but this is what we had to work with. Grafted, and after grafting, can you see how we are already starting to head into the right direction? We're not anywhere close to where we want to be, but at least we headed there. The next thing that I wanted to do was I wanted to place the implants, and I wanted to do some soft tissue augmentation as well. So I incorporated the VIP-CT graft described by Misha et al. In 1999 and modified by Dennis Tarnow the following year, where he described this tunneling underneath. And this will give us good tissue bulk in this area. And now we can start developing that site. So we went from this to that. No pink porcelain. Is it perfect? Not perfect. Are there things I'd change? Absolutely. I've been doing this 5 or 6 years. Every day I do it. I think I know less and less about implant dentistry. But we've given this patient her teeth back in the anterior aesthetic zone. We incorporated a lot of techniques by a lot of clever people, and we provided her with some kind of result that I was quite proud of. If we look at the cross section, good bone. Will it be like that in 10 years' time? Who knows? I hope so. Thank you. This is so in conclusion, thank you. In conclusion, I just want to say that I think you need to have lots of arrows in your quiver. Learn the techniques, have an open mind, see how other people do it, and try and choose the best approach for that case. Thank you again.
Thank you very much. Wonderful presentation. I think that takes us to the end of the third group. I think everybody deserves a little bit of a break here. Yeah. You know, when we thought that by the time we were breaking for lunch, I was talking with my board of directors, the judge, because I don't think it can get any better. And we were wrong. It's getting, You know, when we thought that, we were all surprised that here we are. You know, it's a wonderful presentation, and you know, keeps me humble once again. We're gonna take a little bit of a break, everybody. Okay, so let's come back. When do we come back? Okay, the last group starts at 3:35. Okay, 3:35, everybody. Thank you.
Hello, my name is Dr. James Cadigan. I graduated from dental school at the University of Manitoba in 2009. I moved to Vancouver and I bought a practice in Richmond. So I worked with both my parents. It was by design that I became a dentist because both my parents were dentists. It was pretty hard to resist the draw of a life that I really understood well. One of the things that my dad really loved doing was dentures, whether they're complete or partial dentures, and that is the complete opposite of most dentists in my experience. But I understood very early that if you're going to put implants in someone's mouth, you should know where the teeth go first. Implant dentistry and surgery in particular is kind of an exciting, it requires all of your attention. Apply yourself. You have to really prepare. That, for me, really engages me as a human.
Hi, guys. She's a dentist, so she's a terrible patient. And what? She's going to tell me how to do my sinus lift.
No, I'm not doing any sinus lift.
Now, hush.
My mom has always been my champion. My mom would say, don't wish your life away. You know, you're always thinking, next year's going to be easier. Next year, I'm going to have this thing paid off. Or next year, I'm going to do things differently. And realistically, next year is going to be more complicated. Next year is not going to be any easier. Okay, I'm ready to make the next step in my career.
Each competition is composed of 15-minute clinical case or research presentations.
Okay, so you can see down here that lower left 38, this is our 6-year follow.
Yeah, Megamind, it pushes you out of your comfort zone. And as much as you were sweating and as much as it was stressful, when you go back and you look at the ultimate result, you have grown. And so my goal for myself is that I'm gonna find some personal growth. And having those moments where it's not just about teaching other dentists, it's about teaching your patients, and you know, it is about a legacy. And what do you leave behind?
Surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water, found my faith because I don't wanna be stuck in the...
So, hello, my name is Evina and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, after one painful and, as she said, very expensive appointment, she looked at me, at the baby, and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy. I'm happy and I'm grateful for my mother because I love what I'm doing.
You ain't seen nothing yet. So I went down to the water, found my faith because I don't.
And what I'm doing if I'm not working, so I love food very much. And also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water. And I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and I can be a top expert and still live and enjoy life.
So I went down to the water, found my faith because I don't.
I think that Megamind is not just a competition. Yes, it's a competition and the winning is not a goal. I think that the most important thing that we are together and we are sharing ideas and creating that big, strong community. So how I'm feeling? I'm happy. I think I'm happy.
Oh no, you ain't seen nothing yet.
그날 되게 떨렸어요. 준비도 열심히 했고 그래서 좀 힘들었으니까 내가 돼야지, 내가 그 칸에 가야지 이런 생각을 갖고 들어왔었는데 이제 다른 선생님들 발표를 좀 듣다 보니까 오늘 많이 배워가야겠다라는 생각도 들고 실제로도 하루 종일 이제 앉아서 이제 20분 정도 이제 발표를 들으면서 되게 많이 배웠고요. 다들 너무 잘하셔가지고 사실 될 거라고 생각을 잘 못했습니다. 여기 서 보니까 정말 더 그날 기억이 다시 떠오르는 것 같습니다. 네. 저 빈 자리들에 앉아 계셨던 이제 교수님들, 다른 참가자분들 다 기억에 남는 것 같아요. 위너가 됐으면 좋겠다고 생각하고 왔는데 위너가 될 거라고는 생각을 못했습니다. 네. 솔직하게 진짜 될 거라고 생각을 못했어요. 그래서 발표가 났을 때 더 기분이 좋았던 것 같습니다. 네. 저희 부모님께 꼭 감사를 드리고 싶습니다. 저희 부모님은 이제 임상을 하신 지 한 30년 이상 되신 두 분 다 치과 의사세요. 그래서 제가 치과 의사가 되는데 롤 모델이 되어 주시기도 했고 제가 이제 치과 의사로 또 성장할 수 있도록 항상 지원을 아끼지 않아 주셔서 꼭 감사하다는 말씀을 드리고 싶습니다. 이번 그 메가마인드를 준비하면서 더 나은 치과 의사가 되기 위해서 더 많이 배워야 된다는 그런 깨달음을 얻게 됐고 환자를 위해서 더 좋은 진료를 하기 위해서 앞으로도 더 많이 공부하고 더 배우는 그런 치과 의사가 되고 싶습니다. 치과라는 분야 내에서도 배워야 되는 내용이 굉장히 무궁무진하다고 생각합니다. 임상 경험이나 지식들을 이제 공유하면 이제 세계적으로도 모두에게 윈윈이지 않을까 하는 생각에 조금 더 글로벌한 꿈을 꾸고 있습니다. 또 이제 제가 더 많이 아는 것은 더 또 나눌 수 있는 그런 연자가 돼야 되지 않을까라는 생각을 하고 있습니다. 이제 칸에서는 이제 또 새로운 주제로 이제 새로운 발표를 해야 되기 때문에 이제
Work for us, and her 2-4 was broken palatally.
Dr. Scott Jung,
because the buccal plate is primarily
Scott Jung, representing Canada.
Less than 20%, and reduction of sides with the concave.
Why? Because we have comprehensive
problems.
It was a fierce competition. 20 contestants from all over the world, and they are the best, and they're representing their nation and their continent, and they're competing against one another in order to make the final 6th spot.
Did you disappoint that statistics?
Yeah, of course. I mean, we go there in hopes of winning. I don't think anybody's there just to enjoy the time. They want to win, right? And that's the part of the competition. I understand that as a dentist, we're good at being a dentist, but we're not trained and skilled enough to become a good speaker. There are people who it comes naturally, but most of us needs training. And I found that going through the 2 years of Megamind really has trained me, gave me a hard training in speaking. Now I know how to speak better. I know how to present better. I know the last Megamind made me a better dentist who can serve my patients better. I'd like to start off my presentation with this particular picture.
League America, Dr. Scott Jung, Canada.
Oh, I'm hugely honored, and I'm very excited to make it to the final round of Megamind again. Megamind, to me, it means 2 things. Number 1 is a dojo training for speaking, trying to encourage, educate other dentists about the potential and the future of implant dentistry. And second is also a platform to meet other clinicians and share the ideas in order to advance our career and our profession. My mindset going into the final round is to shoot for gold. You want to win, and I'm giving my best to win.
I'm Nabil from Lebanon. I live in Batroun. It's a coastal town known for its beautiful sea, water sports, and stunning nearby mountains. I'm the co-founder and periodontist at Dentist Studio in Byblos, Lebanon. It's a private polyclinic. We are a team of 6 dental specialists, including my sister and my wife. Since I was a child, I wanted to be a doctor. I was inspired by my father, who is a doctor and my idol. And I also had a deep passion for technology. And it is during my residency years in periodontics at the St. Joseph University of Beirut where I discovered digital implantology, and I felt that this is the perfect blend of my interest with my dental career. Since graduating, I practiced prosthetic and implant dentistry, and then became instructor in guided surgery at the same university, and later managed the craniofacial research unit at the Craniofacial Research Laboratory at the same university. I also founded a guided surgery service and training services for other dental professionals. Balancing work and personal life is definitely a challenge. However, I make it a priority to spend some quality time with my family and engage in some outdoor sports activities like windsurfing, biking, and snowboarding. This allows me to recharge and stay focused and be more effective in my professional life. I'm grateful to the persons and colleagues that encouraged me to enter Megamind, since it is an opportunity for me to share my passion and the techniques that I've developed in digital implantology. I've collaborated on many scientific projects and studies, but I haven't yet shared some of the most impactful things that I've done with the broader community. So I think this is a chance for me to challenge myself, to learn from others, and to contribute to the ongoing evolution of the digital dentistry.
Yeah, right there.
Okay. Yeah, was it 10 more minutes? Okay. Oh, okay. I'm too early. All right. Okay, everybody. Okay, where is it? Okay, let me go through here. So we have the last bracket group, group 4. By the way, how's everybody doing? You okay? Yeah, I tell ya, I hate to be one of them, okay? Being judged, yeah. It's very, very difficult. It's just going to come down right down to the wire. And I'm not kidding. This is by far the highest level of a quality presentation, right? So far. And I'm not just saying it to make you guys feel good. Because Dr. Park, would you agree you were here last year, right? Yeah. Dr. Jung was last year as well. Yeah. And Mazurek, who's been doing for each year, the level goes higher and higher and higher. And some of you who became a MINEC Knight from a season 1, they were coming to me at the MINEC event. Goes, you know what, Dr. Kwon, I'm so lucky we went to the first year. Yeah, if it was this year, we would not make it, you know. And I was even talking with Professor Kwon. I said, you know what, if I were to enter competition next year, I will lose. I will lose. Okay, that's how good all you guys are. So I'm very, very, very proud of all of you. Okay, all right. We only have 5 more presenters left. Okay, yeah. But sometimes we save the best for the last, right? Yeah. Okay. So the next speaker obtained his master's degree in periodontics from St. Joseph University of Beirut. He has co-authored numerous international publications. By many, he is considered to be an expert in digital imaging and guided surgery. The title of the presentation today is Crafting the Optimal Workflow in Digital Implantology. Let's welcome Dr. Nabil Gosen, representing Lebanon.
Thank you. Good afternoon. I'm Nabil Gosen from Lebanon, and today we're going to be crafting the optimal workflow in digital implantology. So, I'm co-founder and periodontist at Dentist Studio in Byblos, and I'm also instructor and researcher at the St. Joseph University of Beirut. I come from Batroun. It's a coastal town known for its beautiful sea, outdoor sports, and stunning nearby mountains. But as I stand here with you today, my heart remains with my country, and I dedicate my efforts to my people who are suffering during this hard period of time. And I hope that you will have all a safer and more predictable future. These principles also apply to my work, as the predictability in implant placement and the safety for my patient are the 2 aspects that I value most in guided surgery. But beyond that, as a digital enthusiast, I truly enjoy the process of digital planning. And it is in every case that I try to learn something new, to explore new digital techniques, and to improve my workflow from one case to the next. That's why today we're going to dive into the world of digital planning. I'm going to present a case where it highlights some of the optimizations I've implemented in digital implantology over time. It's about a 72-year-old female who had no major health issues, but she needed a total rehabilitation of her mouth due to functional and aesthetic reasons. But she was afraid to do so and was hesitant. At the clinical exam, we see that she had a reverse smile line, a disrupted occlusal plane, teeth aggressions, deep bite, overjet, and many other problems. As a first step, we extracted the teeth that was causing pain and infection for the patient. And then the patient went for a few months and didn't go back. But when she got back, after a few months, she told me, I've struggled with my teeth for so long, and I'm finally ready to get a new smile that makes me feel good again. Will it be possible to make that happen? So, in order to answer my patient, I had to do first the virtual prosthetic design. I did so by taking jaw scans and smile face scan with the Medit i700 and an extraoral full face scan with a Bellet 3D face scanner. And now we aligned all these models based on anterior teeth geometry and also based on nasal geometry in order to have the intraoral models aligned to the extraoral face scan. But now, if we look closer at this scan, and especially at the quality of mesh in the smile area, we see that it lacks depth and definition. And studies have shown that even high-end extraoral scanners still struggle from capturing accurately this area. And it's not recommended to do anterior digital smile design by using these face scans. But when I compare this quality of mesh, of this mesh, compared to the smile face scan with the Medit i700, I see that the latter has much more details in it. And because already these two models were already aligned in the previous step, so I thought, why not combine both and adapt the full face scan to the smile face scan in this area. And like this, instead of having this non-optimized face scan, we will have a more optimized face scan where it shows the relationship between the teeth and the lips and will be more suitable for the anterior digital smile design. So now that I have this model ready, I can create face guides in order to do my virtual prosthetic setup. And this is a great communication tool to show the patient and to explain to her what we can do with the treatment. And now that we know our roadmap for the treatment plan, we will have to create our optimal virtual patient by adding hard tissue data to it. And this is done by taking a CBCT and aligning it to the intraoral scan model. But as we see in this case, we have in this model a non-reliable zone for alignment in the posterior area and a reliable but small zone in the anterior area. And in those cases, it is recommended to do an alignment device in order to accurately superimpose the CBCT data to the intraoral scan data. And some of the devices are called EvoBite or R2Tray. And that's why I've introduced in my previous presentations what I call the DAD, or the Digital Alignment Device. It's a device that is fully digitally designed. And by that, it's aligned by default to the intraoral model. So its advantages that we don't need to print a physical model or to mount this device with silicone material on the jaw model or to take a desktop scan in order to register its relationship with the jaw. So we simply have to print this device, add the radio-opaque markers in their design position, place it in mouse, and take the CBCT with it. And we will have to simply now superimpose these two models based on the markers. And like this, we will have a good superimposition of the intraoral scan with the CBCT. Now that we have our superimposition, we uploaded this CBCT scan to a validated AI segmentation platform, which is the Urrutia. And we performed our AI segmentation. And with several software manipulations and software tools, we created what I call the optimal virtual patient model. This model features every single anatomical structure as its own entity. So we have now the bone with the extraction sockets, the teeth, which are created by a combination of the AI segmentation and intraoral scans, and the gum as a solid model with the teeth indentations in place. So this will help me to manipulate each anatomical structure by its own, do seamless extractions to the case, show my wax up, do some gum manipulation, and then many other advantages we will see in the design phase. So now that we have this complete model, we can now transfer it to our implant planning software, which is the R2Gate in this case. In the R2Gate, we placed our implants based on the virtual design that we created. And one important step in the digital planning of implant cases is the assessment of bone quality prior to the implant placement. And several studies have shown that with some CBCT calibration techniques, we can accurately predict this bone quality prior to the procedure. And one of these tools used is the Digital Eye tool inside the R2Gate software. However, the report differs if we have an implant placed in a healed socket or an implant placed in an immediate extraction case. Because in this case, the gray density values of the teeth will be included in the report. And on one hand, it will mask the available bone quantity in contact with the implant, and it will also misrepresent the measurements of bone quality assessment. That's why, in the first attempt to better assess the bone quantity in immediate extraction sites, we published last year a study where we made this assessment by measuring the potential bone implant contact in terms of square millimeter area. And like this, we could choose our optimal implant position, not just based on the implant dimensions, geometry, and depth of thread, but also on the remaining available bone volume after this virtual extraction. But now, it will remain to assess the bone quality in these sites. And I wanted to use the same digital eye tool in immediate extraction cases as in regular cases. So what we did is we took the segmented teeth from our optimal virtual patient model, we imported them to the 3D slicer software, and we applied a mask on the raw CBCT images in order to replace the gray density values of the teeth with that of airways, representing a virtual extraction on the raw CBCT images. And like that, I will not have this report anymore. I will have a more comprehensive report showing me for each site the potential bone to implant contact in every type of bone, along with the total potential bone to implant contact. And on the other hand, we have the bone density inside our drilling site, and like this, we can adjust our drilling protocol according to this report. And now I show you several sites in the same case where we see how we adjusted our drilling protocol based on this report of bone quality and quantity on the implant sites. So now that we've done with our digital planning, we will go to the guide design phase. And in the guide design phase, we used our optimal patient model to choose and create the guide support model for every step by doing selective extractions and by also manipulating the gum to simulate Frappli fractions. And like this, we also designed our temporary restorations based on the gum and bone anatomy. And as we see here, we've created an oval-shaped context in order to preserve the gum architecture after the immediate temporization. Now we can print our guides, and we can go to the surgical intervention. Now, because the patient was too sensitive and could not handle long procedure, we decided to split the surgery into 2 steps. So the first step, we placed the posterior implants for the upper and lower arch in a guided way. And in the second step, we extracted the remaining teeth, placed the anterior implants, and did our temporization. So here we see the second surgery in lower arch. This is the pin guide. After we placed our pin guide, we extract our implants, we placed our drilling guide, and then we drill and place our implants. And then we opened a small flap to do a small bone reduction in order to accommodate for the restorative space. And finally, we can see our printed temporary, the hybrid printed temporary, fixed with the fixation pins. As for the upper arch, it's the same way. So first we placed our pin guide, and then we extracted some of the teeth. We placed our second guide, we placed 4 implants, and then we extracted the remaining teeth, placed our multi-unit abutments with the temporary cinders, and did our temporization. So now we can see here the post-surgical x-rays immediately after the second surgery. And this is the soft tissue healing 3 months after the surgery. So we see that we have a good gum health and a good gingival architecture. And now it's time to take our digital impression. We took our digital impression for the upper and lower arch with the temps in place and without it. But in this case, we didn't do a regular intraoral scan body technique, but we used a modified reverse scan body technique, where we scanned these anterior bridges outside the mouth with the intraoral scanner, but instead of using the reverse scan body, we used regular digital analogs. So we modified the library in a way to switch the scan bodies with digital analogs. And depending on the studies
the previous studies done by this team, with this technique, we can achieve a higher accuracy from the intraoral scan body technique. Moreover, because soft tissue collapses immediately after we take out our provisional, scanning this temporary outside the mouth will help us restore this emergence profile from our temporary scan. And like this, we can design our definitive restorations based on the shape of the pontics of our temporaries. And here we can see the gingival scalloping after we remove our temporary restoration. And this is the final outcome, showing a good gingival architecture with an FP1 prosthesis in this anterior zone. I can show you now the X-rays 6 months after the implant placement, and also 15 months after the initial implant placement, which shows a good bone stability over this period of time. This is also a 1-year follow-up of the case. And what's important to us doctors is that we will have a happy, smiling, and satisfied patient at the end. Now that we've seen all those optimizations in the current case, can we say that this is truly the most efficient approach to use daily? So to answer that, I will have to show you the flow chart that outlines the current software, techniques, and workflow used here. As it seems a little bit complex and unpractical to use every day, it might serve as a proof of concept for future software development in order to implement these features in a more user-friendly solution. And thank you.
Well, thank you so much. Very impressive work. Very impressive work. You know, with all the AI and things, I don't know how far that digital we can push. Wow. Very impressive. Thank you for sharing all that. Okay, yeah. The next contestant is a board-certified specialist in prosthetics from Kyunghee University, South Korea. He is also the captain of medical officers in Korean Army. The title of his presentation today is Comprehensive Insights to Digital Prosthetic Workflow. Chances, Challenges, and the Limitations. Let us welcome Dr. Chan-young Park from South Korea.
Good afternoon, everyone. My name is Chan-young Park, and it's a great honor to present in this year's Megamind. I'm a prosthodontist from South Korea, also a husband, and a medical officer in the Korean Army. So perhaps the only person in this room who's serving for the military right now. Yes. So my topic today is about digital, which is a key paradigm in today's field of dentistry. But you should know that digital is not perfect. We are in the transitional period. So that is why we still rely on the combination of the digital and the conventional. So I felt the need to clarify the current status of the current digital prosthetic workflow in an evidence-based manner with some of my cases. So today I will discuss two aspects. First, the advantages and the challenges of the current digital prosthetic workflow. And second, what we should consider to minimize the errors for digital fabrication in everyday practices. So starting with the advantages and the challenges, digital simplifies lab procedures and reduces the chair time. And this is already proven in so many journals, including the systematic review, so nothing much to talk about. But we should consent to this. Digital allows a more comprehensive, restoration-driven diagnosis. And I think that the development of the 3D facial scans has played a major role in this, in both aesthetic aspect and the occlusal aspect. So if we take a look at the aesthetic aspect, when designing the optimal smile, it's clear that we should consider the patient's asymmetric facial features. And recent studies have given us some guidelines on this, such as when setting the dental midline, it should follow the patient's facial flow curve. And when setting the anterior occlusal plane, it should be parallel to the patient's commissure lip line as well. So this is where the digital would come in, because by using the 3D facial scans, prosthetic design respecting the patient's facial features would become possible. And next, if we look at the occlusal aspect, it is recent evidences support that using the anatomic landmarks from the 3D facial scans are reliable enough for setting the optimal occlusal plane for oral rehabilitations, and also setting the arbitrary hinge axis in case if the face bow mounting is needed. So for the occlusal plane, we would use the elytra goose line or the Camper's plane. And for the arbitrary hinge axis, we could use some known posterior reference points, such as the Bayron point, which is set according to the ear tragus, or the Bergstrom's point, which is set according to the Porion. So this is a case example which applies a digital diagnosis. Now, this patient visited our clinic hoping for overall prosthetic rehabilitation. And by the looks of the initial panoramic view, we could observe some hopeless teeth and implants on the posterior area. And by the looks of the initial intraoral photo, we could see some severe attrition, anterior crossbite, loss of posterior support, which indicated insufficient space for aesthetic restoration. So full mouth rehabilitation seemed to be needed for the treatment. And so since we had to secure enough space for restoration, the vertical dimension had to be elevated around 3 millimeters. And this newly established jaw relationship was digitized and superimposed to the patient's facial scan so that we could assemble the virtual patient. So for the next step, face bow mounting was done digitally. And so we used the Bayron point, 13 millimeter anterior from the posterior margin of the ear tragus as the hinge axis to realize the dynamic occlusion as close as possible. And the occlusal plane was set using the elytra goose line and the position of the retromolar pad, along with the average value of the anterior tooth exposure for the elder people. So using these settings, diagnostic wax-off was done with the 3D printed provisional crowns and dentures. And mutually protected occlusion was set as the virtual occlusal scheme, while checking the facial aesthetics so that the dental midline would follow the patient's banana-shaped facial flow curve, and so that the anterior occlusal plane should be set almost parallel to the commissure lip line. And this result was shared with the patient to optimize the expectations as well. So based on the wax-up, implant planning was done, leading to the guided implant surgeries with the initial mouth preparation. And the 3D printed crowns and the dentures were delivered to the patient with canine guidance in check. And not much occlusal adjustment was needed due to the design. And after 10 weeks of the osseous integration, we switched to the second provisional restorations, at which point we were now ready to fabricate the final prosthesis, checking that all the tissues were stable and fine. So final impression was taken on the abutment level with the cross mounting, and the casts were all digitized in a dual scanning manner so that we could design the final crowns respecting the morphology of the provisional crowns. So these are the finally fabricated zirconia crowns and the final dentures, and they were all delivered to the patient. And after 1 year, this photo was taken, and we could see that all those soft tissues, the crowns and the occlusal scheme, along with the peri-implant bones, were maintained without any problems. So overall, the patient regained confidence in smiling. Brief case example, which utilizes the digital diagnosis. So overall, using the digital tools may allow a more comprehensive provisionalization in many aspects, which will lead to more optimal prosthetic results. So what we've seen were the advantages, but the main problem of the current digital prosthetic workflow in implants is that its accuracy and indications are still unclear according to the most recent studies. And for the two most important conditions for the full digital prosthetic workflow would be the accurate digital impressions with accurate digitally fabricated cast. So let's take a look at what the current studies say about this. The in vitro studies of the scan body impressions suggest that their accuracy is already superior to the conventional impressions, but we should keep in mind that the actual intraoral conditions will undermine the scanning accuracy. So that is why we have to pay attention to the in vivo studies. And according to these studies, their accuracy is clinically acceptable for short span cases, according to studies, like single case or anterior partial arch cases, or short partial arch cases with distal free ends. But for long span or full arches, their accuracy is reported to be still unclear and controversial even with the use of various auxiliary scan aids. So this is still a challenge in today's digital dentistry. But on the bright side, the accuracy of the digitally fabricated cast for the prosthesis seemed to be within clinically acceptable range, regardless of the range of edentism. So, according to the evidences, the ideal indication for the full digital prosthetic workflow seems to be limited upon short span cases. So what does this mean? It means that digital is not perfect, so we have to take detailed care for every step that's associated with the prosthetic fabrication in digital. So let's take a look at what we should consider to minimize the errors in digital prosthetic fabrication. Now, this is a case example using a full digital workflow. Also, a story of a firefighter who suffered from a dental trauma with spontaneous pain with unaesthetic appearance on the maxillary central incisors. Now, by the looks of the initial examination, the two teeth seemed hopeless to be saved, so implantation seemed to be needed. So careful planning was done regarding the facial aesthetics. And restoration-driven planning done to fabricate the surgical guides, leading to the guided surgery. But the initial stability was not strong enough, so we waited for around 12 weeks for osseointegration. And after 12 weeks, digital scan body impressions were taken, perhaps the most crucial step in digital prosthetic fabrication. So what are the factors that we should consider for successful digital impressions? I think the answer is concentrating on the fundamentals. Scanning conditions, scanning strategy, and scan body choice, some things that we would miss in everyday practices. So first, if we look at the scanning condition, let's look at some evidences. The ambient lighting conditions is very important, and it seems to depend on the clinical situation, but the studies agree that regardless of the scanner types, the optimal accuracy seems to be achieved around 1,000 lux without the chair light. And it seems that compared to the triangulation scanners, confocal scanners are less affected by the ambient lighting. So this may be one of the criteria for choosing the most optimal scanner if digital impression has to be performed. And second, the ambient temperature. Some basic things, but changes in the surrounding temperatures of the scanners may undermine the scanning accuracy. So we should maintain stable temperature when scanning. And of course, scan surfaces have to be kept dry enough to minimize the needed reflections and to maximize the scanning accuracy. The next part is the scanning strategy and the optimal scanning distance. It is still unclear, still on the studies, but studies agree on one fact that too close scanning distances will cause oversaturation of the stitching of the data, which will cause distortion when they are converted to the mesh data. But if the distance is too long, it will undermine the ability to capture the reflected light from the scan surfaces. So it may be advisable to keep the scanning distance within these boundaries. And the scanning pattern. This will also vary among the scanner types and the clinical situations, whether it's mostly dentate or whether it's mostly edentulous with implants. And many studies have conducted researches on each clinical situation. So it may be advisable to adhere to the manufacturer's recommendation or the clinical evidences. And finally, the scan body choice. We usually use PEEK scan body or the titanium scan body for the material. And for the PEEK scan body, they are more easily scannable since there's no surface reflections. But the problem is that they are only recommended for single uses because they have some deformation issues, such as if repeated sterilization is done, or if excess torque is applied on the tissue. So for multiple uses, titanium may be the better choice for scanning, but they also have a problem because they have some surface reflections. So we should consider the pros and cons of each materials when the scanning is performed. And about the optimal geometry, they will also differ among each situation, but all the studies agree on one fact, that if they have too much sharp or complex structures, it may undermine the scanning accuracy because these structures may be distorted when converted to the mesh files, causing trouble in accurate matching with the library. And finally, the dimension. There's not much studies about the diameter, but there seems to be a certain pattern associated with the supramucosal height. Depending on the neighboring tissues, short length scan body may be more preferred on the dentate regions, while long length may be preferred on the edentulous regions. But up to now, there seems to be no difference in accuracy between 3 to 7 millimeters of the scan body height. So what I want to say is that optimal scanning strategy has to be based on the evidences. And so for this case, I used a peak scan body for single use. It was cylinder shaped with only 1 or 2 decut area for matching with the library. While hand torque was applied on the scan body so that we could prevent any unwanted deformation. And the scanning direction, it was set from occlusal, palatal to buccal direction with the zigzag pattern on the scan body area. So after scanning, interim PMMA crowns were fabricated and delivered to the patient, but we could still see some black triangle areas along with uneven gingival lines, so additional gingival recontouring was done to improve the pink aesthetics. And at this point, we could see intact gingival architectures without any inflammations, which meant that we were now ready to fabricate the final prosthesis. So for the next step, digital allows a more simplified process of transferring the subgingival contour because only the scanning and assembling the needed data on the single CAD software is mandatory. So this process will allow us to more simply design the final prosthesis, which respects the contour of the provisional crowns. So after designing the prosthesis, the customized abutments with the crowns were all fabricated, and they were fabricated without using any 3D printed cast. So you might ask a question. Is using cast-free workflow without the 3D printed cast would produce accurate results? Actually, there's no straight consensus about this issue, but limited evidences suggest that for very short span cases, cast-free workflow is reported to produce better prosthetic fit because they exclude the errors caused by the 3D printed cast. But the problem is that obviously pre-adjustment on the model is not possible, which may cause longer chairside adjustment time. So up to now, for longer span cases, 3D printed cast may still be mandatory. So regarding this, the customized abutments were delivered with using the PMMA prototype so that we could prevent any misfit caused by the rotational freedom of the internal hexagonal channels. And after checking that everything's fine, we switched to the zirconia crowns with the patient recovering his smile with the restorations. And after 1 year, all the soft tissues, the crowns, and the surrounding bones were maintained still very well. So overall, successful digital smile recovery was done. So it's time to wrap up our presentation. Digital allows a more comprehensive diagnosis in a restoration manner, and the indication for full digital prosthetic fabrication is expanding every day, but still limited for short span arch cases according to the evidences. And we should remember that digital itself is not the master key. So every clinical step must be done with detailed care. And I think the most important thing is that we should keep update our evidences on the issues about the digital. So these are the references, and thank you for listening.
Thank you for a wonderful presentation. Okay, coming right down to the wire now. All right. The next presenter is also from his country, South Korea. He is currently a prosthetics resident in the Faculty of Dentistry at Seoul National University. He came with his beloved fiancée, and I asked her, okay, what do you think? You think he's going to do well? Yeah. We'll see how he does. If he does well, she'll still marry him. I'm just kidding. I'm just kidding. I'm just kidding. This is how Dr. Kwon gets in trouble. You know what I'm saying? Yeah. Just a lighthearted joke here. Okay. Yeah. The title to this presentation is Details in Digital Implant Rehabilitation, the Key to Patient Satisfaction. Please welcome Dr. Jung Ju Kim from South Korea.
Okay, good afternoon, everyone, and thank you for inviting me to this amazing event. Thank you for giving me this chance to present my case in front of these wonderful audiences. Sorry, I need some help here. Okay, I'll move on right to my topic. Okay, that was a nice event again. Okay, so this is my second time in France, and the last time I visited France was 19 years ago. It was in the year 2005, September. And that's my family picture. And fortunately or unfortunately, all of them are now dentists with different majors. And I come from South Korea, the capital city, Seoul. It's a very nice city, so I really recommend you guys to visit here at least once. More the better. And this is my hospital where I work, Seoul National University Dental Hospital. This is my colleagues. I'm on the right. And then my name is Dr. Jung Ju Kim, and it's really nice to meet you guys. So back to my topic. My topic today is details in digital implant rehabilitation and the key to patient satisfaction. I'll first give you guys 3 keywords. First, be a good listener. Second, be the mastermind in your treatment process. And third, focus on the basics. My topic will focus on these 3 topics, these 3 keywords, and I'm presenting you before my presentation so that you guys can focus on these keywords. So the first case I want to present is, I titled it A Lifetime Smile. If this reminds you of Megamind, the quote, I think that's just a coincidence. And this is the initial panoramic radiograph when I met the patient. And guess what? This patient, he's only 32 years old, and he had suffered from lymphoma. Now his lymphoma stage it's in a stable stage, but he's still with his temporary prosthesis and haven't had his definitive prosthesis yet. And some of the patient details is that he lives 4 hours away from my hospital, so he has to come every 4 hours just to meet me. And moreover, he just got hired and got a new job, so he can now only come on Saturdays. And his first impression and aesthetics is the most important thing for him right now. And if we look at the problem list, first aesthetics, the temporary prosthesis with him right now has obviously a lot of problem. It has the expanded dental arch, and the crown length, it was too excessive, too big for the patient. And second, he had poor oral hygiene. He told me that it was difficult to brush his teeth because he was worried that the temporary prosthesis will fall out when he brushes. And every time the temporary prosthesis falls out, he needs to come to my hospital, and it takes 4 hours. And third, the problem list function. The temporary prostheses were always fragile, and it can easily fracture. And there was only 1 implant in the right maxillary posterior area, which was prone to fracture. So we set a treatment plan for him to place 2 new implants on right maxilla and remove the 2 exposed implants on the mandible and replace it with 3 implants besides it. This is the picture here. And however, the treatment for the mandible was postponed at patient's request. So we moved on to maxilla first, 2 implants on the right maxilla. It was neatly placed using a surgical guide. And we move on to the provisional prosthesis stage. We decided to reinforce the interim prosthesis using a resin fiber. It was because of the aesthetic issues, and because he was a young patient and he just got a new job, aesthetics was very important. And instead of using a metal wire, we instead using a resin fiber that was aesthetic and it looks like a tooth color. Provisional prostheses were delivered to the patient and it was made as a screw retain type. And the reason why I use screw retain type is because it does not use cements. The patient was always concerned of cement loss, and because this does not use cement, the patient does not have to worry of the temporary prosthesis falling out. And moreover, because this type of prosthesis, screw retain prosthesis, has more thickness of resin, it is more strong to fracture than the cementation type. Also, because now we can check if the patient can actually brush his teeth and get his oral hygiene maintained by changing to screw retain provisional prosthesis. So this is a provisional prosthesis delivered into the patient, and we still have the exposed implants on the mandible. However, we have a much more nice appearance of the patient here with just the provisional prosthesis. Now the patient's telling me that the other teeth look so nice, and now the exposed lower implants looks more noticeable, and now he wants to go on with the mandible surgery. And moreover, he told me that because he got a new job, he doesn't want to be without teeth after surgery. So I told him that using digital implant planning and guided surgery, we will fulfill your needs. So planning was done to remove the 2 exposed implants and replace it with 3 implants nearby and with immediate reloading. The immediate reloading was prepared based on the position of the patient's existing prosthesis, so the surgical guide was designed to make the same prosthesis again, and prefabrication of the provisional prosthesis attached to the temporary titanium cylinder was made before the surgery. So the implants were removed nicely, and the other implants were placed at the position as we planned. So what I did on the chair side was intraoral relining, and what we did on the lab side was finishing and polishing the temporary provisional prosthesis. So if we look at the pre-operation photo on the left and the post-operation photo on the right, the patient goes home with almost in a similar situation that he came to the clinic that day. We'll move on to the definitive prosthesis stage. First, the abutment selection. Let me remind you of the initial state of the patient. There are a lot of problems here, including that there was titanium and zirconia abutment with supragingival margin, and it was standing out, and we do not want this to happen again. And if we check the provisional state, the provisional restoration's crown length was very adequate when smiling, so we had to use pink porcelain or at least pink staining on the gingival side to represent the gingiva and reduce the crown length. This, in other words, means that we cannot use zirconia abutments on the anterior area, even though it can be very aesthetic. And that's why we decided to use anodized titanium abutment on the anterior area, and the articles reports that pink anodized abutments represent a good aesthetic alternative to zirconia hybrid abutments, especially in mechanically challenging situations, and it's much more better in aesthetics than the unanodized titanium abutments. So the anodized titanium abutments were selected in the anterior region for the patient. And we'll move on to the intraoral and facial scanning. A dentulous ridge was scanned, and it was scanned with the scan body once more, and the provisional bite registration was used so that the patient can keep on with his provisional bite and the vertical dimension that he had. And facial scanning was done, and the T-zone area drawn on the screen was used as the alignment region because this zone does not change as the patient, even though the patient's expression or facial expression changes. That T-zone stands still, so that's why we use this area as the alignment region. And for jaw motion tracking, and the jaw motion tracking was done before we do jaw motion tracking, recording mandibular movements in clinical situations. We have to make these attachments before we go into the clinic. And we have to check that there are no interference in lateral or protrusive movements, because if there's interference, it's going to definitely result in a wrong data, and it's going to extend your chair time. So we want to check this onward before we go into the clinic. And we have the digital face bow on the left and bite fork on the right. The bite fork was used to record the maxilla's position. And the patient's movement were recording the right lateral, left lateral, protrusion, and mouth opening in orders. So digital Facebook was done, and it was the prostheses were designed on the virtual articulator. And moving on to the digital smile design, I think this is a very important slide that I want to mention. This is very important because I think this is why we need to be mastermind in our treatment process. Digital is really good. It's going to give more information to the dental technicians, and it's going to help the dental technicians to make a good prosthesis. And I agree that good dental technicians can make good prosthesis. However, we need to give more information to them. It's because the dentists are the people who meet the patient for the most time. Dental technicians usually don't have the chance to meet the patient in face-to-face, so we have to give them the information needed. We have to give the impressions how the patient actually is, so that the good technicians can make better prosthesis. So we checked that the definitive prosthesis design was changed from the provisional state, and we checked the facial with the facial scanning data, and the definitive prosthesis were delivered. And this is a much nice impression compared to the initial state. So we have a facial appearance that looks much better, a facial profile better than the initial state, and the facial photo. And this is the last panoramic radiograph we have. And moving on to my second case, I titled it Rebuilding Smiles and subtitled What Only Implants Can Do. It was a 70-year-old lady. She came to our clinic to restore her missing teeth. The first treatment plan was maxillary complete denture and 2 implants on the mandible because we did not have much bone on the maxilla. So we made the complete denture in a traditional method. However, the patient refused to use the complete denture due to a severe gag reflex. The complete denture on the screen was never worn by the patient. So we had to revise the treatment plan with implant-supported fixed restoration in the maxilla too. So both lateral sinus augmentation and horizontal ridge augmentation in the anterior were planned. Moving on to the surgical phase. Lateral sinus augmentation was done, and this is a preoperative CT on the left and the right, and we have the panoramic radiograph. We don't have much bone, so we did lateral sinus augmentation. And if we look at the postoperative radiograph, I think we have enough bone right now for implant placement. And for horizontal ridge augmentation, we decided to do sausage technique for the anterior maxilla. This is a preoperative photo. We have the CBCT and the panoramic radiograph. We don't have much bone. Actually, this is a very hard situation, I guess. And since we had enough explanation of sausage technique today, it's immobilizing the collagen membrane using a titanium pin and bone graft material inside. So if we look at the preoperative photo, this is on the right and this is on the left. We only have about a millimeter thickness of bone. So we did sausage technique, postoperative photo on the right, and this is postoperative photo 2 months after the surgery. And after 6 months, we can realize that there are still bones remaining so that we can go on to implant placement. Digital implant planning was done. I usually make impression with individual tray for these kind of cases, especially like edentulous maxilla where we don't have any tooth, so that in these complete edentulous case, because I think the fit of the radiographic stent and the surgical guide depends on the impression quality. So digital implant planning was done for both posterior areas. It was done flapless. It was nicely done. And for the implant planning on the anterior area, we decided to place 6 implants, including the premolar areas. So the surgery was done again. It was done nicely. And this is the post-operative photograph. However, somebody might have noticed that we missed 1 implant. 1 implant fell into the sinus, and it was removed right after by my fellow surgeon, Dr. An. We removed the implant right away because there's going to be more complication if the implant stays in the maxillary sinus. So moving on to the restorative phase, we first make tentative vertical dimension registration, and we fabricated this bite jigs to set the accurate vertical dimension for the patient. And what I do before I go to the clinic in the lab site, I check that there's passive fit with non-hexagonal connection and that there's no interference with driver use. This is definitely going to save your chair time, and this must be done before you start your clinic. And I made a wax trim in the anterior area so that we can evaluate the preliminary aesthetics, facial aesthetics of the patient. So it was recorded, facial and internal scanning was done, and I thought that looking at the facial scanning data there, I thought that it was very over-prominent facial profile with a wax trim on. So I requested my dental technician the provisional prosthesis to be designed with a little bit of lingual shift. And we can see that the design was done with the lingual shift. And the provisional prosthesis was made with screw retain prosthesis. This is her provisional stage. However, there was a problem with the ponic on the central incisor area, so ponic-based modification was done. Waiting for the gingivas to be healed, and the gingiva was nicely healed, and we moved on to the definitive prosthesis stage. Intraoral scanning was done, and bite registration was once more done with the provisional prosthesis on, and facial scanning was once more done. And this is another slide that I request my dental technicians for switching and making modifications for the provisional design. I really think that this is a very important thing that we all must do when we request for a definitive prosthesis. This is the last chance that we can change, and this is what I think the dentist should really do. And these aesthetic factors, they're actually the fundamental aesthetic factors that are for most of the patients. I know that aesthetics can be very personal, but we have the fundamental basics. So this is, I think, why we need to stick onto the basics. Even though we use digital, digital is just a method, it's just a tool, and it cannot be something perfect without the dentist using it the right way. So definitive prostheses were made, and she now has a rebuilt smile. And to summarize my presentation, I gave you 3 keywords. First, be a good listener and give an individualized treatment for each and every patient. Every patient is different. Every patient is going to need different treatment, different prosthesis for them. And be the mastermind in the treatment process. We need to be in charge of what we do, and we need to know how it's going, and we need to give information so that technicians don't just give them the data and let them make anyways. They need more information for that. And stay true to the fundamental basics and principles, since digital is a tool, it's not a cure-all. And I want to especially thank my team of dental technicians. They did a very good job. They did a perfect job. I really thank their contribution. And my fellow doctors, they're my good old friends. They always were very helpful when I always had problems with the patients. And this is my mentor, Professor Jae-hyun Lee. He always gives me inspiration and motivation. I really thank him, and Professor Shiman Park for letting me use his digital devices. So thank you so much.
Wonderful presentation. Thank you so much. Thank you so much, Dr. Jung Kim. You know, I think one of the most underappreciated team members are the technicians. You know, we get all the glory and we get all the thank yous, but the technicians often gets, forgotten. So, what we should do is during the break, we should call our technicians and thank them, send them a text message, okay? Thank you very much. Okay, wonderful. Okay, so the next speaker represents his country, Kuwait. He has obtained his master's degree in prosthodontics. His presentation explores the integration of digital technology in planning and execution. The title is The Implants in the Aesthetic Area. Please welcome Dr. Ahmad Al-Anazi from Kuwait.
Hello, everyone. Good afternoon. Thank you all for staying up this late. My name is Ahmed Al-Anazi. I am from Kuwait, and I am very honored today to present to you a lecture about implant aesthetic. Just a little bit background about me. I graduated from Mohammed bin Rashid University. I did my prosthodontic training there. I am a prosthodontist in Kuwait Ministry of Health. I joined Harvard School of Dental Medicine to do implantology training there, and I'm currently a member of the Royal College of Surgeons in Prosthodontics. So Today's lecture is implant in the aesthetic area. And as we all know, implants have been extremely successful, both in the biological aspect as well as the mechanical aspect. But we often encounter a lot of complication, especially when it comes to the anterior aspect. And the reason for that is because either the restorative dentist or the surgeon did not implement special consideration. And I will show you in this presentation the consideration that we need to take into account when we plan those cases, as well as show you 2 cases where we implemented those considerations. So one of the first important consideration that we need to take into account is the peri-implant mucosal soft tissue. This is extremely important because you ideally want to have a disease-free environment. And if you have a peri-implant that's deficient, you need to know how to create it. And if you have a peri-implant soft tissue that's present, and it's before the tooth is extracted, you need to know how to keep it. The second one, as a prosthodontist, I should always think with an end of mind. So knowing your restorative design is also extremely important, knowing what type of material you're going to use, and whether you have enough restorative space for it or not. The third one is knowing your proper 3D position. Ideally, you should focus to be in a screw-retained fashion, but also you need to keep the biology in mind and know how much bone quality and quantity you have to begin with. And fourth is the abutment selection. Every abutment has its own indication. So some abutment are tie-based, some are custom abutment, and some are angulated. Each of these abutments will give you different indications and should be used in different cases. And fifth is the implant timing and the provisionalization timing. And as we all know, that implant, anterior immediate implant, produce a much better aesthetic result when you compare it to the healed site. And the reason for that is because we minimize the 3D shrinkage, both in the vertical and the horizontal aspect that undergoes during the healing. And the last one is the emergence profile. Ideally, your emergence profile also should be within 30 degrees, so you don't create an area where you accumulate food and then you develop perimucositis, and then periimplantitis, and possibly even have a bone loss. And I have this article that even supports from my program director, Dr. Herman Gallucci, that when you use a wider healing abutment during a micro-CT analysis, they found out that it negatively impacted the peri-implant mucosal width. Let's jump to the first case of the day. The patient is a female with high smile line, and she's very concerned about her aesthetic. And as you can see, she's missing the canine, and the case is already a complex case because it has a high smile line. So let's check the restorative space. We found out that the patient has good amount of restorative space, both in the vertical and the horizontal aspect. We checked the soft tissue characterization. The patient is having good keratinized tissue, height and width. The adjacent papilla are present. The mucogingival line is away from our flap design. There is no vertical deficiency, but there is a horizontal deficiency. And in order to be aesthetically pleasing and biologic, you need to correct this deficiency, as well as restore the patient with a tooth. And the best 2 ways to do that is either bone augmentation or soft tissue augmentation. And to find out on which technique you're going to use, we should put this in the virtual world and first design our restorative restoration. So we acquired all the data for this patient, and we put it in the implant planning software. And then we placed our implant prosthetically driven. We even selected our prosthetic abutment before we start the surgery. And this is our provisional design. What we wanted to do extra in this case, we wanted to push digital dentistry higher, digital dentistry further. We wanted to create the prefabricated restoration prior to the implant surgery. And in order to do that, which is a new approach, in order to do that, we had to integrate 2 different software together. One is a CAD software, and another is an implant software. Any changes you make on the implant software will represent in a real time on the CAD software. Any changes you make on your CAD software, it will also be visible on the other software. In this way, you will be able to lock your implant position and make your restoration in a screw-retained fashion and hopefully be able to deliver it on the day of the surgery. So after we locked the implant position, we created our surgical guide. We printed our restoration prior to the surgery. We cemented it over the thigh base. And now let's see if we were able to be, if we're going to be successful in screwing in this provisional during the surgery. So a surgical guide was placed, and we made sure that the surgical guide is fully seated to ensure high level of accuracy. And we opted here to go with mid-crystal incision because it's the least vascular area, as well as to bring some of the buccal flap on the provisional, and we'll have a creeping of the soft tissue. And a full guided protocol was implemented in this case. Implant was selected. Implant was placed through the surgical guide. And here what we had to really pay attention to is to have a depth control. Not only a depth control, but also rotational control. If we had any changes or any inaccuracy in either the vertical axis or the rotational axis, our abutment or our screw-retained provisional will not be seating. So this is how the patient looking like on the day of the surgery, and we're extremely happy with the results so far, and we're hoping that our provisional will be screwed in. So we tried the provisional, and it's finally screwed in place without any adjustment. And that means we were extremely careful and we were extremely accurate in our planning and in our execution. This is the patient occlusal view on the day of the surgery, and this is the patient occlusal view on the virtual ward. They are extremely identical to each other without mimicking the planning phase into the day of the surgery. We wouldn't be able to put this temporary restoration. We harvest our connective tissue graft from the palate, and then we ideally made it 20% to 30% larger to compensate for the shrinkage that usually happens. And this is our free gingival graft. We did our CTG bed preparation after that. We de-epithelized our connective tissue, our free gingival graft. We secured it in the buccal aspect of the implant, and then we placed it on the buccal aspect of the implant. Notice it is a bit more over. The contour is more puffed than it's supposed to be. This will this situation will be minimized during the healing phase because usually the body goes under 3D shrinkage during the healing phase. Hemostasis was achieved with the Gore-Tex suture and collagen tape. And this is the patient on the day of the surgery after the suture. Notice the mesial papilla here. And notice the mesial papilla 3 weeks after. We were able to achieve a new papilla height. We were able to achieve new gingival creeping, not because of my surgical skills, but because we created the environment for it and we trusted the biology. Final impression was taken, screw-retained restoration was made, and this is the initial situation that the patient came with, and this is how we ended up on the day of the insertion. And we take a PA and we found out that our restorations are fully seated and we are happy with the results. We take a look at the occlusal view and we found out that with connective tissue graft, we were able to correct the soft tissue continuity. And that's how everything is looking like. And we were able to produce to this patient an aesthetically pleasing smile as well as biological restoration. Let's talk about another case that instead of creating a soft tissue, we had to preserve the existing amount of soft tissue. So this is the patient, came to the clinic, and he's missing tooth number 9. And after further examination and with the patient, we found out that the patient's having a diastema, there's tooth wear, and there is deep bite, there is a fracture of tooth number 9, and there is a deficient metal ceramic on tooth number 8. So after careful assessment, we found out that 8 and 9 needs to be extracted. So we told the patient we need to extract 8 and 9, and we are going to place an implant in 8 and 9, but in order to close the diastema, we need to have a laminate veneer on 7 and 10. And that's what we did, and the patient agreed to the treatment plan. But we also told him, we will not be able to restore you with a screw-retained provisional, because we wanted to protect our implant throughout the process. Instead, we will create him a socket seal abutment, which is also called as a customized abutment. And the reason we want to create that is because we want to preserve the soft tissue architecture, as well as seal the socket during implant surgery for our bone grafts. So we strategically place our implants. After doing our wax-up, we strategically place our implant to be 3 to 5 millimeter deep in the apical part to ensure high insertion torque during implant surgery, to be 3 millimeter away from the buccal plate for our bone particle to be placed in, and to be 4 millimeter in depth so we can have enough supercritical attachment. And the surgical guide was fabricated to replicate the plan, and this is the day of the surgery. This is how the patient, so we did atraumatic extraction. We made sure the buccal plate is intact. We place our surgical guide. We place our implant in a fully guided fashion. Then we put our prosthetic abutment. We made our socket seal. We put our bone graft. Then we put back our socket seal. 3 months after, this is how the patient is looking like. We were able to preserve the soft tissue architecture, and we were able to proceed with our digital impression. Digital impression was taken, digital and screw-retained provisionals and laminate screw-retained restorations and the laminate veneers were made. And this is how they are looking like. Now before we try in, so we also made sure that our screw-retained are applying the EBC concept, which will have the emergency profile, aesthetic pleasing and biological, and will stabilize our soft tissue during the restoration period. And we had the reverse S curve will support our ABC concept. So this is the day of the insertion. We try in our restoration. We talked our restoration to the manufacturer recommendation. And we also made sure that the occlusal premature contact are eliminated, not only the protrusive aspect, but also on the latrusive aspect. Otherwise, we might jeopardize our implant. And this is the patient on the day of the insertion. We take a PA to find out that our implants are fully seated, and this is a CT after 1 year of post-op of implant placement. And this is the initial situation of the patient, and this is the final results of the patient. And we were able to achieve, with applying these concepts that we discussed earlier, a highly aesthetic smile and a highly biological also restorations. And the patient was happy, and we were happy with the results that we achieved. And we wouldn't be able to achieve this result without implementing all these 6 principles that they work in a synergy. So not each one of them are important, but they all work together. And with that, I'd like to thank you for your time and for your attention, and thank you.
I guess we're nearing the end because I'm losing a battery on my phone. So I'm charging right now. Okay. How's everybody doing? 1 more to go. We can do it. We can do it, everybody. We can do it. Okay. You know, we always say, maybe the last, but never the least, is our finalist. He came from far, and he's been waiting patiently all throughout the day. He represents his country, Thailand. He has obtained his master's degree in maxillofacial prosthodontics from Bahidol University, Bangkok, Thailand. And he is also a committee and an editor-in-chief of Thai Association of Dental Implantology, TADI. The title of his presentation tells all about what's coming your way. SOS, calling for rescue in implant complications. Ladies and gentlemen, strap on your seatbelt because he's going to take us for a ride. Let's welcome the last presenter of the day, Dr. Onar Puty from Thailand.
Thank you.
Woohoo!
Sorry, come back. Hi, I'm Dr. Onar from Bangkok, Thailand. I am maxillofacial prosthodontist and I like music. I've been started implant in 2010 and after 7 years of practice. Then I just realized that implant complications such as skull loosening or fracture is really terrible for me. Then in 2017, I like to overcome my fear. Year by year, in 2018, I start to merge the complication of implant and music together as first lecturer at the first stage in Guangzhou, China. And today, I'd like to make it again as Broken Ball from Josh Groban, but I modify relics as Broken Crown by me.
Again, I want to hear how crowd was lost and disappeared. What food you ate last night, how hard you bite the bone. Remembering what I've told you.
You remember me today? Yeah. As you thank you. As you have seen in the video presentation, it is all about my life and my patients, and it's all about the mechanical implant complication, such as skull loosening, skull fracture, and the fixture and the abutment fracture. The incidence rate is like 6 to 12%, 4%, and 1% or less than it, respectively. It seems like a small number, right? But if situation happen to you, you're gonna be hectic and headache. So that's why I'm standing here, to prove that when you receive the call of the SOS from your colleagues or from your patients, as a SOS, it means that something or someone needs help. So the SOS calling for the rescuer implant complication. Start with the case number 1. 6-year-old male patient come to see me with a chief complaint of implant crown has been loose and broken. And the history of this one is a long history. 2-1 implant crown in the 2012 designed as a cement retained prosthesis. So patient come back 9 years later on 2021. Take a look closer. We see that the implant crown had loose and porcelain chip at the edge. So diagnosis of this case is abutment skull loosening and the improper prosthesis. The point of concern that we should take a look is, first is mobility, second is in the aesthetic zone, and the third thing is very important. Patient feel discomfort because he had pain on the gum and the incisor edge irritate his tongue. So what is the ideal treatment plan that we should do? First, we should remove the crown, right, and take impression and make a new crown. But in the real situations, what happened is, when I remove the crown, I destroy or ruin the abutment. So not only the crown that need to do impression, I have to order the new abutment. And lastly, we have to rethinking what is wrong. So I redesign from the cement retain into the SCRP or screw cement retain processes for the good retrievability, and tie-based abutment and the zirconia multilayer was used. So we got the new crown, we got the new abutment, and 1 year follow-up as this picture. The question is, how about the ruined abutment? It should be occur? No, right? So what is the better solution or any rescuer that can help us? Coming to the review of the paper of the Carrillo in 2020. So he have the same question like us. How to register the screw access hole in the cement retain prosthesis? So we have in this paper, they claim that the CT scan can support the accuracy of a screw access hole. So in your clinic, if you have the intraoral scanner, and we can merge that advantage with the CBCT, with the CAD-CAM technology like this. Image superimposition of the screw access and the crown image. Then we merge it. We got the visual guideline of the screw access hole. Then we design the screw locating guide, and then we manufacture it with the transparent acrylic resin. And if you have case that have screw loosening, you just apply this device on the crown that loose. Then you drill it, and you can find the screw access or screw head very easily. So we can conclude that screw locating guide can enhance the less destroy and retrievability of your implant crown. Go up to the more complicated The second case, 6-year-old male patient come as an emergency. Actually, it's not my case. Patient come from far away from another country. His chief complaint is a breach on the implant has been dislodged for 2 to 3 days. He's a tourist, so he come to see me. And I take a look that 44247 is a breach on the implant dislodged. And from the x-ray that we took, we find an implant screw fracture. And this is our diagnosis. So the question is, how can we remove the screw fracture? The most easiest way is to use Explorer, right? Or can you use an ultrasonic scaler to turn counterclockwise or reverse way? Or do we need a specific removal kit? Before we go for removal, we need to know the factor. The first factor before you go for removal of the screw fracture, first is the level of fracture. The screw is fractured at above or below the implant shoulder. And second thing is the tightness. Is it low, loose, or high tightness? Then I can classify from easy to the complex case. The easy and the intermediate is mean that the fracture of the screw is fractured above of the implant shoulder. And the tightness, if it's low, you can use Explorer. If it's very high, you can go for the ultrasonic scaler. But for the most complicated case is when the screw fracture below and the tightness is very high. If it's more below, it's get worse. So do we need a specific removal kit or not? Take a look. Go back to our case number 2. When we see this in the X-ray and in clinical, we see that the screw fracture is equal or above the implant shoulder. And then we can test with our hand instrument and find that the tightness is very high. So we categorize or classify as an intermediate level. And you should use the ultrasonic scaler like this. And when we use the proper way, proper method, the screw is coming out easily. The question is, not every case that fracture like this way. Some cases very complicated, fracture at the lower part and very tight. So which removal kit gonna be your hero? Like Superman, Spider-Man, or whatever hero? Because we have plenty of the removal kit system in the market. So in Thailand, I have the course of the management of the complication. My part is like a removal screw fracture. So I have many experiences of the screw removal kits from several systems like this that I teach to my students. And recently, I just tried this one from the Megamind. And I can conclude that 3 characters or 3 things that for the best screw removal kit. First, effectiveness. It should be removed for every case or almost of the case with the fast time. Second is the strength of the material or the tips of the screw removal kit. Its strength is it's made from the material, the sharpness of the tip that can engage the fracture part, and the durability that you can use it for multiple times. Lastly, everyone can use it. It's called user-friendly. So 3 steps for the screw removal kit. First, they start with the claw or remover. The shape is like this. The function is to engage the fracture screw with the sharp 2 end. But if it's not work, you go to the second step we call the drill. The drill function is to create a hole at the face of the fracture part. And then you follow with the third step we call the tapping. The tapping, the function is to engage the hole that we made from the second step, and then we gain the friction, and then we can remove the fracture part very easily. This is a removal kit in the market that I can conclude in Thailand. From Megamind, they have 2 versions. Like the old version is 911, and recently they have the MacGyver. For the 911, they have just only single tips. We call it claw or a remover. But the MacGyver have 3 steps. And if you take a look, many systems, some systems that have 1 tip. Most of the systems nowadays, they have 3 tips or 3 steps. So the question is, why many systems use the same step, but they gain the different result? Why? Because design and the material that made of is different. And the easy of use concept that they think for their user is different. So this make the difference, just small detail from my as a process style. We finished for the screw fracture part. So we go up to the screw abutment and the fixture fracture. For abutment and implant fracture, the incidence rate is less than 1%. And for the abutment fracture, it can break at the weak or fatigue point under the heavy force. Then this is the pattern of the implant fracture. Have you ever been experienced this pattern before, like crack, just small crack, or unilateral, or bilateral, or even the worst cases, like a cutting the horizontal way from the neck of the or the body of the implant. So recently, I just know MacGyver. Do you know what is this word come from? It's come from two words. Meg is come from Megagen. Had the revolution in the implant removal kit. And Guyver is a MacGyver. MacGyver is mean he's a hero in the movie that we have been in the theater before. This hero can help the people in very creative way. So when we merge it, Megagen can fix problem in very creative way. And we want to open up the box of the MacGyver kit. When we open up the box, you will see three parts. From the left side, implant. In the middle is abutment. And the big part is a screw solution. We can take a look from the left. It's an implant remover. It's made of a tungsten carbide that we know that it shows a really high strength. And we can call it universal because they have three sizes, from small or narrow and to regular and the wide size. Which label, which size that compatible with the size of most of the implant market. So it means that it's very universal. And lastly is a design. The design of the tip is called the self-tapping that provide the accurate engagement with the delicate cutting. So it's very effective. For the abutment remover, they have a single piece that you can use with the different tool size and length. Then just put it and remove the hex that broken. Just turn counterclockwise or reverse way. Very easy. For the screw remover, they have three parts, like a 3 deals. So in each deal, they have a different diameter and size. So they have a guide cylinder. The function is to provide or to protect the internal wall of the implant. If you use it properly, it can match most of the implant system connection in the market. So this is my experience for the MacGyver just a couple months ago in Bangkok. They show, and I like to try. So in this part, I like to show you how to remove the implant. Start with the implant. From the left side. This is an implant of the Megagen. So how to use it? They have a 3 size. Yellow is the bill or Y. R is a regular and S is a small size. For Megagen, we can choose the blue one, the regular size. How to use it? Yes, how to use it. So we need to use a ratchet in the counterclockwise or unlock side and turn like, when we place an implant remover and we turn the ratchet counterclockwise like this. Let's try. Can remove this one. When it loose, use a fingertip. Just fingertip. Remove reverse or counterclockwise direction. Oh, implant coming out easily. So I can say this is not evolution, but truly a revolution. Start from 2015, Megagen launched the 911 kit. If you take a look, it can remove both fixture and screw and abutment. But when we compare for this fixture removal, you have to use with many direction, many devices. Compare with the recently one 2023 MacGyver. Only single piece, turn counterclockwise, and then you can remove it. We call it a user-friendly. For the screw removal, for the 911 kit, they have only single tips. We call the remover. But Megagen improve it with the 3-step. So we call it show the really high effectiveness and can remove with a fast time. They can claim that within 5 minutes, and I test it already. So coming to this point, I am start with fear of the implant complications. But from many advice, from my mentors, I got to realize that actually from your fear, you have to develop it into the creative way. From many study of the textbook, and one book that I like is not a textbook, but it's called Just Like Megagen. Have you ever read it? I just got it 2 months ago, and when I got it in print and I read it, it's inspired. This book inspired by Dr. Park. He's a CEO, and when I met him, I said, Dr. Park, I come to France to join the Megamind. He said, good luck. So it's really to encouragement, you know. And I have to say that when you came across your fear, you're struggling with the obstacle and the challenging, you become a better dentist from yesterday with a stronger mindset and wiser method to conquer the implant complication. As the Megagen core value, predictable and achieve as planned. You want the music again? Yes, it's not end yet. Yeah.
Remembering what I've told you, Sagru was loose and crown was cracked. Discomfort, pain, broken apart. Did you listen? the way to save implant. Rescued by me.
Special for MacGyver for this song. If you love it, just I like grab your hand. The MacGyver is the best gadget for now. And I can conclude that if someone or your colleagues call you as a SOS calling, such as the school loosening that happened, you can solve with the school locating guide from the technology of CBCT intro scanner and the CAD cam. But if it's broken, the implant removal kit that you listen for today, it can help you to less destroy of implant component and decrease your clinical share time. Come back to the basic. Prevention is better than cure. So good or proper diagnosis and treatment plan and maintenance to your patient is very important, and it can increase your dentist life confidence, such as a predictable and achieve as planned. This is my references, and I'd like to say thank you, Megamind. This is truly unlock my potential and test my mind, and the MindNet group that worked hard for us, all my patients and family since the first day that I joined. Now that we are here, 21 contestants, and I have to say thank you to my family. My sister and brother helped me to create the video production. That's that's someone you love, that's someone you smile. If you like my presentation, if you like my music that can inspire you to become better dentist and to conquer the implant complication with us. So please enjoy the song and achieve that my ultimate goal. Thank you.
Woohoo! Thank you very much. Now I gotta do a few things. I gotta bring out a Go Attic and bring out Dr. Short's, our karaoke machine as well as a block kit and a hip graft kit too. Okay. So, all right. Thank you so much, my friend. Thank you. Okay. Yeah. Now what we're going to do, we're going to take a break because we need to take a break so that our value judges can stress out a little bit more and start to punch in the numbers, okay, so we can tally it up. So we're gonna take about a half an hour break, okay? Half an hour break, get your coffee, go to the washroom, and please come back, and then we're going to do some announcement, okay? Thank you, thank you.
But stay, don't close your hands. I wanna make this play. I know you're faded. Oh, but stay, don't close your hands. I wanna make this play. I wanna make this play. But stay, don't close your hands.
Hello, my name is Dr. James Cadian. I graduated from dental school at the University of Manitoba in 2009. I moved to Vancouver and I bought a practice in Richmond. So I worked with both my parents. It was by design that I became a dentist because both my parents were dentists. So it was pretty hard to resist the draw of a life that I really understood well. One of the things that my dad really loved doing was dentures, whether they're complete or partial dentures, and that is the complete opposite of most dentists in my experience. But I understood very early that if you're going to put implants in someone's mouth, you should know where the teeth go first. Implant dentistry and surgery in particular is kind of an exciting, it requires all of your attention. Apply yourself. You have to really prepare. That, for me, really engages me as a human.
Hi, guys.
She's a dentist, so she's a terrible patient.
And what?
She's going to tell me how to do my sinus lift.
I'm not doing any sinus lifting.
Now, hush.
My mom has always been my champion. My mom would say, don't wish your life away. You know, you're always thinking, next year's gonna be easier. Next year, I'm gonna have this thing paid off. Or next year, I'm gonna do things differently. And realistically, next year is gonna be more complicated. Next year is not gonna be any easier. Okay, I'm ready to make the next step in my career.
Each competition is composed of 15-minute clinical case or research presentations.
Okay, so you can see down here that lower left 38, this is our 6-year follow-up.
Yeah, Megamind, it does. It pushes you out of your comfort zone. And as much as you were sweating and as much as it was stressful, when you go back and you look at the ultimate result, you have grown. And so my goal for myself is that I'm gonna find some personal growth. And having those moments where it's not just about teaching other dentists, it's about teaching your patients, and you know, it is about a legacy. And what do you leave behind?
Surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water, found my fate, because I don't wanna be stuck in the...
So, hello, my name is Evina and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, after one painful and, as she said, very expensive appointment, she looked at me, at the baby, and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy, and I'm grateful for my mother because I love what I'm doing. And what I'm doing if I'm not working, so I love food very much. And also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water. And I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and I can be a top expert and still live and enjoy life. I think that Megamind is not just a competition. Yes, it's a competition and the winning is not a goal. I think that the most important thing that we are together and we are sharing ideas and creating that big, strong community. So how I'm feeling? I'm happy. I think I'm happy.
Oh no, you ain't seen nothing yet.
그날 되게 떨렸어요. 준비도 열심히 했고 그래서 좀 힘들었으니까 내가 돼야지, 내가 그 칸에 가야지 이런 생각을 갖고 들어왔었는데 이제 다른 선생님들 발표를 좀 듣다 보니까 오늘 많이 배워가야겠다라는 생각도 들고 실제로도 하루 종일 이제 앉아서 이제 20분 정도 이제 발표를 들으면서 되게 많이 배웠고요. 다들 너무 잘하셔가지고 사실 될 거라고 생각을 잘 못했습니다. 여기 서 보니까 정말 더 그날 기억이 다시 떠오르는 것 같습니다. 저 빈 자리들에 앉아 계셨던 이제 교수님들, 다른 참가자분들 다 기억에 남는 것 같아요. 위너가 됐으면 좋겠다고 생각하고 왔는데 위너가 될 거라고는 생각을 못했습니다. 솔직하게 진짜 될 거라고 생각을 못했어요. 그래서 발표가 났을 때 더 기분이 좋았던 것 같습니다. 저희 부모님께 꼭 감사를 드리고 싶습니다. 저희 부모님은 이제 임상을 하신 지 한 30년 이상 되신 두 분 다 치과 의사세요. 그래서 제가 치과 의사가 되는데 롤 모델이 되어 주시기도 했고 제가 이제 치과 의사로 또 성장할 수 있도록 항상 지원을 아끼지 않아 주셔서 꼭 감사하다는 말씀을 드리고 싶습니다. 이번 그 메가마인드를 준비하면서 더 나은 치과 의사가 되기 위해서 더 많이 배워야 된다는 그런 깨달음을 얻게 됐고 환자를 위해서 더 좋은 진료를 하기 위해서 앞으로도 더 많이 공부하고 더 배우는 그런 치과 의사가 되고 싶습니다. 치과라는 분야 내에서도 배워야 되는 내용이 굉장히 무궁무진하다고 생각합니다. 임상 경험이나 지식들을 이제 공유하면 이제 세계적으로도 모두에게 윈윈이지 않을까 하는 생각에 조금 더 글로벌한 꿈을 꾸고 있습니다. 또 이제 제가 더 많이 아는 것은 더 또 나눌 수 있는 그런 연자가 돼야 되지 않을까라는 생각을 하고 있습니다. 이제 칸에서는 이제 또 새로운 주제로 이제 새로운 발표를 해야 되기 때문에 이제 준비를 하고 있고요. 사실 이제 두 번의 발표를 이미 했기 때문에 이제 더 좋은 발표를 준비한다는 게 꼭 쉽지만은 않은데요. 그래도 이 과정을 통해서 저 스스로가 성장을 했다고 느끼는 만큼 이제 더 좋은 모습을 꼭 보여드릴 수 있도록 하겠습니다. Unlock your potential, test your mind, Megamind.
My name is Domingo, and I'm a general dentist in Lafayette, Louisiana. I graduated from dental school in 2007. Upon completion of my residency program, I applied for a 2-year implantology fellowship with Brookdale Hospital in conjunction with NYU. I always felt the need to come back to the city that helped raise me. After practicing for 6 years, I eventually moved back to Lafayette, and that's where I've been for the past 12 years now. I practice as a general dentist. My practice is mostly limited to implants. We do have a referral-based practice where more difficult cases that require, I do most of the surgical aspect, start out with the prosthetic aspect, and in that, I've developed the Louisiana Dental Implant Lab that helps support me. So we're a full digital lab. We do take some analog cases, but that's like my playground.
No, I don't want a picture. I don't want a picture.
I want you to meet my wife. Yeah. This is my wife, Megan Domingo.
Hi, how are you?
Currently, she runs operations for the dental lab and all 13 employees that we have here.
So close.
How's it that your husband is your boss?
I'm the boss.
Oh, you're the boss. You're the boss.
I have a motto for myself: work smarter, not harder. You know, in my small community, it's we only have 150,000 people. Isn't as big as New York City, where I used to practice. Patients here can't afford $30,000 treatment plans. So my goal in this was to help be able to lower my overhead expense by having a digital lab. So being able to provide the best level of care for a least amount of out-of-pocket for the patients as possible, and giving them a wow factor at the end of their treatment plan. It looks good. Yeah, this is good. When I was in residency, my mentors were the guys that lecture around the world. I looked up to them, and I thought, one day I want to give back to the younger generation. So as soon as I got out of the residency program, I wanted to lecture immediately. But I was so young, the sales reps wouldn't let me lecture for their companies. So I documented my cases, and I was showing them things that I was doing, and that's kind of helped me get some speaking engagements.
It's important to understand how to get a patient in from the 2D world into the 3D world, and once the surgery is performed, we'll convert our digital wax up.
League America. Dr. Denny Domingo, United States of America.
21 of the best clinicians that I think are some of world-renowned clinicians, and me, just a general dentist in a small town, which sounds intimidating, to be honest. I'm expecting the best clinicians in the world to present their best cases on a very big stage. I'm going to do the best that I can at a mission in life to do the best for others. And God really has a purpose for me. Creating that purpose and showing him what was possible for me.
We allow the biology to work for us, and her tooth 4 was broken palatally.
Dr. Scott Jung.
Because the buccal plate is primarily
Scott Jung, representing Canada.
Less than 20%, and reduction of size with the concave.
Why? Because we have comprehensive
problems.
There was a fierce competition. 20 contestants from all over the world, and they are the best, and they're representing their nation and their continent, and they're competing against one another in order to make the final 6th spot.
Did you disappoint statistics?
Yeah, of course. I mean, we go there in hopes of winning. I don't think anybody's there just to enjoy the time. They want to win, right? And that's the part of the competition. I understand that as a dentist, we're good at being a dentist, but we're not trained and skilled enough to become a good speaker. There are people who it comes naturally, but most of us needs training. And I found that going through the 2 years of Megamind really has trained me, gave me a hard training in speaking. Now I know how to speak better. I know how to present better. I I know the last Megamind made me a better dentist who can serve my patients better. I'd like to start off my presentation with this particular picture.
League America, Dr. Scott Jung, Canada.
Oh, I'm hugely honored, and I'm very excited to make it to the final round of Megamind again. Megamind, to me, it means two things. Number one is a dojo training for speaking, trying to encourage, educate other dentists about the potential and the future of implant dentistry. And second is also a platform to meet other clinicians and share the ideas in order to advance our career and our profession. My mindset going into the final round is to shoot for gold. You want to win, and I'm giving my best to win.
I'm Nabil from Lebanon. I live in Batroun. It's a coastal town known for its beautiful sea, water sports, and stunning nearby mountains. I'm the co-founder and periodontist at Dentist Studio in Byblos, Lebanon. It's a private polyclinic. We are a team of 6 dental specialists, including my sister and my wife. Since I was a child, I wanted to be a doctor. I was inspired by my father, who is a doctor and my idol. And I also had a deep passion for technology. And it is during my residency years in periodontics at the St. Joseph University of Beirut where I discovered digital implantology, and I felt that this is the perfect blend of my interest with my dental career. Since graduating, I practiced prosthetic and implant dentistry, and then became instructor in guided surgery at the same university, and later managed the craniofacial research unit at the Craniofacial Research Laboratory at the same university. I also founded a guided surgery service and training services for other dental professionals. Balancing work and personal life is definitely a challenge. However, I make it a priority to spend some quality time with my family and engage in some outdoor sports activities like windsurfing, biking, and snowboarding. This allows me to recharge and stay focused and be more effective in my professional life. I'm grateful to the persons and colleagues that encouraged me to enter Megamind, since it is an opportunity for me to share my passion and the techniques that I've developed in digital implantology. I've collaborated on many scientific projects and studies, but I haven't yet shared some of the most impactful things that I've done with the broader community. So I think this is a chance for me to challenge myself, to learn from others, and to contribute to the ongoing evolution of digital dentistry.
go ahead. All right, everybody. Okay, let's have a seat. You guys have to help me kill some time. All right. See, now everybody's smiling. Everybody is all happy, now relaxed. You guys going to have a great sleep tonight. Except those who do get picked for top 6, you won't be sleeping much because you're going to have to practice again for tomorrow, right? Okay, at the main podium. All right? Yeah. Now, yeah, I do want to take this moment to make a special dedication. It wasn't really part of my plan, but yesterday, as I was going through the slides and things like that, I know that I might have a few minutes of a moment, few minutes, to share something with you that means a lot to me and the judges.
So how many works is to be a speaker? How many jobs? I can be the best Niklaus Pelang, Jan Linde, scientists, even the super scientific level. But it's not enough. It's a part of, very important. But it's not enough. It's not enough. We need to be good photographer, but it's not enough. We need to create some emotion. Without this final part, there's no deliver. To do this is to tell our stories. Stories is the fil rouge, to say en français. But without a story, we don't have a lecture, an effective lecture.
For those of you who's been with Megajan and Minek long enough, you know who this man is. He has touched so many of our hearts. And I've never met anybody who has so much passion for fellow dentists and for education. We miss him greatly. We miss him dearly. On behalf of Megamind 2024 and on behalf of the board of directors and the judges, I dedicate this year's Megamind competition to Professor Diego Lopes. Okay. And sometimes I still can't believe he's not with us. Diego has helped me greatly during the last season because I was carrying with this burden of Megamind, and there was a time that I felt so lonely, so difficult. And we will chat, text each other, and we'll do a Zoom meeting. And he'll give me a lot of good support and ideas. And he and we shared this vision of what the MINEC future young presenters, lecturers would be, you know, and we were dreaming about that. And I had this opportunity to send the top 6 Cinderella of the season 1 and season 2 to Milan to be trained by Professor Diego Lopes and, of course, his dear friend David. Yeah. He had this passion for dentistry. So we dedicated to Professor Diego Lopes. Now, I do have to kill some time, okay, because you're wondering who's the winner. Well, we just entered in all the numbers, and at the back in our Megamind HQ, they're going to have to add the numbers up, right, and then do the scoring, and they're going to submit the top 6 list, okay, yeah. But like I said, when I decided to partake in a Megamind, competition was not the ultimate goal. It was to create a platform for doctors around the world that can have an opportunity to showcase your talent, but also your love for this profession. Yeah. But of course, competition always makes it more exciting. Yes? All right? Makes it more exciting. It's like a reality show. There has to be something, right? And I think you guys all played your part very, very well. I'm going to take a little moment to show some of the video clips along the way that I created as a hobby and also a self-documentary. And people were asking me, what is Megamind? What is a Megamind? And I was so tired of explaining to them all the details how I got it. So I made a 5-minute video clip over here, and we'll watch it together.
Sweet pea, apple of my eye. I don't know when and I don't know why.
Congratulations, you are going to be going to Korea.
Oh, thank you so much. Oh my god. Can I call my mom? 엄마, 저 지금 전화해도 돼요? 엄마, I made it to K-pop star. I'm going to Korea. Oh my gosh.
Dr. Park called me in
I think it was near the end of 2022. He told me about a global lecture presentation competition platform called the Megamind. Apparently, Minek headquarters is preparing for the season 2 and wanted my involvement. To be honest, I had no idea what it was about. I kind of heard about it, but nobody really remembers because there was not much promotion behind it. So that means if I'm going to be leading the way, I have to think of it as a fresh start, ground zero. Megamind is a combination of online, on-site, live performance by contestants around the world. They're given 15 minutes to showcase their clinical cases and talents. Winner of the national round will advance to the continental round. In the end, 3 contestants will represent each of the 7 continents. So that means top 21 will go to the final round to compete live for the ultimate 6 winners. And I call these 6 winners the Cinderellas. Initially, I said no, because starting something of this scale and magnitude is never easy. It takes a lot of time and patience, neither of which I have. But Dr. Park is an ultimate persuader. The hook was that anyone from anywhere using any implant system can compete. A true open league competition. Now, that's something exciting. The art of persuasion. I immediately knew season 2 of the Megamind had to be different, quite different. Branding is not something that you can see or touch. Branding is what it makes you feel, how you feel. It is very, very difficult to create, but if we do succeed, it will reward us with unparalleled level of interest and attention from the audiences all over the world. About 10 years ago, there was a popular Korean TV show, a Korean version of AGT. It was a weekly TV show that me and Ginny, we would watch religiously. A reality show featuring young amateur singer-songwriters from all around the world to showcase their talents on TV. What's the ultimate reward? Top 3 winners will earn the record contract with the renowned record labels such as YG, JYP, and Antenna. So many young, raw talents yet to be discovered were all on the stage. But for me, one particular young kid from Seattle, Washington caught my attention. This 14-year-old high school kid was just ecstatic to receive an invitation to enter the competition. A kid with no formal training in any aspect of music. He brought his guitar and his voice, and he performed this.
Okay, 5. Sweet pea, apple of my eye. I don't know when and I don't know why. You're the only reason I keep on coming home.
The long story short, he became one of the top 3 winners and got to sign a record deal with Antenna. What really drove the excitement of the show was a storyline. Not the story of the show or the judges, but the story of the contestants. Not how well they performed on the stage, but what each of them had to overcome, the challenges and the impossibles. That's what made the show so much more memorable. Because as an audience, we always root for the underdog. And of course, that's where I got the inspiration for the Megamind campaign. Story is not about the Megagen implant company or their products. Megamind is all about the contestants and their stories. Their courage to overcome their fear, to stand on the stage, their chance to push their limits and their boundaries, and to rise to the occasion to reach for their stars. And when the stars do line up, the Cinderellas are born. We call them the Minek Knights. Minek is an exclusive community of dentists and educators who will encourage and push each other to become the best that they can be. In other words, their journey to become the future leaders in dental education has just begun. Unlock your potential, test your mind. We are Megamind.
Sweet pea, apple of my eye. I don't know when and I don't know why.
That's the story. So I tell them, somebody asks me, what is Megamind? I send them the link, watch it. So that's the true story. And that's how the story started, and that's here we are. And that's why when we started the branding campaign, with David, I said it has to be a story. It has to be a story of somebody that we might not otherwise know. And it was very difficult, but I think we did a pretty good job. And of course, without Dr. Park's support, nothing would have this been possible. And this quote, so when Dr. Park asked me, Dr. Kwan, I want you to lead this. So we have to draw an inspiration from a quote. And this inspiration quote, no matter what anybody tells you, words and idea can change the world. I'm a movie buff. I love watching movies because I don't have that much time. So whenever the time that I have, I watch a movie by myself. And this movie, I watched it when I was in university. And of course, it's from the movie Dead Poets Society, right? Yeah. And from there, I had to come up with a vision statement for Megamind. What is a vision statement? A vision statement is something that when you start a project and when things don't go the way you want it to go, like in life, then instead of quitting, you need to look back at what that vision statement is so that you can regain your courage. I think this is very, very important. And my vision statement that we created is to search and cultivate the future leaders in global dental education. And when I wrote that vision statement, 3 sentences came right away, which is, unlock your potential, test your mind, we are Megamind. Literally, 1 minute just came automatically, you know? And that's when I knew that's probably how Elton John feels when he's writing music. Just inspired, right? You know? And one of the first very video to use that idea, the video that I explained to David, and then David came up with this video clip.
No matter what anybody tells you, words and ideas can change the world. From the movie, The Dead Poets Society. Megamind 2023 was an ambitious project. Over 300 contestants around the world participated in this open league competition. The scale of such an event is unprecedented. Now we have top 20 finalists representing their own countries to compete for the main podium in Antalya, Turkey.
This was last year.
This is very, very exciting. It is truly a Cinderella story because it takes courage for these young doctors to make such efforts in front of the global audiences. The final competition will be aired live from Antalya, Turkey in October the 13th at the Middle East and Africa Scientific Meeting. So, who will be the next Cinderella? Unlock your potential, test your mind, because we are Megamind.
So once David made this video, okay, I think we got the main vision going on. That's our goal. We're here to search and cultivate the future leaders in dental education because we believe that. Their words, and your ideas will inspire people, and that will change our profession. That was our vision statement. So we got the vision statement. I got the idea. We have to test it out how we're going to tell the story. We have to come up with some sort of a template. I had no idea. One day, I was doing a motorcycle ride, coming back from Grand Canyon, Zion Grand Canyon, back to Vegas. I had this idea, is that what if we can interview the doctors and tell the story? So one of my motorcycle riding buddy, his name is Dr. Bernard Jin. So we just arrived. He's still in his gear, right? Okay, here. I say, you know what, Bernard, pretend that you're a young dentist. Like who? Just make it up. Just make it up. Doesn't matter. Just make it a couple minutes, you know, tell a story. So no script, no nothing. I turned on my iPhone, and then we start recording this.
Hi, I'm Justin Cho. I was born and raised in Seoul, Korea.
He wasn't.
Where I was influenced by a very famous dentist in my hometown. When I graduated from dentistry at Seoul National University, I started practicing dentistry for the past 10 years. That's when I got into the world of implantology. It was in this world of implantology that I met fellow dentists who were passionate about implants, which is why I love implant dentistry so much. I'm very excited to participate in the upcoming Megamind competition because I believe that this passion needs to be spread around. I've never competed in such a global level before, but it really excites me. In fact, I look forward to the challenge. To me, it is more than just a competition. It is an opportunity to test myself. As a solo general practitioner in my small town, I have documented many cases that I've been doing for the past few years, long enough to see a good progression and tell a great story. This level of opportunity only comes around once in a lifetime. And not only that, ultimately, it makes me a better dentist. I look forward to competing in the Asian regional competitions, and I thank Minek for this opportunity. Till then, I'll see you at the stage.
So I made that video clip in the hotel room. I did a quick editing, and I showed to David. David, do you think this works? And he looked at it. He goes, very amateurish, Dr. Kwon, but I think we can do it. So that started this whole idea of storytelling. And once we got that idea of this, how we want to push our campaign forward, of course, David, with his professional skill, we did our very first proper storytelling of the future Cinderella.
All this time, I've been feeling hopeless till you came around, came around. All this time, you're the only reason I'm not chasing highs, chasing highs. What is love? Lately I've been wondering just what is love, what is love? Can you open that for us?
The decision to become a dentist was made for all the wrong reasons. I was of the understanding that it was very easy, more likable and digestible than medicine, which I heard horror stories about medicine, the residencies and all that. So I went into dentistry thinking it was easy, and as it turned out, that was a grievous miscalculation because it's not easy. It was interesting because I never thought I would place implants. When I graduated out of dental school, I was always under the impression that implant dentistry was outside the scope of general practice. But when I started seeing patients, there were so many scenarios where I was like, wow, they would benefit from an implant. Too bad I can't do implants. I would refer the patient out, and sometimes when you refer them out, you know, they never go to who you refer them to, or something gets dropped along the way and they never actually get that treatment. So I thought to myself, I'm like, well, what if I learned this? This would be a very valuable service to them. And in 2009, I took my first training course in implantology, and I never looked back.
We're very excited to announce the upcoming global event, the Megamind.
Well, this is actually very unique, this competition. And I go, it's a competition. I go, first of all, right? So that in itself is such a motivating factor. My goal is to win. No, I'm kidding. Anytime you have to showcase your work, you better know it inside out, right? So in that process of going through your cases and creating a presentation and really getting granular and dissecting what you did, I think that's an amazing learning opportunity. I think you would really have to master what you've done. That's how I learned a Megamind, but once I thought more about it and saw what it was about, I was like, this is excellent. This is what I want to be. This is what I want to do. Helping me progress and become a better clinician. If you're scared of public speaking, if you're scared of presenting, take this on. Guess what? We have to be good at presenting. We have to be good at public speaking, because guess who we present to every day? Our patients, our clients, our team members, right? We have to, that's our profession, that's what we do. We have to communicate with people. I would encourage anyone that is in dentistry that wants to grow in their career to embrace opportunities like this.
That's how professionals do it. So he was Justin chose my work. That was David's work, right? And of course, you know, David understood my vision and he made it into realization. And once he showed us, me and our Megamind team headquartered in Korea, we were very, very excited. That was a little glimpse of what's to come, what's to come. And that was an amazing turning point event for us. So 좀 더 시간 끌을까요? okay. All right. So I gotta burn some more time. Okay. All right. Okay. All right. So that's my job. Okay. Yeah. So top 6 of you. First of all you guys are top 6. Okay. Like that's how I feel. Is to choose 6 out of this 21 top 21 in the world is not an easy task. So I tell you, the point difference is going to be less than 1 point, each one of you, but we do have to announce something. So they're tallying it up, and once they got the top 6 score, they'll bring the list to me, and I'll start to announce. And when I announce, each of the judges will have the honor of a presentation. Okay, yeah. Last year, these are the 6 Cinderellas that has survived through the final round, and they made to the top 6. And once you get chosen tonight, become a top 6, and you'll have the honor of representing us to do and make us proud at the main podium tomorrow. And you will be slotted into their main key speakers in the morning, and we will have a prime time, I believe, between 11 to 1 o'clock. Okay, and that too will be aired live as well. Okay, yeah. And I'm very excited for whoever that may be. And last year, this is what they did at the main podium. It's a bigger stage, and they go up there and they present their case. The challenge was these 6 presenters, they didn't really get to sleep at all the night before. Why is that? Because they did the presentation the day before in 16:9 ratio, and they had to switch to 3:1 ratio overnight. Can you just imagine? So that's why this year I asked, right, what is the projection ratio? Is it 3:1 or 16:9, right? Okay, they said 16:9. Are you sure? Yes, 16:9. Are you sure? Yes, it is. Okay. Then we announced that it's going to be 16:9. That's why initially you guys were instructed to prepare your presentation 16:9, right? And then only a few weeks before, as they are placing the displays, Dr. Kwon is 3:1. Oh my God, right? Okay, so but most of you prepared from 16:9 to 3:9, which is not easy to do because it's a different way of storytelling. Right? So whoever you guys did make it a 3:9, if you do get chosen, don't worry, you can sleep well, right? And do the same thing, rerun tomorrow, okay? So that'll be good. That'll be good. Sorry? No, it's just the 3:1. Oh my God. Jin-san, is it 3:1 or 16:1? I think you have to stay up tonight. You have to stay up tonight, okay? Yeah, all right. Yeah. Okay, let me get stressed out a little bit more. Okay, I'll figure it out. I will make it work. Yeah. I think it's a 3:1. I think yours will be cut off on the side. That's okay. That's okay. You're still good-looking guys, so nothing changed. Okay. Yeah. All right. So that's that. Okay. That's that. And so one of the significance of the real prize of being chosen as a top 6 Cinderella, not only that you get to go to the stage, not only that you get to have some cash, but the real prize that you get inducted into the prestige membership of Minek Night, and you will be inaugurated in the next year's Minek Night event. Okay, it is a very exclusive group of the world key opinion leaders. And you'll have a lot of previous clinicians who were also Minek Night. And there you also is going to be me and all the judges here. They're part of the Minek Night, where we'll be helping you to coach you and guide you to give you more opportunity so that you can become a presenter of the future. Okay. Okay. Yeah. Now what I'm going to do is I'm going to kill some more time, but I can only kill some time by myself so much. So I'm going to ask the judges, come and help me kill some time too. Okay, Kyuhan, come here, okay? Yeah. Kyuhan is like my Korean brother because his name is Kyuhan, and I had a best friend. His name was Bak Kyuhan during when I was high school, right? So I never forget his name, right? Okay, yeah. He wasn't as good looking as you though. All right, so I love you more. Here you go.
Oh, thank you. The guy told, it is more than a competition. I believe this also. And I want to appreciate your attendance, make valuable these organization. And also I want to thank to the all technical team for their great effort. Also, the headquarters, extraordinary job. They had an extraordinary job doing this organization. And also, for the board members, they really needed very excessive concentration while judging all day. And they have an outstanding concentration for this work. Thank you for all dear board members. And of course, I want to thank to Mark, because as a name father of this organization, yeah, of course, I want a big applause to Mark. Because he brought this organization to this level and make valuable organization in the world. I want to thank again to you, Mark. So, any guys, maybe Makari? Huh? Yeah, please.
You can talk as much as you want. Both. This is your chance.
I have 1 hour tomorrow. Don't worry. So, well, I think that maybe we can discuss a little bit the day and start with the. We did give you only compliments throughout this day, saying that you were all of you amazing, that the level of lecturing was very high, and it was. I participated last year in the Megamind event in Antalya, and I can really tell that last year we could tell that maybe half of the participants were not fit to be winners. But today, no. Most of you, if I can say all of you, are fit to be winners. And I'm not saying this just to please you. It's a reality. As I said before, a good lecturer, and as our dear friend Diego said, you can be a linde, but this does not mean that you will give a good lecture. You can give maybe the best material that you have, and then you can see people sleeping in the room. In order to give a good lecture, you have to do the balance between science, between clinic, between beautiful iconography and communication skills. I was amazed by some of you with their beautiful communication skills, beautiful iconography. Now, there are some negative points that we should also talk about. Out of 21, only 2 had their own research or publication to support their lecture. And this is something that we should work on. Because if you want to be a good lecturer, you need to have your own material to show on stage. This will give you more value when you lecture. Second thing is that some of you did not do the 1-year follow-up properly, and this was mandatory, as I understood. Like showing a clinical picture of a 1-year follow-up without a radiograph, or showing a radiograph or not showing a radiograph. Today we show CBCTs, not only 2D, 3D, in order to show our results and see that what we're doing is successful, and this is how we show it. And there is one third thing that was negative and that we have to work on, that out of the 21 contestants, we had only 3 ladies. So first of all, we have to, big problem. There were, you have to applaud the 3 ladies that were really exceptional. And hopefully next year we will have 50-50 sex ratio.
I hope.
Thank you very much. Thank you. It was really a pleasant experience. Mr. the Dean.
Merci.
Merci, Monsieur le Président. Nice to come to an end. It was a hard day for us. And it was a hard day because of your level. It was very, very difficult to put together the points. We still don't know what will happen, who will be the winners. But I'm sure that all of you are the winners, and not only. Megagen is the winner, and all the doctors that will be educated by you will be the winners, and of course, their patients. What we have seen today, we have seen the preferred topic was aesthetics on implants, and then it was some bone reconstruction, and it was some digital prosthetics, full arches, very interesting topics, like in a very good international conference. What we have seen treatment of complications easily, like singing. And I think that what is different to this year in comparison with the last years is that the level, I told in the morning, the level was the group was very compact. It was very difficult to differentiate the peaks from the bottom. No, it was not like that. We have seen good quality educators. We have seen more scientific ground than other times, but still, as my friend said, we do education, but we have also to create content, to educate people by our own work, to create studies, and only 2 people showed the studies. And the surprise was that many of you belong to a university, so you have in your daily activity creating science and studies, clinical studies, because we don't expect more than that, but still not many published or presented their own work. Education is a very important, I'll make it longer, Mark. Education is very important, yes. It's a very important responsibility. When you are on the stage and hundreds of doctors are looking at you, and they take all the information and they will apply it. So you have a huge responsibility when you are on the stage. You have to give them a very solid ground, scientific ground, and also a clinical issue. What we had, we know. What we should have more ladies, agree. And then many of you are not beginners, and hardly we can see 1-year follow-up. Of course, the rules of the competition was 1-year follow-up, but not everybody reached this. I think we have 4 or 5 people that didn't have a follow-up of 1 year. But I think to be consistent, we have to show people that our results are stable in time. This is a very important condition when you are educator, to show them that you have a scientific ground, you work by the book clinically, and then your results are stable in time. These are very important 3 things. And more science, more follow-up, and more lady doctors, and a lot of responsibility being educators. Technology is something amazing. We have seen a lot of technology, beautifully organized. We have seen more concept lectures this year than other years. The rules are to present a case, but we had the luck to see some colleagues presenting a concept lecture, and I enjoyed it, because we need also this kind of educators. And of course, technology is important. Deliver and know how to use the technology is important, but still keeping the biological rules in mind. I have to thank you all for being so consistent. It was very clearly seen that you prepared very carefully everything. This was obvious. All of you prepared very well. not only the visual part, also the speech, also the ground. It was amazing how good you prepared everything. And I have to thank you. I have to thank the juries for the hard job they have done. We'll see the result. It was very complicated this year. I have to thank Mark for taking the idea of Any Reach Days, the old idea of Any Reach Days, and transforming in something global, in a Megamind, which is a huge Any Reach Day. And it is more and more successful. And to thank the headquarters, to thank MegaGen for investing a lot of money, energy, time to create this Megamind. Thank you.
I want to apologize for taking so long. I think I was the guy who held you guys up. It was easy to choose the first 10. It was the top 10. It was easy to choose the bottom 5. Everyone in between was very difficult because you're all so equal in your approach. I just have 3 comments I would make concerning your continued efforts in speaking to professionals. One thing that Mark said to me when he said, when you're making a judgment on the presentations, ask yourself who you would want to listen to again, or you want to spend more time listening to that speaker. And there were, again, the top 10 of these contestants. I would like to spend more time listening to you. And so when someone is in the audience listening to you, that's, you know, the key is to make sure that you're presenting material that people need to know and that they want to hear more from you. So of course that means staying current with your information. Things change so quickly, it's hard to do that, but for those of you who are taking the lead in speaking, you need to be current because next week, what you present today, next week may change. And the last comment I would make is that it's always difficult to choose a topic for presentation because your audience will be a wide range of people. There will be some new novices in the field and some very experienced people. But my comment on that is that even those people who are very experienced will appreciate when you deal with the fundamentals and when you lead us to situations that are a bit more challenging and that although may seem repetitive, if they deal with the fundamentals, then even the experienced clinician will appreciate it. Thanks again for your effort.
Thank you. Still, there is time. I don't want to repeat the words, but my words are going to the competitors. Today, we have seen a very high quality presentations. The photos are almost perfect, and it's very, very difficult to take good pictures when we are working in our clinics. It's very difficult, especially if we do oral surgery and dental implantology. We have to know that. The average of all the speakers today are above the majority of the speakers in the majority of the podiums worldwide. Of course, there are stronger speakers, of course, but you all, these 21 participants, are above the average. That's very important. And I just want to ask to all of you one single message, one single thing. Please, all of you are the winners. I would like to ask you to the ones who are not be in this group of 6, don't be upset. Please, don't be upset. We don't know who are going to be these 6, but please, don't worry about the rest of the people who are not in the group, because all of you are leaders. I don't know where, I don't know how, but you are going to lead dental implantology in your country, maybe in other countries, but all of you guys, the 21 of you, will gonna lead dental implantology. Please, don't be upset. That's the important message for today. Because I know, we say it's like the Olympic Games. The important is to participate. We know it's not like this. We want to win. Everyone wants to win. But believe me, the important is to be in the group of the 21. Just in the break, I asked to Mark, why don't do some meeting with the finalists of the Megamind competition? And do maybe 1-2 days of 15 minutes presentation of all of you. And we can just be together the other seasons of Megaminds, because it's brilliant presentations. And the level is higher and higher. Then I think you have to be proud to be in this final. You have to be very proud to be one of the finalists in these sessions. And I just wonder that after this event, all of us will be very happy. Thank you very much.
I was expected to see some butterflies from your stomach, from the participant, but I wasn't able to see one butterflies in this room. So I don't know how can I start with my small speech here. So as an educator, I would be really happy to have a student like you guys in my department. What I expected for the first time is that some kind of a small presentation from a beginning practitioners, but I think you guys are all established speakers from my point of view. And so taking a clinical picture during your clinical practice is one thing, and in the meanwhile, building up your own cases. So I also taking clinical pictures during my surgery. Some patients just ask me, hey doc, why are you taking so many pictures? Just stay focused on my surgery. But I usually answer them like this. The taking a picture is a part of education. So if you don't want to get this kind of pictures, just get out my hospital. So I think you guys really did really great job. So I was so excited. So when I came into this room, I thought that it's gonna be a really long day to spend a lot of time giving some point for everybody, but it was really entertaining, and I was really happy to see all of you guys in this remote city of Cannes, really far away from my country. And then, so I'm not here judging you. I'm here to communicate with you and sharing the knowledge with you. It is always great things to share knowledge and communicate the people who have the same profession. Thank you.
Okay, guys, the list is in my hand. This is in my hand. Very, very tight competition. Very, very tight. How we're going to do this is we're going to have one of you, we have 6 of you, and we have 6 Cinderella, okay? Yeah, I'm going to have you, Kyuhan. We're going to go in this way, this way, this way, this way. So let's line up. Let's line up so that they're going to take some picture of us as well, all right? Yeah. Okay. I'm going to tell a little bit about the story about our trophy. It was designed by Dr. Jem Durgan. Yeah. He's a dentist. Where are you? Are you here, Jem? No? Okay. So he's a dentist, but also an artist. And he's upgraded the award. And looks even better. So we have it ready here? Yeah, let's bring one first. Yeah. And so we're going to have a certificate. Okay. I'm going to call out the winner. And call out the winner. And we're also going to give out the trophy. Show the trophy. Come here, come here. Show the trophy. Jin-sun, you're always hiding behind, right? Always hiding behind. Okay, yeah. So this is a Megamind right over here. It says a Minek and has a name over here. So the first Cinderella, not in order, not in the order. So it's just top 6. Okay, you don't think that because I called it first, it doesn't mean that you're the first. Okay, yeah. Okay, so first Cinderella recipient of Megamind 2024 goes to Dr. Matia Manfredini. Dr. Matia Manfredini. It'll be given by Dr. Leonard Schwartz. Okay, right over here. Yeah, over here. Right over here. Good, good. Yep. Yeah. Okay. There you go. You hold on. Yeah. Okay. There you go. Look at the camera. Okay. Got it? Congratulations. Wonderful presentation. Very proud of you. Absolutely. Okay. All right. Okay. All right. Yes? Yes, you said we're going to group for afterwards. Yeah. Okay. All right. And then next, Cinderella number 2. The winner goes to, it's going to be presented by Jordy. It's like an Oscar, okay? Okay. Yes, please. You put the glasses, and I open up the envelope, and you get to do this. Are you ready? Ready, Jordy?
I don't know who is this one, but his name here says Dr. Felix Wer.
They never met before. Okay. Okay. All right. Okay. You got to hold this, my friend. Yeah. Okay. Hold on. Yeah. Got to do your part. There you go. Okay. Yeah. There you go. Don't cry. Okay. Yeah. There you go. Okay. All right. So the Cinderella number 3. Okay, put your glasses on. You ready for this? Okay. Drum roll. Here we go. Okay, Kyuhan. There you go.
Oh, Dr. Nabil Johnson.
Come on down. Yeah. Don't fight. Excellent. Congratulations. Okay. So we have 3 remaining. 3 more award to give out for 3 remaining Cinderellas. Okay. Next one, we'll have the honor by. Okay. Yeah, bring your glasses. So all of us, we cannot see with the glasses and cannot see without the glasses. Okay. All right. So next winner award goes to
Dr. Evelina Gineviscietti.
Come on now. Okay. There we go. Okay. The next award will be given by Professor Kwon. Do you have your glasses? No, you're okay. You're okay. All right. And the award goes to... It's Korean way of doing this.
The prize goes to Dr. Chan Young Park.
From South Korea. Fantastic. 이거 줘야죠. Trophy. Okay, good. It's heavy. Okay, there you go. Congratulations. Okay, all right. The last award. Okay, there's one more. It's the last one. Okay, and you get to do your glasses? No, you good? Okay. So the last award goes to the last winner. Drum roll. Okay, drum roll. Okay. There you go. Yeah. It's very difficult, writing. Yeah. We have to analyze this first, okay? Make sure that you pronounce it properly.
Yes, it's complicated.
The last award goes to...
Dr. Sa Yue. He left. Okay, I'll take the prize then.
Okay, you'll take the prize. Dr. Sayu from China. I think he had to I think we'll go together. Here we go. I look like Dr. Sayu. Nobody will know.
This will go to Dr. Sayu.
Yeah, we'll take
just
a picture.
A moment, just a
Let me
moment,
hold
just a
it.
moment.
Hold this here. Okay, and then you hold there, and then we'll send him off.
Send a photo to Dr. Sayu.
Got it? Good.
Thank you.
Excellent. Okay, good job, everybody. Okay, so what we're going to do is we're going to have a group photo of the Cinderella, and the rest of you also get to have your trophy as well. Everybody who's attended, you have a souvenir, heavy souvenir that you're going to carry home. Okay, all right, and then it's very good for doorstopper. Okay, yeah, it's like an Oscar. Okay, so let's have a Cinderella. So first come here, and then we'll take a group photo, and then
make a group photo with Cinderella's and the jury
sure,
first.
Sure.
And then
I'll stay out. Okay. Okay. All right. Find your presenter. Yeah. Okay. Yeah. Just stay. Yeah. Maybe the Cinderella sit at the front down, and the judges go up. Okay. Why don't we do that? Okay. Yeah. Let's do that. I'll come over there. Don't worry. I'll join in. I'll make sure. Okay. Gotcha. I'll go right here. Maybe I'll go right here. Okay. Excellent. And then let's do group 사진 찍는 거다. Okay. Oh, also, yeah. we have something special that we didn't have last year. Okay, I would like to give appreciation plaque to the judges. Because for me, without the judges, this would not have happened. And you guys took on some of the hardest job, in this project. Okay, so I'd like to award this to Professor Jordi Cagallo. Thank you. Okay, there you go. Take a picture. Okay. Oh, that's him. That's him. You gotta look at him. What if we get the wrong guy? Yeah. Thank you. Wonderful. Thank you. Thank you, Professor. Okay. Next goes to Professor Christian Makari. Makari, come here, my friend. Okay, that's you. Okay. Next goes to Dr. Leonard Schwartz. Dr. Schwartz, come this way. Yeah, right here. Put together. Thank you, Dr. Schwartz. Thank you. Appreciate it. Truly appreciate it. Okay, the next one. Dr. Professor Yong Tae Kwan. Professor Kwan, thank you so much for today. Okay, and my thanks to also Professor Christian Dino. Christian. What? Thank you, Christian. Thank you, as always, my friend. Okay, and Professor Gyuhan Durgan. Gyuhan, come this way, my friend. Okay. Okay. And let's, oh, was it one more? Or? What? Just for me? Wow, I didn't expect that. Okay, who's going to present it to me? You and you will. Okay. Yes. Actually, you know what? I want to take pictures with all you guys. Come this way. Okay. Me in the middle. Make me feel important. Come on, let's go. Together. There you go.
Good job, Mark.
So what we're going to do now, we're going to take a group photo with the Cinderellas. You guys already did that, right? So, yeah, with all of them. We're going to take a group photo. So we're going to take, give an award to, okay, everybody, okay, for participating. Okay. Dr. Zhu Zhenkun. Come on down here, please. Dr. Zhu Zhenkun. Am I pronouncing it right? Nope. Okay. All right. Okay. Dr. Pablo Urrutia. Dr. Pablo Urrutia. Come on down. In the middle. Yeah, we'll take picture. Yeah. Okay. Okay. Dr. Yusuf Al-Shafi. Dr. Yusuf Al-Shafi. Yeah. There you go. Absolutely, my friend. Here you go. All right. Yeah. It's heavy as Oscar. Okay. Yeah, there you go. All right. Come this way. Yeah. Dr. Ucher Scott Jung. Dr. Jung. Dr. Jong Ju Kim. Dr. Kim. Okay. Dr. Su Sheng Quach. Come on down. Dr. Danny Domingo. Danny. Dr. Maros Kopeka. Dr. Kanika Burukanshan. Burukanshan. Dr. Michael Mazurek. Come on, my friend. Dr. Rudy Garana. Come on, my friend. Absolutely. Dr. Sungjin Kim. It's heavy, it's heavy. You know, you come here. We'll take pictures together. You come here, you come here, you come here. You deserve to be here, okay? Together. So for your children in the future. All right. Thank you, thank you. Dr. Ahmad Alanezi. Come down, my friend. Thank you. Okay. Dr. Onar Puty, the singing complicated dentist. The singing complicated dentist. I'll never forget you, okay? I'll never forget you. Here you go. Okay, hold the trophy? Yeah, thank you, thank you. All right. Okay. Do we have enough space together? Did everybody take picture together? I think that's one thing we forgot to do last year. So everybody, I know it's a little bit tight. Let's layer up. Okay. We only get one chance to do this. So let's everybody gather. Let's take a group picture together. Okay. Come on down. Okay. We'll fit in there. But yeah. Okay. Let's do yeah. David, do you want two? Okay, let's try two. Okay, yeah. Okay, and then one layer up here and one down here. Okay, yeah. Okay, yeah. Yeah, some of us can come up. Okay, yeah. Judges too. Yeah, Jordy. Yeah. We're gonna have to fit in there too. We gotta fit in there too somehow. Yeah, we gotta fit in there. Yeah. I don't know. Like maybe we can do like something like this. Okay.
No, we bring six. We bring the chairs and we sit.
Maybe we sit here like my grandma and grandpa used to do. We sit down over here. We can do that. Like a park will do that, okay? Yeah, that's right. Let's mingle with them. Okay. Right over here. Big smile. Okay. The winners. The Cinderella. Okay. Yeah. Yeah, that's with the Christian. So the winners, winners stay behind because we have to give you some instructions what to do for tomorrow. We're gonna prep you up. Yeah. That's it. That's Dino. Yeah, Christian and Dr. Sayu, you can take picture of. Yeah, take picture right now. David. Yeah. Okay. He was going to the airport and came back. Photo. Okay, let me take a